or say Thane Task Force, local task force, and we have seen that practically every branch is involved in this. So we start with virology, basic knowledge about the virus. Then we have got diagnostic facilities. We have involved radiology. Since this wave is disturbing pediatric and expected move or expected wave will be up for pediatric, we have involved pediatrician. We want to know what are the probable COVID precautions to be taken in pregnancy. So ANC persons, they are there. All the leading top task force members, they are going to talk about the management of COVID-19. And to know what is the epidemiology, we have got epidemiologists. We have got for panel discussion, state level and national rank leaders of IMA on one hand. And on the other hand, ex-ICMR head, Dr. Raman Gangakhedkar, or say the chief advisor of Maharashtra State COVID Department, Dr. Subhash Salunkhe, or the past and present or incoming presidents of IMA. So all these eminent guests are there. So you have got a sort of full brush up for COVID-19. And lastly but not least, one doctor is going to talk about the newer treatment, because there is no treatment as of now apart from vaccination. Vaccination also will be discussed, newer vaccination will be discussed, and newer medicine will be discussed. With this brief introduction, I would like to start. In between Health Minister Shri Rajesh Tope and Urban Development Minister Shri Eknath Shinde are also going to join and bless this program. So accordingly, little bit changes will be there, but be tuned for everything. Dr. Zarir Udwadia, who is the National Task Force members, he has got a National Task Force meeting at early 11:30-12. So he will be coming early and finishing his lecture. Same is true for Dr. Shashank Joshi. He has got a State Task Force meeting at 11. So he will be also coming. So Dr. Pakya Madam, the first lecture will start immediately after my speech, inaugural speech. And everybody has to stick to the time. So if the time is over, I will say that the time is over, and within 1 minute, that person has to wind up. So this instruction is very strict because we have to follow the time sequence. As a token of inauguration, webinar has taught us some new things. I am doing this by Deepa Prajwalan. I am lighting the candle on the screen. If you have got candles brought with you, you also can lit the candle, and then we'll say that the session is inaugurated. So I start that process. So this is it. Can you see? Hello.
I put a Samai also, sir.
You can see the candle?
No, sir.
Huh?
No, sir.
Yeah. So it is this. So the conclave is open for discussion, and we start the proceedings. I invite Dr. Vanita Korde to handle the next.
Good morning to one and all present. Yeah, sorry.
Please.
All are requested to mute their.
Good morning to one and all present. I, Dr. Vanita Kode, am privileged to introduce the chairpersons and the speaker of today's first session, ABC of SARS-CoV-2 Mutations and Genome Sequencing, RT-PCR. I call upon the chairpersons, Dr. Rupa Vishwanathan, who is a microbiologist practicing in Mulund. Dr. Rupa Vishwanathan. Dr. Milind Ubre, attached to RGMC Karwa as a microbiologist. And Dr. Mukesh Udani, pathologist having blood bank in Thane. I now invite our speaker, Dr. Pragya Yadav, scientist and head of Maximum Containment BSL-4 Lab, COVID Lab at NIV Pune. It was her team that first isolated SARS-CoV-2 in India. She is currently involved in conducting multiple studies on newly emerged variants. She has previously done extensive research on Crimean Congo hemorrhagic fever virus and Nipah virus. Over to you, Dr. Pragya, madam.
Good morning, and thanks for introduction. So as we all are seeing the second wave of SARS virus now, and we are going through a lot of crises because you all medical fraternity, so I know that you know better than me. And I give my due respect and thank you to this organizing committee, Dr. Dinkar, Dr. Gangakhedkar sir, and rest of the expert panels. Prior I start, I just, this is a picture of a BSL-4 facility which is established in ICMR and NIV Pune, within NIV Pune. And this is the first Asia's functional maximum containment facility where we can work on high risk group of pathogen. We can do all kind of studies related to animals and human in this facility. If we talk about the Coronavirus family, we know that it is divided into alpha, beta, and many more. And there are some very prominent diseases which we all know that. And you all know that the SARS coronavirus first came few years back, and then MERS came, which caused a lot of damage to humankind. And now the SARS CoV-2 is there, which is affecting and causing the pandemic. But with this, there are many other members in this particular family, which called alpha, beta, gamma, and delta coronaviruses. And they also have mainly involved the bad coronaviruses, which is known worldwide. If you look at the structure of this virus, it contains structural and non-structural proteins. And a few of them you heard every day, and mainly that is a spike protein, which everybody is talking nowadays. But there are certain more structural protein which play very important role. That is nucleocapsid, membrane, envelopes, and the genome is around 29,000 base pair, where you can see the spike structure on this virus genome. If you look at the structure, you can see ORF1A, RDRP, RNA polymerase is called, and then spike gene, which is again bifurcated in S1 and S2. The S1 is mainly function to regulate the virus host, and S2 mediate the membrane fusion and viral entry. M protein involved in the viral integration, and E protein is facilitate assembly, envelope formations, and budding. This is a cartoon of a virus where you can see the virus run through 5 to 3 UTRs and combined of different proteins, which is coded here, and where a nucleocapsid protein also play very critical role in encapsulation of genome and packaging of the virion. Then there are many non-structural proteins which help in binding, even regulating the virion formation, proofreading of viral genomes, replications, and contribute to structure of transmembrane scaffold proteins. So they are called NS1 to NS1, NSP16. So different kind of these proteins play different role in the virus function. When the virus was first time released from China last year in January first week, then there was a lot of confusion about the classification of the virus, and after a while, then GSET came up with a classification which was based on mainly on the amino acid classification. Initially, whatever virus actually moved, that was all from the Wuhan, China, and it was given SLV. Initially, it was called based on the GSET genome, and where you can see now there is a LSVG, GH, GR, GV, and GRY. These kind of classifications you must have heard from the GSET, and this is all based on the. If you look at the amino acid position, based on these positions, it was divided. The main mutation which you had last year was D614G, which was amino acid change in the genome of the virus, and from LSV suddenly it predominant converted to G, and then further it mutated and it called as GH, GR, and GV, where you can see the respective mutation and these. And now we have circulation of GRY, where we have more mutation. Further, this virus started more mutations, and rather going for these amino acid, then we went to specific mutation of ORF1A and spike protein, and based on this, we are seeing different mutations. Before I go and talk more about that virus, I just like to mention some of the very important contribution of NIV, which we did last year. We developed the diagnostic immediately that was based on different genes of the virus. Real-time PCR4 gene-based test was developed. It was distributed to different VRDL laboratory, which is working under DHR, and then these reagents were distributed to laboratories. Around 50 lakhs reagent has been distributed to different part of the country. Then NIV participated in validation of real-time PCR kit, ELISA, antigen kits, so that timely supply and kits can be made available to our population. Further, we developed for research and R&D different assays that included COVID Kavach ELISA, immune fluorescence assay, plaque reduction assay, and microneutralization assay. Then we also developed the animal models, which includes monkeys, hamster, and other models for studying vaccine and other products. We developed antiviral tests in very quickly. We worked on monoclonals and polyclonal antibody. And more importantly, we also developed the indigenous vaccine with Bharat Biotech, which is now a rollout in our country. With this, we also raised a huge amount of antigen, which was used for preparing equine sera, which is under going project, and we are looking if this can be used for the treatment. Then we also study with many pharma companies for their preclinical study for vaccine that include BBIL, eBiologicals, and Serum Institute, as well as Zydus, which is going in for phase 3 vaccine now. The testing efforts was very important for the country, and we could train a huge number of laboratory, which you can see in this map. And stepwise, we could cumulatively test 10 crore last year, and then 20 crores with the timeline, and more than 2,000 laboratory has been functionalized, and 7,000 RT-PCR testing laboratories is running. We also work on the true date PCR validation, which is being used in our country in remote area and district area. With this, the 12 high throughput machine also running in the country. All the efforts together could validate a huge number of kit of ELISA, PCR, and RT-PCR, and that all together could reduce the price of testing, which was initially a huge number in thousands, and now we have reached in a very low price for routine testing of COVID. I just take you back last year, January, when we detected first 3 cases from Kerala. Same time, we also sequences the virus within a day, and we found that this virus is 99.98% similar to the Wuhan strain, which was found. And we also try to do virus isolation immediately, because virus only can give you any product in the field of research to progress. Initially, this effort get failed, but in March, when we have Italian tourists visited in Rajasthan and Delhi, we could isolate the virus within a week, and then that actually helped to progress in different fields. And how this virus isolation helped, just want to remind you, the sequencing is part of each and every activity, which I'm going to talk to you, and why it is so important today. So not only this virus help in making the vaccine, but also ELISA and all these antivirals, raging monoclonals, and many research and development. Moreover, when in January, when we had got fear of the variant of concern, coming from South Africa, UK, and Brazil, we could also isolate these variants, and we can do impact how they are affecting our vaccination. So we are studying that also using this virus strain. The first virus sequence which we got from Kerala, you can see then that time there was not much confusion. So there was this G clade, V clade, and you can see in the right this clade. And initially it was coming from S clade and L clade. Slowly it shifted to G clade. Our team also went to Iran, and they helped in collecting the specimens, sending an IV. Overnight we tested and provided the report, and based on those, these citizens moved back to India, and we also not only sequenced, but we also isolated the virus from these samples, and we could present the first few genomes from the Iran, which was also belonging to these class. We developed this ELISA, which was helping first zero prevalence study in our country, and which could give an idea in April to June what is happening in our country and how much percent population was positive. This technology was handed over to 7 more companies, and they could produce bulk, and it was used in the country. Further, we plan a study where we could monitor the real-time presence of virus in our country, and that was from January to August, where we bifortly we collected specimen from each state and union territory from existing VRDL laboratories, and we could analyze around 689 complete genomes, and we found that till August in our country we have dominantly GH and GR clade, and these sequences also reveal the presence of single independent E484Q and N440K from Maharashtra and in the southern state in May and March month. We also could, by this study, we could prove that till August there was no variant of concern or variant under investigation, and which we found after the December. This suggests that the virus is mutating.
5 more minutes, madam.
Sorry, sir?
5 more minutes.
Okay. So these are the distribution which we could show from this virus. And further, if you look at the distribution of this virus in our country, state-wise, we presented how these mutations are happening in our country and what was the status. We also monitor the spike protein changes month-wise, and we could show that there was no VOC present. At the same time, we could also present the bad coronavirus in our country in different states, and they were not engaged in COVID-19 spread. So that was also a great finding. And then the INSACOG has been activated in February month, where 10 main institutions are involved, and they are doing 5% genome sequencing monthly and giving real-time data in the country now. Then further, we know that vaccine take a long time to develop, 15 years, but quickly with the help of our expertise and BBIL team, we could develop this vaccine and went to third phase trial, and then vaccine could roll out in January. That was only 9 months, and we could prove is not only is efficacy but also effectiveness in hamster and also monkey, and which lead to a very good scientific publications. Now we know that there are 2 vaccines which is present in our country, Covaxin and Covishield. And if we look at this, which we call BOC variant of concern, there are 3 main BOC present worldwide. The B117, that is a UK, which introduced from in January, and then B1351, which is South Africa, and P1 is a Brazil. And all 3 variants has been reported in our country. There are 3 main mutations which you can see in this E484K and 50Y and D614G. With this, there are many variants of interest, and recently in our country, B1617.1.2 and .3 BY has been emerged, and we also detected B1525 in our country in community transmission. There are certain variant of high consequences, but so far we have not seen any worldwide. I would like to throw a little quick light on these BOCs, how they impacted our vaccine program. We have isolated first UK variant, and then we could see with the Covaxin that Covaxin is effective and it is giving equal neutralization as we seen with the same strain from where the vaccine is being made. Further, we went ahead and we look at the pathogenicity and also transmissibility. We found that UK variant is highly transmissible in hemisphere, and which is also seen in the real time in UK and other country. That data came up. We also isolated South Africa virus, and now we are studying its effectiveness on co-vaccine and also how it is impacting the hamster model. You all know that this particular variant has affected many ongoing vaccine trials and shown a very poor efficacy. Further, we also isolated a Brazil variant, which showed that this is working with co-vaccine, and also this showed a high pathogenicity in hamster model and high viremia, which call for studying more on this particular virus. BY.1.525 we have isolated, and we are working to see how this will react to the vaccine program. Then in December we started seeing surge in. Slowly we see the surge in Feb in Maharashtra, and we could see some new mutations which was noted in the genome of this virus, and it was called B1617 because of these mutation which is written here, and we could see that more than 50% cases has these mutation, which further divided and called 0.1, 0.2, 0.3. We isolated this virus quickly, and we could study that co-vaccine is, though showing a little reduction is neutralizing capacity, but still it is functional against this variant. Further, we also did a study in hamster to see if it is pathogenic or not, and we found the lungs are severely infected and damaged with this particular variant in compared to earlier isolates. We went ahead and also studied the Covishield vaccine sera, and we found that there is a drop down in neutralizing capacity of Covishield, but still because of their immune capacity, it should protect the person if they have vaccinated with these variants. With this, I would like to thank the organizer of this program and our Professor Balram Bhargav sir for all the support doing a lot of studies during 1.5 years. We have published around 70 papers only on the COVID, continuously from the virus characterization to vaccine and then further variant monitoring. We are engaging continuously as per the time as it is demanding. We are also working on many monoclonals and polyclonal studies to see how these variants are going to impact the treatment. I would like to emphasize here that sequencing is being educated by every country, that it is very important work, but we have not only done sequencing, but we have meant this whole activity with research activity in the benefit of the country and on timely. I thank Dr. Raman Gangakhedkar sir for always acting like our mentors, promoting us during our research. And I thank Dr. Priya Abraham and my team who has worked from last year to till now without a single day late. We have been infected many times. People were quarantined, but still we did not close the lab or stop for a day. Thank you very much for giving this opportunity.
Thank you, Dr. Pragya Yadav, madam, for accepting our invitation and giving this exhaustive lecture. Thank you so much, ma'am.
On behalf of DigiShield and TPA, I'd like to extend thanks to Dr. Pragya. Please accept this e-memento.
Yes, Dr. Anupama, you can start.
Hello.
Dr. Anupama, you can start. Unmute yourself.
Ma'am, please unmute.
Unmute. Yeah.
Yeah, I've done. Good morning, all. Let's go over to the next session. I am going to compare the session of Dr. Zarir Udwadia. He is a well-known speaker and doctor, world-famous doctor.
Madam, 1 minute. Just wait, please.
Just hold on.
Dr. Santosh Khanna, please come on. You please come.
Sir, mine was third.
No, wait. You will. Piyush, Dr. Santosh Khanna.
Please unmute yourself.
Hello.
Dr. Santosh, please unmute yourself.
Yes, Dr. Santosh, carry on. Can you hear us?
Please carry on.
Please unmute yourself, sir. Dr. Santosh, please unmute.
Madam.
Dr. Santosh, we cannot hear you.
Yeah. बोलते रहो.
Yes, we heard nothing.
अरे अनम्यूट करा ना तुम्हाला आणि मोठ्यानं बोला.
Someone please calling. Please calling.
Dr. Santosh, please wear a pair of headphones if you have one.
Please start, you can.
He is not audible, sir.
Okay, let it be. I will do the part. Hello.
Okay, sir.
Can I continue?
Yeah.
Yes, we can hear you now. Continue, please.
Today I am introducing our next speaker, Dr. Joshi Chitgopkar Madam, along with our chairperson. Dr. Joshi Chitgopkar Madam, practicing in Solapur. She is the Vice President of IMA Maharashtra State, also Vice President of the Pathologist Association. She is eminent microbiologist and pathologist and in private lab practicing in Solapur. Our chairpersons are Dr. Rajesh Butala. He is the Secretary of the Pathologist Association practicing in Thane. Along with him, Dr. Ninat Shah, he is the Secretary of APPI. He is a leading pathologist practicing in Western Suburb in Mumbai. Along with them, Dr. Sonal Bendre Madam is there. She is an eminent microbiologist practicing in Thane. He has done a huge work in COVID RT-PCR area, and he has done very contributed in diagnosing in Thane, along with the rest of the Maharashtra. Dr. Joshi Chitgopkar Madam for our next session. Thank you. Madam.
Hello. Hello.
Yes,
Hello.
ma'am.
Hello. Will you please share my PPT?
Yes, ma'am. I'm doing that.
Good morning, everyone. This is Dr. Joshi Chitgopkar from Solapur. Am I audible?
Yeah.
At the outset, I am very much thankful to the Pathology Association and Dr. Dinkar Desai sir for giving me the chance. Today, I would like to speak on challenges in diagnostic testing, diagnostics of the COVID-19. As we all know, controlling the COVID-19 pandemic is entirely depending upon testing, tracing, and treatment. These three T's are very important. And we, as a pathologist and microbiologist, has entire responsibility of testing and tracing during this pandemic. And for early diagnosis as well as high quality diagnostic test. There is lot of research being done on this. Next slide, please. As we have just heard, next slide. This is all right. We just now heard from Dr. Pradnya very nice elaborative structural details of virus, and as we all know, this virus originated from Wuhan in China, has made a havoc all over the world, and it's just a virus from family Coronaviridae with genus beta coronavirus, and it is a positive sense single stranded RNA virus. And the important part of this is it encodes 16 non-structural proteins, 1 to 16 is genome with very important part of this genome is RP, that is RNA dependent RNA polymerase, and 4 structural proteins, that is spike protein, membrane protein, nucleocapsid and glycoproteins, and envelope protein, which is the area of concern for diagnostics especially. Next, please. Next, please. Hello. Next, please. Hello. Piyush, next slide, please. Piyush. Yes. The S protein is a class 1 fusion protein, is pivotal in endocytosis mediated viral entry and consists of 2 subunits. One is S1 and S2. S1 harbors actually receptor binding domain, which is very important, which directly binds to human ACE2 receptors, and they are they play very crucial role in all the this movie of coronavirus. Crucially, while the M protein is the most abundant, the S glycoprotein is the main inducer of the neutralizing antibodies and the most diverging proteins. That's where we have seen high mutation rate in these viruses. Just now we have heard about the mutations, possibly modifying glycosylation sites or consequently altering maybe ACE2 binding proteins, CTL epitopes, or accessibility to protease and neutralizing antibodies. Next, please. Next, please. The diagnosis of the SARS-CoV is based on 2 types of tests, that is direct identification and indirect identification. Direct identification will be based on antigen detection as well as genome detection, that is NAT testing. And indirectly, of course, specific antibody response. The direct diagnosis is the gold standard for an active infection, as everybody knows, and nucleic acid amplification tests, that is NAT tests, are very much playing pivotal role in this. While the detection of specific anti-SARS-CoV-2 antibodies, also known as serological tests, is the cornerstone for identification of previous contact with the virus. These are diagnostic as well as epidemiological importance they carry. We can detect either binding protein. Okay. Actually, there are 3 basic tests. One is for direct test. Amongst direct tests, nucleic acid analysis, which can be based on RT-PCR or certain high procedures like LAMB and other. I will enumerate them later. The antigen detection test, one is very simple point of care test, that is lateral flow test, rapid antigen test, RAT, which is very famously known as, and ELISA based test. And second is antibody test, which is, hello, sorry for the interruption. Secondary antibody test, which are lateral flow again, which can be point of care test and ELISA test. So these are the viral tests which can be utilized. Next, please. Next, please. Next, please. These are the viral tests. One is, as just now I enumerated, antigen tests, which can be, these all tests can be performed after nasopharyngeal as well as oropharyngeal swab collection, which gives good yield. The maximum yield is when we collect nasopharyngeal as well as oropharyngeal swabs. But RT-PCR can be performed on lower respiratory specimens also. These are very specific tests as well as sensitive. But as compared to antigen test, RT-PCR test is highly sensitive as well as specific test. And we have to go for it at least after 2 days. They recommend, WHO recommends, but in India we have seen that 4 to 5 days are required to get these tests positive. Next please. This is the difference between these two tests. Indented use for direct detection, both of them are indented intended for use. Then we know that RNA is detected in RT-PCR or nucleic acid amplification test, and viral antigen, nucleoprotein antigen in antigens. Then most are authorized. These antigen test is authorized for point of care. Both can be done on nasal as well as nasopharyngeal and oropharyngeal specimens. Sensitivity as compared to nucleic acid testing, antigen testing is very good. Antigen testing is low sensitivity, cost is also low, and specificity for both is quite high. Next please. Next please. Next please. So to get tested for current infection or acute infections, symptoms are very much important, and close contact with the person is very much important. The people who have been asked to be referred, that is for those who are going for travel or certain basic requirements for the work, they can also get tested with this. But CDC recommends that anyone with any signs or symptoms of COVID-19 get tested, regardless of vaccination status or prior infection. So this is the key of contact testing and tracing. So these are the 4 sites amongst which next please. Next please. Next please. Amongst which nasopharyngeal and oropharyngeal is most convenient and giving good yield. Next please. So antigen based test, this is these are such type of devices which are available, which is a sandwich enzyme linked amino assay, and where nucleoprotein is pre-coated on this microplate, and with the help of the antibodies are detected with the help of this. The test is around 70 to 86% sensitive, while specificity has been 95 to 97%. And whenever this test is negative in a symptomatic patient or high risk contact, we have to go for RT-PCR. Next, please. So NAT can be used, or NAT can be used in different ways. That is, 2 basic types are there. Thermal and isothermal. Amongst thermal, which is very popularly known as RT-PCR and very widely used. And among isothermal tests, there are few technologies, that is NEAR, transcription mediated, LAMP loop mediated, then helicase dependent. Nowadays, we are very much hearing about CRISPR technology and stand displacement amplification. Next, but now only PCR is widely used. RT-PCR, real-time RT-PCR is widely used. Next, please. Next, please. Next, yes. So this is the simple method how PCR is carried out. Just collect the sample, add it to viral transport medium, then transfer it to laboratory, extract genome from it, then amplification is carried out, where denaturation and primer, by adding primer and then polymerase chain reaction, the genome is amplified and then identified with the help of fluorescent probes. Next, please. So RT-PCR, real-time, in several real-time RT-PCRs, the primers were designated against envelope that and RNA-dependent RNA polymerase, that is RD-RP region. The E region being first line screening and RDRP being the confirmatory. And other researchers also used or developed one-step RT-PCR assay for testing, and some other researchers also used N gene as well as ORF region for the diagnosis. In fact, though this is very highly sensitive as well as highly specific test, there are certain in certain cases we get false negative results, but they may not only derive from poor sensitivity. This is great discussion everywhere that why RT-PCR? My RT-PCR is negative and there is HRCT positive. I am HRCT positive. I am showing symptoms and still there is RT-PCR negative. So it can be because of low amount of sample, maybe because of inadequate conservation or presence of amplification inhibitors in it, or mutations. Nowadays we are seeing there are many mutations are evolving. So mutated genome may be there actually. So mutations in the target region of the specific primer may be used. So these can be some reasons where we can say that this test or low amount, very small amount of genome may be there. Next, please. Next, please. The real-time RT-PCR, in real-time RT-PCR, we have heard many a time this CT value. What is this CT value? These are the number of PCR cycles, also known as cycle threshold, which are required for the amplification of the genome at the threshold level. But we should remember that all current SARS-CoV-2 RT-PCR assays approved by EUA are labeled only for the qualitative detection of gene targets specific to the virus and are not approved for quantitative measurement of the amount of virus present in the sample. So, while the CT values can be reduced by increasing the amount of gene target in the sample, it can be influenced by many other factors as well. That is quality of the specimen collection technique, sample type, whether it is saliva or nasopharyngeal, gene target, and other exactly type of assay. So there are no current recommendations for the use of CT values in the patient management, and more research is needed for this type of viral load kinetics. So please remember that even if we may get some idea, but CT values are not much important. Nowadays sequencing, just now we heard from Dr. Pradnya that sequencing of the viral genome is being done very widely to identify the exact mutation. Next one. So if this is a flow chart, just to know if patient is symptomatic, go for antigen testing. If positive, patient is infected. If negative, go for RT-PCR or NAT testing. If positive, patient is infected. In case of asymptomatic and close contact, again same sequence we have to follow. And if RT-PCR is negative, there is no current infection we can say, but we can go for next testing after 8 to 10 days if patient turns again symptomatic. And if patient is asymptomatic and there is no exposure and still antigen is positive, we can label the patient as positive or infected. And if there is no antigen, there is antigen negative, no need of going for RT-PCR in case of asymptomatic patient. But whenever the patient feels symptomatic, he can anytime go for RT-PCR and test himself. It's very important in contact tracing as well as detection of the cases. Next one. The second part of this is the indirect diagnosis, that is antibody testing, which is important, and it is point of care test. We can use it as a point of care test where we are detecting IgG and IgM. Next please. We are detecting IgG and IgM. So point of care tests generally are lateral flow devices that detect IgG and IgM or total antibody. even on finger prick testing. And laboratory tests, these are ELISA or chemiluminescence test, or above that, that is CMI or fluorescent using fluorescent technology, we can go we can use ELFI. So yes, serum, plasma we can use, and there are many assays which are useful. We can detect binding proteins as well as neutralizing proteins by antibody testing. This is the graph. Next, please. Next, please. Next, please. This is a simple graph to know when to do what. So after 0 days, we know that the detection of the genome by RT-PCR starts after 5 days, and gradually it declines after 14 days to 28 days. In the same way, antigen follows the same path. Antigen follows. Then IgM detection starts after 7 days and gradually drops by 21 days. And antibody amongst this IgM is early protein which is detected earlier, and after 14 days till we don't know how long it will detected, IgG is detected. Antibody mediated immunity for SARS-CoV-2 is for viral specific, it is IgM and IgG, and they are detectable after between 7 to 14 days after the onset of the symptoms. Next, please. Next, please. So serological testing does not replace virological testing, and should be used to establish presence or absence of it cannot be used for acute testing. It is just we can have some, and it is not recommended currently to assay the immunity of COVID-19 following COVID-19 vaccination, or to assess the need for the vaccination. But still, we have had nowadays tests against antibody test against the nucleoprotein as well as spike proteins, of which spike proteins give some idea about the post-vaccination status of the patient. The history of vaccination and prior SARS-CoV infection must be considered whenever we are interpreting serological testing. Next, please. So there are certain do's and don'ts. Remember that everyone should continue to take steps to produce themselves to the others by using masks, staying away from 6 feet, and washing hands, as well as using PPE. It is always must, even if we develop antibodies. What are the do's? Antibody test results should not be used to determine if someone can return to the work or return to schools, or to certain other, or mix with the people. So it is the time which will decide, that is 14 days or 17 days, that will decide about this, and not antibody tests. So these are the antibody tests, rapid detection, which are simple to do and low cost, and they can be used as screening tests, while ELISA and CLIA required laboratories, required special instrument, and it can be used as second level testing or screening testing. Next, please. So just a rapid review of mucormycosis, which nowadays we are seeing very largely many cases of mucormycosis complication are being seen. So what is the mainstay of diagnosis is microscopy and culture of various clinical sample specimens are the cornerstones of the diagnosis. Serology, we can use ELISA, immunoblot, or immunodiffusion test. Then we have certain molecular tests which can be done to diagnose molecular this PCR or sequencing, as well as blotting, and can be used. So this is a picture of histopathology. Next, please. Next, please. Next, please. Next, please. Next, please. Yes, so this is the mucormycosis. You can see the picture of mucus. Next, please. Yes. So you can see the histopathological picture of mucormycosis. You can see the ribbon-like hyphae in the tissue, and these are the actual fungus. You can see the growth on plate, SDA plate. You can grow on them blood agar plate also. So just for diagnosis, sinus inspection and biopsy of the sinus or orbit along with the washings. Then direct microscopy or histopath or culture. Imaging will definitely help. There is antigen test, galactomannan and D-glucan. Then ELISA can be done, and molecular testing as just now I have mentioned. So thank you very much. Next, please. Next, please. Thank you very much for giving me the chance. Over to Dr. Dinkar Desai, sir. Thank you, sir. Thank you, everyone, for patient listening. Thank you. Thank you, Piyush. Thank you, Piyush, for sharing the slides. Thank you very much. Desai, sir. Piyush.
Yeah. Thank you, Dr. Jyoti, for an elaborate lecture on laboratory diagnosis of COVID. So there are a few questions from the people, and the first question comes as why nasopharyngeal swab is still performed when few journals are saying that oropharyngeal swabs are good enough.
No. Yield of oropharyngeal swab is quite less as compared to nasopharyngeal. So we prefer to go for both nasopharyngeal as well as oropharyngeal, which gives almost 80% possibility of yielding the viruses.
Yes, that is very true because oropharynx is so volatile in terms of virus localization. It becomes difficult.
Yes.
Yeah. One more question which comes to the mind is when so many kits are coming out with different primer probe combinations, what would be the ideal primer probe combination that you would like to suggest?
As of today, RPDP is the most used and most time-tested kit which we should use. But nowadays, because of mutations, we have to see the kit which will detect the mutations as well. So we can go for such type of the kits, because every day then something new is coming, and we have to test it, we have to validate it, and then start with it.
Yes,
I think
highlighting that.
NIV is quite helpful in giving us the guidelines about using the test.
Yes.
Can I just add one line with the Dr. Jyoti's comments?
Yes, Pradnya, please.
Yeah, so the spike gene is most vulnerable because most of the mutations are seen. But fortunately, that kits which ICMR has recommended for maximum laboratory, they are based on E gene, RDRP gene, and nucleocapsid gene. Recently, one V1617.2, when WHO has declared that it is a BOC, there was some doubt that some of the mutations which is happening may cause a reduction in RDRP enzyme activity. So immediately we have tested a pool of 100 samples and compared with the existing, and actually it is not affecting RDRP gene. So that way we are quite safe. But if you remember when the UK variant emerged in December and January, so there was a huge number of cases were missed if you are using the spike gene because of the mutation. So this is a kind of on-time research we have to keep doing with the mutations and variant arrival in our country.
Yes, thank you.
I think ICMR should consider having 2 genes always in a kit instead of going a single
Yes, it is already 4 gene based assay. Never tested 2 genes. So in case if there is a mutation, you should not miss second. But if you have the symptoms and still it is coming negative, that is alarm to immediately raise and inform us so we can actively investigate the case.
Thank you, Dr. Pratik. There is one more question from the audience which says, what are the operation theatre protocols for mucormycosis?
Hello?
Hello.
May I get the question again, please?
Yes. Dr. Jyoti, there is a question which says, what are the operation theatre protocols for mucormycosis?
Okay.
It's from Dr. Sunil.
Yes, actually, it is the same as we have previously done it for diagnosed patients. We are being using this type of protocol. Actually, these mucormycosis spores, they are not resistant. They are just as usual. What we have done previously, we can use hypochlorite as well as we can use glutaraldehydes, with which we can get rid of these spores.
A question from my side. There is a lot of confusion about what is the ideal sample to be sent for detection of mucormycosis.
Yes, actually, I would like to go for a certain swabbing, which is in post-COVID test and highly susceptible cases to test, because if we could detect them earlier, it will be very much helpful. I'm trying to do such tests, so collect them in early phase, especially in case of diabetic patients or in high risk patients. But we have seen that whenever we get the black crusted material from nasal swab, that helps in early diagnosis, and immediately we can see the hyphae and fungi in on just KOH mount, and that is sufficient along with culture.
Regarding antibody testing, few points. Can we elaborate whether which is better, nucleocapsid based assay or spike protein or S1S2 protein?
See, there are two types of things actually: nucleocapsid and spike protein. When generally the tests which are available in the market, they are against whole virus. So we are testing them against whole virus only, IgM as well as IgG, which won't be able to differentiate. We won't be able to differentiate between the whether it is infection or vaccine, because confusion started after vaccination. So if IgM is there, again same thing has happened. So nowadays we are getting kits which are using separately as nucleocapsid and separately as spike protein. So if we are going for nucleocapsid detection, so we can predict that this can be after infection, because the vaccines are against spike proteins, and spike proteins are raised. If antibodies against spike proteins are raised and there is no history of infection, we can say that vaccines are being worked. And but there is no such, it is again under study. We don't have any such data.
So is there any inter-assay comparison, because some give index, some give arbitrary units? So is there any comparison in level for
what is the mode of spread of mucormycosis?
We'll have to stop the question.
Sir,
Hello.
can I make a quick comment on this last question, sir?
Yeah, go ahead. First.
So if you are taking co-vaccine and there is a breakthrough case, then you cannot differentiate, because co-vaccine is a complete antigen and it will produce many antibodies against it. But if you are taking Covishield vaccine, then definitely you can use the complete antigen ELISA kit, which if it is a positive, it means that you are getting this positivity because of the natural infection. Because Covishield is a spike-based protein, so you will only get reactivity with spike-based ELISAs. Rest of the ELISA will not work with it. So you can differentiate by using these methodology. Thank you.
So thank you, everybody. Now I request Dr. Sanjay Pingulkar to take the proceedings ahead, because it was my lecture, but since Dr. Shashank Joshi has to go for a state level task force meeting, so we have rescheduled, and we request Dr. Sanjay Pingulkar to take next proceedings.
Good morning, all delegates.
It is a pleasure and honor to introduce Padmashree Dr. Shashank Joshi, sir. He is a consultant endocrinologist at Lilavati and Bhatia hospitals, as well as his Dr. Joshi Clinic in Mumbai. He is a member of Maharashtra State Task Force for COVID-19. He is a president of Indian Academy of Diabetes, former president of API, Endocrine Society of India, RSSDI, AACC India chapter, and honorary emeritus editor of JAPI. He was awarded International Clinician of the Year 2012 by American College of Endocrinology. He was conferred the 2014 prestigious award of Padmashree by Government of India. I welcome him to start his talk on how to manage home quarantine patients. It's over to you, sir.
Chairpersons?
Am I audible? Are my slides?
Okay.
Sir, just wait.
Chairpersons, Dr. Amol Gite, who is a gynecologist at Siddhivinayak Hospital, which is a COVID hospital and managed hundreds of cases till now. Dr. Alpa Modi, who is a general surgeon.
Just a minute, sir. Dr. Pingulkar, just a minute. Yeah. Dr. Jayaprakash Pednekar is on the screen, so I welcome Dr. Jayaprakash Pednekar as the chairperson for this session.
Okay.
And Mr. Piyush, can you... Shilpa, yeah. Dr. Shilpa Totla, you can add.
Dr. Shilpa Totla, she is a vice president of PPA from Aurangabad. She has 21 years of experience in pathology. Around 10,000 RATs she has conducted in industries around Aurangabad in this COVID epidemic. I welcome her also to chair this session. Over to you, sir.
Dr. Jayaprakash Pednekar is working in Kaushalya Medical Foundation, and he is actually a COVID warrior. The next is Dr. Amol Gite. He is running a Siddhivinayak Hospital, which is a leading hospital in Thane, and he too is also a COVID warrior because his hospital is almost full for this COVID activity pandemic, last one and this one also. So I welcome again on behalf of TPA Dr. Shashank Joshi sir for this important meeting. Thank you very much for coming, and please proceed, sir.
Thank you so much. I know that nowadays on the Zoom timings may not be appropriate, but unfortunately I have to leave one of the meeting. I thank Dr. Vedhas Nimkar for me to talk on home isolation and home care. And we know that COVID treatment at home is what 80% of people with COVID in India are doing and across the world are doing. We have already had some very good insights in diagnosis and investigation, but we need to monitor 7 things when you're at home. What works at home, what does not work at home. And the main thing in home isolation and the worry people have is what are the red flags? Not too early, not too late. When to transfer, when to triage. So the key word at home isolation is to recover well without having a red flag and without needing to triage or transfer. And maybe a simple take-home message. So we all know this very well that when COVID is trapped in our body, the SARS-CoV-2, we can have 2 pathways. One is the adequate immune response. If our human host responds with a timely, innate, adaptive response, we'll have a very nice type 1 interferon response, and we'll have an excellent clearance by the macrophage as an antiviral response, which is de novo, and which is basically our own Th1 cells and the B cells, and they will neutralize the virus itself, and we'll get a classical normal recovery. And that's what happens at home in 21 days, probably 14 to 21 days. And we know the virus is actively multiplying or replicating for the first 10 days if the patient is at home. Of course, if the patient is in a hospital, in a ventilator setting, the viral shedding can continue more than 21 days also. Unfortunately, a small percentage, maybe around 15 to 20%, may not have an adequate immune response. They either due to comorbidity, due to age, we don't know. We don't have a score which can predict with a reasonable certainty who will get that, or whether it's a high viral load, that they will get a blunted immune response where there will be a delayed limited type 1 interferon response, endothelial cell death, epithelial and endothelial leakage, overactive T cells, natural killer cells, and accumulated macrophage syndrome with a cytokine storm. That's what happens. So typically, as I told you, 80% of COVID is self-limiting, and that's what we manage at home. and we need to use a lot of clinical judgment and monitoring to handle people at home. Unfortunately, we need to identify at home who will deteriorate and get into that severe category of 15 to 20% which need hospitalization. And we know that 1 to 2% can be fatal. We want to keep our case fatality rate at 0.5%. We want to work towards a zero COVID death situation. We know that there are 3 stages clinically of COVID. First is the asymptomatic stage or the pre-symptomatic stage, where there is a lot of viral engagement of PAMs and no interferon response, a very good innate immune activation, and that's what lasts most of the time. And then, of course, we get the non-severe symptomatic phase, where you get generation of antibodies as well as T-cell response with a lot of DAMs. And rarely we may have the triple C syndrome or the severe respiratory inflammatory thrombotic episode of cytokine release, of coagulopathy and complement response. That's something which we know. Now, we are in the era of evidence-based medicine, and unfortunately, COVID has precious little evidence based on it. So therefore, whatever we talk, if we have to talk, there are 2 types of things. One is most of it is expert-based opinions, but we need to have the rating of recommendations, A, B, and C, A being strong, B being moderate, C being optional, and the rating of evidence 1, 2A, 2B, and 3. 1 being 1 or more randomized trials without major limitations, 2A being other randomized trials or subgroup analysis of randomized trials, 2B being non-randomized trials, observational cohort studies, and 3 being expert opinion. Unfortunately, most of the levels of evidence in COVID are either in C category or 3 category. And that's something which needs to move into an A category or 1 category. So clearly, when we look at, how to handle COVID, let us look at what we need to do. So I'm not talking on testing, but we know that, you already talked a lot on testing, and you know that there have been new ICMR recommendations on the testing. So I'm not getting into the level of recommendations of testing like A3, B2, B2, B3, A3, A3. And these are all based on the NIH panel. There's a very nice 380-page document, which is an evidence-based panel document. But biochemical markers can be the key in home care if they are done on day 3 onwards. And there are 2 tests which I would like to illustrate, which can be simple and cheap and economical. That is CBC and CRP. To do appropriate complete blood count of CRP, it can I have the there's a lot of background noise. The CBC throws out 2 things which can prognosticate. One is RDW, red cell width. There's a very good JAMA paper to show that if your red cell width is more than 14.5, you're likely to progress. And of course, if your neutrophil to lymphocyte ratio is high, you're likely to progress. So just on a simple CBC, you can get a reasonable certainty that there could be some prognostic indicators. Beyond that, in CBC, WBC count, neutrophil count, platelet count, lymphocyte count, NK cell count can all be measured. And they are all investigational. And whatever is in the green probably has better data. Whatever you can see in the yellow has or the light brown has the less data. Second is CRP. Rising CRP definitely helps. Doing other tests like LDH, D-dimer, ferritin, PCT, IL-6 may or may not help. D-dimer has its own limitations. As pathologists, many of you all know the limitations of D-dimer sometimes being done in home care. But if there are 2 tests at home care which may be useful between day 3, day 5, day 7, and that is a clinical decision which either through teleconsultation or through physical examination somebody has to take. It is basically these 2 tests, and they can give you a reasonable yield. A rising titer of CRP clearly is suggestive, and obviously CBC. The D-dimer may help you to make a decision on anticoagulation. So that's something which may be there. So the most important thing is when somebody is diagnosed with COVID is to follow an ATM approach. Assess the patient, triage or transfer the patient, and manage the patient in an emergency way. So when you're assessing the patient, we need to look at 7 things, as I said. First is look at temperature. And if the temperature is more than 100 degree Fahrenheit, definitely paracetamol has a role. And many people, if they persist fever beyond 5 days, then it's a red flag. So clearly remember that if your temperature is persistent and there's persistent fever, which can occur also after COVID, after 3 weeks. But if there is persistent fever beyond 5 days, it's a red flag. But otherwise, you can manage by round-the-clock paracetamol. That's all you need. Sometimes you may need an NSAID. And there are NSAIDs of choice like mefenamic acid, naproxen, so on and so forth. And in the initial days of COVID care, people thought they could be harmful. Now we know that they may not be necessarily harmful. But temperature above 100 and paracetamol is there. If the pulse rate is if there is a sinus inappropriate tachycardia or if there is tachycardia, clearly it's an alert. And you know that when there is fever, and the reason we need to give Rindoclac paracetamol sometimes is because if we don't give that and somebody has underlying cardiometabolic risk, and if you get tachycardia, it will trigger cardiac events. And these are the people who need to be shifted to hospital care. If the respiratory rate is about 24, again, it's an alert. So obviously you get a simple TPR, temperature, pulse, and respiratory rate from home itself. And if you can teach a patient how to measure pulse, temperature, and respiratory rate, you can easily red flag them out. But obviously that's something which we can do. If somebody is a hypertensive, check the blood pressure. If the blood pressure is persistently above 140/90, start a blood pressure medication, but there could be an alert. You may move the patient at home because 50% of mortality which is seen in COVID is in hypertensives. The most important tool in COVID care at home is the saturation. And the pulse oximeter provides you a very, very nice and appropriate guide. And if you do a baseline saturation, and if it is less than 93%, you need to get the patient into a corona care facility or a oxygen facility. And if there is a 6-minute walk and there is a 3% drop on that saturation, again, you need to red flag the patient and move him to the hospital. If the glucose is a vital sign, we all know it, people who don't even have diabetes, but if their glucose is above 180, between 140 and 180, then you need to have an alert. Try to preferably put them in a hospital and get them on insulin. And as I said, a lot of COVID care at home is happening through telemedicine, e-Sanjeevani, digital connectivity. And that's why the vital 7, and in fact, digital connectivity twice a day is vital. If you feel that your patient is not able to connect to a medical care person, twice a day for 14 to 21 days, it is better to put him into a CCC facility. It may not be a DCC facility, which is like a district care, a tertiary care referral center, but then put him into institutional quarantine, because we don't recommend home isolation, because you know that there could be a break in continuity between day 7 and day 14. It could prove fatal. So remember, these 7 things are the crucial key things when we are doing it. So who is at high risk for deterioration? Now look at symptoms: fever, fatigue, dry cough, and breathlessness. If there's dry cough which is persistent more than 7 days, probably you can give them an inhaled budesonide, but otherwise don't start them on steroids at all. If they are breathless, they are persistently fatigued, they have fever which is persistent more than 5 days, it's a red flag, move them to a hospital situation. If the patient is sick or toxic, move them to the hospital. Now, there are some people who may experience loss of taste and smell. If they experience loss of taste and smell, it is as good as RT-PCR. Usually these people recover. That's usually a rule, but that should not mean that a person gets complacent. If there are aches and pains, if there is a runny nose, sore throat, or nasal congestion, and occasionally you can get just diarrhea. Obviously, travel history doesn't matter now because we are all having community transmission. And obviously, if you're a healthcare worker, your approach has to be a little more aggressive, because the likelihood of a higher viral load or a variant of concern is higher. The biggest challenge which we need to triage in COVID care is happy hypoxia, because that's where we lose patients, and it's important to diagnose that occult hypoxia. And also rarely remember, COVID patients can present to a casualty or emergency room with stroke, with acute coronary syndrome, with seizures, or even diabetic ketoacidosis. Today we are in COVID era, so every patient is presumed to be COVID unless proven otherwise. And therefore, the easiest way to triage patients in home isolation or in a casualty is to do the NEWS score, which is National Early Warning Score. It's a British score, and you look at the respiratory rate, you look at the saturation, you look at air and oxygen, look at systolic blood pressure, pulse, conscious level, and temperature. And this is available on an app. Just look for the NEWS app, and you can easily, triage a patient if they need a emergency response or not, and red flag it very clearly. As I told you, the single most important tool to be used in home care is the 6-minute walk test of oxygen saturation. So when you have to triage, you need to understand who is red, who is yellow, and who is green. And obviously, this is the key issue which you know, that is the patient safe and on room temperature saturation is okay, or is he unstable? If the COVID suspect, does it need ICU care or non-ICU care? Is it safe and can be managed in wards alone, or can it be managed in casualty alone for some other purposes? So that's very, very important. So obviously what is key is saturation and the red flags. So saturation below 94% on room air, you might need to give some oxygen. Above 94% on room air, no oxygen is required. But if the NEWS score is more than 5, if any NEWS parameter is more than 3, if there's sudden onset of breathlessness, or there's a positive 6-minute walk test, clearly that's a red flag. And you need to move the patient. And obviously that's the time we need to look at other things. Of course, we have a lot of tools like we can do a PCR that time, we can do an antigen testing that time, we can do a focus that time, we can do a gene expert that time, we can do an HRCT that time. Remember, all these have to be sparingly used and usually to be used in an emergency room situation. And also, don't rush for an HRCT. Unless and until the RT-PCR is negative, it's a suspect COVID, you are on day 5 to day 10, under clinical suspicion, you do that. So obviously, you need to look at who needs what treatment and you need to triage them in the hospital, whether they are mild, moderate, or severe, and that's not my scope of my talk. So managing them at home, outpatient, okay, that's the key. The key in outpatient management is supportive care. Adequate hydration is the key. Isolating the patient is the key, and ensuring that everybody at home who's managing with the patient, if there is no separate bathroom and toilet, and it's better to put the patient in institutional quarantine, and also ensure that all other family members mask themselves. Also remember, in non-COVID space, home masking is recommended for people who get a maid at home or any human being which comes at home outside the bubble who's at home. Second is, if there is symptoms of COVID, they need to be triaged either by telehealth visits or by in-person care. And if there is dyspnea or there is a sudden onset dyspnea or there is a worsening of respiratory status, then you need to move the patient out. So it is important to manage the patient's vital signs, physical examination, risk factors for progression to severe illness, and availability of healthcare resources. All these have the rating of evidence base, A and 3, A and 3, A and 3. So remember that the rating of evidence has been put down here. So COVID timetable is 14 to 21 days. And therefore, the biggest challenge is most people are asymptomatic in the first week. In the second week, they suddenly deteriorate at home. Then they scamper for a bed and suddenly they die, either because of a sudden pulmonary embolism or a myocardial infarction or a coronary event, or sometimes because of hypoxia. So, and also remember, post-COVID, the timetable is the 3 months or 100 days. So right approach, right time, and right medicines are important. If somebody is asymptomatic, essentially it's all symptomatic treatment. There is no role for either antimicrobial therapy or antiparasitic agents or any other form of therapy, or including antiviral agents. So a very quick word on the antimicrobials which are arbitrarily used. There is a level A evidence to show that azithromycin doesn't work. Doxycycline has no data on it. Ivermectin has precious little data on it in an evidence-based way. Then when it comes down to favipiravir, again, it's a very weak antiviral. If not used in the first 3 days, it doesn't have any impact on the generation on impact of COVID as far as life-saving potential is concerned. So pretty much nothing works. You know, it's arbitrarily given. I'm not so sure whether it will really work. And with that, a lot of adjuvants are given, like vitamin C, vitamin D, and zinc. They may be at best adjuvants, but beyond that, their role truly to save lives is probably zero. So remember that all patients who have dyspnea, who desaturate at sea level, who have probably a higher acuity of symptoms like chest pain, tightness, dizziness, confusion, change in mental status, immediately move them to hospitals. So if there is dyspnea, if there is desaturation, or if there is chest pain or tightness, dizziness or confusion, or mental status change, these are the people who need to be moved out. And obviously, they need to look at the appropriate evaluation. And that's something which we need to recognize very clearly. So is there any form of therapy which may work? And is it available in India? So clearly, what can work in the first 3 days are monoclonal antibodies. One US ex-president got that at home, and you know that can be given as an IV injection. That is the ones which are listed here. These are supposed to be the Lytic cocktail of monoclonal antibodies. One of them is now approved in India, will be available last week of May, and in the first 3 days may work. So that's something which we recognize better and which we can do better. But obviously, there is no use for chloroquine, hydroxychloroquine, azithromycin. There is no role for steroid at all. Please do not give steroid at home-based care at all. There is absolutely no role. There is no role for azithromycin, doxycycline. And you can use some of the therapies as investigational tools. So obviously, the factors for severe disease are well known. And it's only in the late stage. Remdesivir also cannot be given at home. Dexamethasone, oxygen, all of them come when you need to be hospitalized with maybe a little bit of low molecular heparin. So those are the only therapies which can be given in the hospital situation. So remember that when you get the patient to the hospital, okay, probably there may be a role for remdesivir. Again, that's question mark because it doesn't save lives. Steroids definitely help you to save lives. Low molecular heparins can be driven by this thing, and we need to look for complications. So obviously, when you are doing COVID care, you need to understand that it's a lot of mental health and resilience which you need to do. You need to monitor them carefully. You need to identify the red flags. If in doubt, transfer. You need to because the person is isolated, you need to ensure that they are taken care of appropriately, and home precautions for family members have to be there. They need to eat on time and eat appropriately. They need to sleep on time and sleep well and smile well. But it's important that they detox digitally, because there is an infodemic and there is a digital toxicity now. And many of these patients sitting at home, they panic, they become reactive, they take multiple polypharmacy, and in that panic and multiple polypharmacy, they don't even sleep appropriately. So sometimes people give them melatonin, and remember that's okay to give as an adjuvant. But remember that if you do not do that, then you land up making more mistakes. So I think primum non nocere, first of all, do no harm. Most people can recover at home very well, but you need to understand the red flags appropriately and treat them with that zest and vigor. But if there's any red flag, move them on time. So it's not an easy situation for doctors to be in, because the science in COVID is changing all the time. We are getting newer and newer options. Most of the things which we used in the last year's first wave are not applicable in the current wave, because we have better evidence based on that. And most of it is now virtually relegated to a relic. So obviously the COVID care is all about supportive care. COVID care is all about being alert 24/7, monitoring your vital sevens all the time, being digitally connected to your healthcare facilities. And most people will recover well at home in 14 to 21 days. And that's something which is very easily doable. And it needs a lot of resilience, patience, and you need to understand that we need to practice some rational medicine. I think that has happened, but don't get into a reactive mode and a panic mode. Thank you very much for patient hearing.
Thank you very much, sir, for very informative session.
Yes, Dr. Gite, please. Thank you to Dr. Shashank Joshi, sir, for the exhaustive, informative session and providing the insights about the Vital 7 and the new score. Thank you so much. I request Piyush to kindly present a virtual memento to Dr. Joshi, sir.
Sir, we have modified accordingly. It's webinar mode. On behalf of the Pathologist Association and DGShield, we appreciate Sir Padmashree Dr. Shashank Joshi. A wonderful session, wonderful speech. Thank you very much. Next is Dr. Meenal Gorsai. Can you join?
Yes, sir, I'm there.
Dr. Jyoti, you are there?
Yes, sir, I'm still there. Yes, sir.
Yeah. Dr. Piyush, can you give the memento to Dr. Jyoti? Give the memento to Dr. Jyoti.
1 second.
Yeah. Yeah, thank you. Now you, Dr. Meenal, you can proceed.
Next
Okay. The three chairpersons for our next section are COVID warriors from Thane. Dr. Kuldeep Dalal is a consultant physician and he works in Bethany Hospital, Thane. Dr. Vineet Ranveer is a chief intensivist at Sri Mahavir Jain Hospital, Thane. And Dr. Samir Deshpande is a consultant physician and owns Infinity Medisearch Center in Thane. And I am privileged to introduce our speaker, Dr. Salil Bendre. He's the head of Pulmonology Department at Nanavati Hospital, Mumbai, and in charge for COVID facility. Former HOD Pulmonology at KJ Somaiya Medical College, and he has been actively conducting numerous teaching programs on various aspects of COVID. Over to the chairpersons and speakers, sir. Sir, you may start.
Okay. So good morning, everyone. And thank you, Pathologist Association, for inviting me today for this wonderful enclave on COVID and the knowledge sharing which is happening today. And thank you, Dr. Vedhas, for inviting me for this program. It's been really heartening to hear all the previous speakers to know about the virology and the different mutations which have now crept into our management of COVID, or so-called the knowledge about COVID. Today, I'm going to just discuss with you rather for 15 minutes about home management of COVID. I have not made slides because, as everyone knows, there is no fixed data, no proven data to really talk about a very, very strong treatment plan for home treatment in COVID. And Dr. Shashank Joshi, the previous speaker, has put it very aptly that in COVID, when you are treating at home, it is actually monitoring, and monitoring, which is the hallmark of the management in the first 7 to 8 days, because that is the time of the viremia, the active viremia, which will later on progress to the inflammatory stage. So I will just put up certain clinical scenarios for all of us who are listening to me, all doctors who are listening to me. A patient comes to you with high fever, 101, 102, and his RT-PCR is done, which has come positive, say after 2 days of his symptoms, and he calls you up for an online consultation, or his relatives get to you his report. So I will just highlight few things which should not be done rather when we are treating these patients at home. First is, if you have a patient like this who has come with fever and he's come to you with a report which is COVID positive, and it's just 2 to 3 days since his symptoms have started, please do not advise him to undergo a CT scan. That is the first thing I think everyone should realize, and I think everyone knows now that in the first 4 to 5 days, doing a CT scan is not going to help this kind of a plan of treatment for home management also. CRP is expectedly going to be high. So when we think of home management, CRP, the increasing trend, is something which matters and which should be taken into consideration. So when you are advising a CBC, every aspect of that CBC matters. If its hemoglobin is less, then it matters because the oxygen carrying capacity is going to be less. If there is leukopenia or leukocytosis, we need to also rule out any secondary infection along with COVID, because we know that usually viral pneumonias present with a lower WBC count. And you should be also looking at what is called as the neutrophil lymphocyte ratio, the NL ratio. That is a good and a sensitive predictor about whether this patient is going to progress further into a disastrous outcome. So for those people about home management, myths and facts, I will just like to say that one, do not advise a CT scan right in the first day. Yes, you can always look at the CBC and monitor the NL ratio. Very important as far as the treatment is concerned, we all have seen prescriptions of antibiotics going on. It could be azithromycin, it could be amoxiclav, it is doxycycline. So let us please understand that these do not have any substantial antiviral role so to play in the treatment of COVID at home. So there are good number of in vitro actions of even doxycycline. I'm specifically talking on that because we see varied prescriptions where there's a combination of doxy with azithromycin, with vitamins, with also favipiravir. So in this small discussion, I would just like to highlight that one, that doxycycline has shown its effect in vitro. It has shown to have anti-inflammatory modulatory effects as well. It has shown to have binding on the specific viral mRNA as well and reducing the pro-inflammatory cytokines as well. But please understand, they are all in vitro outcomes, and it has not having a substantial data to say that start this patient on doxycycline and ivermectin and wait and relax. No, it is not so. So they are not the panacea of treatment. Neither is favipiravir a panacea of treatment. You need to be observant for these patients. So doxycycline per se is not an antiviral. It has got good effects, but they are in vitro. So don't rely that doxy should be the treatment which has to be started on every patient who comes to you with COVID. It doesn't change the outcome also of COVID management. So antibiotics, please try to refrain from them. Even so to say, when we talk of the anti-helminthic, which is very, very commonly used, which is ivermectin, which is actually a drug of choice with onchocerciasis or strongyloides or even scabies. It does have effect on inhibiting the viral transport protein. It does have effect showing a reduction in the viral factors, which actually lead to the intracellular transport protein, may interfere with the attachment as well. But remember again that there are no clinical trials which have actually validated these. So we have to please understand that ivermectin in variable doses, right from 24 milligram to 12 milligram to various milligrams, and for various durations. So here we are having definitive outcomes which has shown that they really don't change the mortality rate. They do not prevent a deteriorating patient from going into an ICU or a hospital. They are not potent anti-inflammatory as well. So the myths and facts is there is science behind the usage of these molecules. There are in vitro data which have shown to be effective. However, it has not percolated into the clinical outcome and the clinical studies which have really not shown any mortality benefits. So that is about the doxycycline antibiotics, unfortunately being abused, and of course for the ivermectin. Another important point which Dr. Shashank Joshi also made in his talk is about favipiravir. Since we are talking about oral medications, favipiravir obviously comes into our mind because that is one orally available antiviral drug. But favipiravir was used when there was an influenza epidemic. It was also used when there was an Ebola epidemic. In fact, it came into Japan first because of the influenza which had started there. And during the Ebola also it was used. So favipiravir has shown to be having some effect or some impact on the viral shedding, and it reduces about 2 to 3 days is the shorter, it shortens the viral shedding and decreases the time to recovery. So it has a minimal role, but again, what happens is that once the person is COVID positive and is put on favipiravir, even the patient gets some kind of a secure sense that he is on some treatment for COVID. Not only that, the treating physician perhaps may feel that now that the favipiravir is started, we are at least on the correct track for treatment. But in all this, please, we need to understand that the stage of viremia is not curtailed or not immediately affected by giving favipiravir during the course of action. So it has very limited role, and as discussions have happened earlier also with eminent doctors all over, if at all it has a role, then it is in the first 3 to 4 days that it should be started off, if at all you want to give. But once it is started, don't get a false feeling of security that you are on a perfect antiviral drug. So it is not going to be advocated that way, and it should not be advocated that way. Misuse of even that. There are cases where the patient has been diagnosed with COVID on day 1, and after day 10, the patient has been put on favipiravir because he got symptoms after because his symptoms increased after day 10. For all those people who are treating these COVID cases, if at all your patient continues to have symptoms after 7 to 8 days, he is not a candidate to be treated by favipiravir. He is not a candidate to increase doxycycline or ivermectin. And for that matter, at that point of time, the best option at that point, where after 7 days the patient is symptomatic, means he's in an inflammatory stage, please do a 6-minute walk test. Please check his what we call as the PaO2 Of course, this will be in a hospital setting, but such a patient should be ideally in the hospital. The another aspect which comes into home management is about use of anticoagulants. I'm trying to talk of this because these are the common medications which are used for home treatment. So doxy, ivermectin, antibiotic, and favipiravir. Science is there, but the outcome and the clinical robust data is not there to really show that it is a very, very effective drug and reducing mortality. As far as oral anticoagulants, now there is enough scientific evidence to show that COVID virus itself causes a lot of hypercoagulable state by microangiopathy. It affects endothelial lining, the endotheliitis, and it ruptures these walls, leading to platelet aggregation, neutrophil, and further fibrin and thrombus. So the fibrin levels and the D-dimer levels become very high. So if there is a 4 times jump in the D-dimer levels, that is a significant jump of D-dimer and should be taken with caution. But if you go to see, avoid doing a D-dimer every day. Today we do a D-dimer, tomorrow we do a D-dimer, third day we do a D-dimer. It is actually a point of contention that a rising trend of D-dimer with clinical symptoms should be the best way to deal with when we are talking of anticoagulants. And the recommendation is that if the patient warrants anticoagulants, then it should be in the hospital, not in a home setting. Because the best way is to give low molecular weight heparin. It works the best, the least interactions with antivirals, and we can monitor them in the hospital. Because these are patients who may actually emboli and they have sudden drop in saturation, and you cannot have a risk of starting them on oral anticoagulants at home and telling them that I need to see your D-dimer after 48 hours. Because if at all they are going into that stage of thrombosis, you will never get a chance to then admit them to a ICU or to a hospital. So we have to be very sure of that. There are a lot of interactions with novel oral anticoagulants, even with antivirals, even with steroids, and even with antifungals. These points are very important in practice, because there are patients who are started on empiric antifungals because he's on a steroid and he's also on a NOAC. But there is an interaction and contraindication amongst these drugs. There is drug-to-drug interaction. So I feel that NOACs, and as per recommendation, it's not like I feel, I think that word should go away, because everyone is now talking of my experience and my experience and my experience. But we have scientific data to back up and say that if at all anticoagulation, then please get him into the hospital. The best option is enoxaparin, LMWH, least interaction, good monitoring, and least drug-to-drug interactions. So if you are giving anticoagulation, yes, it's best to be done at home, done in the hospital. I have told to you about doxy, ivermectin, favi, and anticoagulants. Remaining are two things which I will just talk for 5 minutes, then wind up. One is about oral steroids. Now, as the previous speaker, Dr. Shashank Joshi, has also deliberated on that oral steroids are good and bad, both. They are good because they are best anti-inflammatory. So they should be given in the anti-inflammatory stage, which is suggested by hypoxia, worsening saturation, worsening breathlessness, tachycardia. So these are the red flag signs that this patient is going into inflammation. He needs steroids and he should be in the hospital. Now that stopgap where a person may feel that now I need to give him steroids because he's having breathlessness and saturation is 93, 94 may actually push him into a secondary infection if you start it in the first 2, 3 or 4 days. This is very important because there has been a random use of oral steroids right from day one, just because the patient is having fever, and steroids are found to be useful. Now, anecdotal improvement may happen. Some doctor has given steroids and patient improved. Doesn't mean that every patient should be put on steroids. They have got their risks of opportunist infection and worsening the viremia if it is given in the first 3 to 5 days of home treatment. So avoid steroids in home treatment unless the patient has these risk factors. And last not the least, talking about vitamins, yes, I think every one of us knows that we are writing vitamins and minerals and zinc and copper. Please, at the end of the day, remember that every molecule, every chemical which we ingest has got its own side effect. Higher dose of zinc, unnecessarily prolongation of zinc itself causes myopathy. It can cause copper deficiencies. So when we are giving zinc, the requirement is 11 milligram as a nutritional supplement. Up to 50 milligram is a good dose, but we don't have to punch them on with different formulations of zinc. Vitamin C, it is a good immunomodulator. It has shown to be reducing the cytokine response, but it has got a particular value. And again I tell, there is no such specific clinical trial which says that it is antiviral and it is the drug of choice for treating COVID infection. These are adjuvant therapies or co-therapies which are given with the understanding that it would be probably having some impact on reducing the oxidative stress and increasing the vascular integrity. So try to understand the science behind all these molecules. Your one prescription shouldn't have azithromycin plus doxy plus ivermectin plus favipiravir along with different formulations of vitamins just because we know that they are available, they are easily there at the chemist and we should be using them. There is no such requirement for that, and there is no such medico-legal background that unless if we don't advise this, then something may be wrong on my part or someone may accuse me as to why I have not used this. We have got enough data to tell us what is useful and what is not useful. So I think with that, I thank you all for a patient hearing. And if there are any discussions, talks, I am ready for that. Thank you, Vedhas, once more.
Yeah. Dr. Salil Bendre.
Yeah.
Dr. Salil Bendre,
Yes.
I want to ask you, can you elaborate on neutrophil lymphocyte count and what is the ratio that is showing you progress?
So the absolute neutrophil count and the absolute lymphocyte count. So there is a ratio which we call as the NL ratio. Okay. So if it is more than 3.5, that actually indicates that the person is in the stage of may worsen. So that ratio has to be monitored. When you do a CBC on day 1 and he is still spiking or he started having cough on day 4, then please do a CBC, check for the NL ratio. And if it is showing it was 1.6 earlier and now it is become 4 or 4.5, then you need to understand that this patient is in a process of worsening inflammatory response.
And my second question is, how long do you prescribe vitamins and the other paramedics that we give?
So, see, vitamins are supplements. Again, as I said, they never came up suddenly when COVID came into existence. We very well know that 11 milligram of zinc is required for a male and 8 milligram of zinc is required for a female as a supplement. So, when we talk of how long, it is of course with the understanding that we don't exceed these normal requirements. We don't need to continue with vitamin D 6 lakh unit every day for 15 days and 20 days just because we know that it is having some immunomodulator action. In fact, there are studies about vitamin C, injectable vitamin C, which has been used up to 6 grams. But the study, that the one which I am quoting, says that there is no real change in the mortality as well. So they have a role as supplements, but limited role. You may, of course, continue. You can always check your levels. There are labs which do a vitamin D3 level, B12 levels, and so on. And so know whether you are having that toxicity or you are across the therapeutic levels as well.
Thanks, Salil. Thank you. Excellent deliberation. Fantastic.
Dr. Salil Bendre, it was really exhaustive and you have elucidated everything so well. And about all the components of the so-called COVID cocktail, which is being used in all the patients. And you have also backed it up with references and the current evidence. Thank you so much. I request Piyush to kindly present a virtual memento to Dr. Salil Bendre. And then over to Dr. Anupama Verma to introduce the next speaker.
Vedhas?
Yes.
Dr. Pednekar here.
Yes,
I want to make a point regarding this Dr. Shashank Joshi's speech on home symptomatology of COVID at home. Regarding the cough, the cough is usually one, peculiar thing is it is non-productive. It is only a dry cough. No one gets a productive cough in COVID. And if one gets productive cough, it has to be some superadded infection. That is one thing.
Yes.
Second, if the cough suddenly becomes very disturbing and exhausting, then one has to take note of it. And then one has to, that patient may require further investigation. That is another. And another thing I want to mention is regarding teleconsultation. When we do teleconsultation, many times the history is given by, sometimes the history is given by relatives and the patient doesn't come on the phone. But we should insist that the patient come and we talk to the patient, because when we talk to the patient, we actually come to know the real condition of the patient. Because only by the speech of the patient, if he's finding difficult to talk, it's exhausting, then also you'll know that this patient cannot be kept at home. He has to be hospitalized. That is what I want to tell you.
Yeah, and
Dr. Pednekar, thank you.
One last point.
You make a very valid point. I completely agree with you. You must insist to talk to the patient. If the patient is breathless on the phone, looking at, he's appearing sick, you can pick it up in 2 minutes and you can just move them to hospital care. And sometimes it is better to err on the safer side because the casualty will, or the emergency room will triage the patient. So you're absolutely right. And you also write about the dry cough. Persistent dry cough beyond 5 days should sound a red alert, however. So, and sometimes you might need a small little inhaled budesonide. But again, that's not standard of care. There's just one study, but that you may look into that. And productive cough may need an antimicrobial prescription. But as I said, the data is in COVID is zero on azithromycin, doxycycline. With due respect to everything, of course, we have two good pulmonologists here, Zarir and Salil. Maybe Salil might make a comment and Zarir might also make a comment on the cough part.
No, I think that was a very important point, and I think I should stress on that inhaled budesonide through a meter dose inhaler and a spacer is one of the very good anti-inflammatory and antiviral effect which has been seen in these patients. So that is one thing which any patient with having a lung COVID where he has irritation and cough, we should be using budesonide 800 micrograms twice a day, and it's an inhaled steroid, so safe also. So that's just one thing I wanted to add.
Salil, and one more point. In 4 of my patients with fever, I asked the pathologist to see for a malarial parasite, and these 4 people gave Vivax positive, and I had to treat malaria first, and then they came down, and I saw the difference in treatment management. It alleviates the anxiety of the person, because once the fever goes after your anti-malarials, I suppose they are much more comfortable. It is easy to manage.
Over to you, Piyush. Piyush, please present a memento to Dr. Salil Bendre, sir.
Yes. Dr. Salil Bendre, on behalf of DigiShield and TPA, we offer you this e-memento.
Thank you so much. Thank you so much. Thank you.
Over to Dr. Anupama Verma to introduce the next speaker. Dr. Anupama Verma.
Hello, good morning all. Am I audible?
Yes.
Yeah, good morning all. It is a very sunny and some rainy Sunday today. And I am extremely delighted to share the virtual dais with so many dignitaries, so many great doctors on screen. I would like to go on a next session, which is to be lecture. Speaker is well-known Dr. Zarir Udwadia. And I am going to start with calling the chairpersons. Already we are having 2 chairpersons on screen already. And I will request to tell Dr. Vinith and Dr. Kamal Saroj to please join us as chairperson. I would like to invite Dr. Rahul Bapat, who is MD physician at practicing at Thane. Dr. Kamal Saroj is MD physician who is practicing at Thane. Dr. Kuldeep Dalal is already there, and he is intensivist practicing at Bethany Hospital, Thane. And Dr. Vinith, he is well-known figure as intensivist at Thane. So these are our 4 chairpersons in the session. And I would like to introduce, I am so honored and delighted and very happy to introduce well-known figure in lung medicine, that is Dr. Zarir Udwadia. Dr. Zarir Udwadia is eminent pulmonologist with Breach Candy Hospital, Hinduja Hospital and Parsi General Hospitals. He has got 3 decades of experience in pulmonology, and his name is quite synonymous with MDR-TB. Whenever MDR-TB used to pop few years back, we used to look upon to him what to do, what not to do. He is having very good experience in pulmonary medicine. He is member of Maharashtra State Task Force of COVID-19, and he has been recently appointed on the Supreme Court constituted task force for oxygen distribution. Over to you, Dr. Zarir Udwadia, sir.
Thank you. Thank you. Thanks for that introduction. And I thought we are going to keep it informal, and I'm happy to take any questions from the chairpersons, the audience. I've not got any slides, so happy to answer all your doubts, questions.
So I would like to invite our chairperson if they want to pose some questions to Dr. Zarir.
I was told we were going to discuss steroids, tocilizumab, remdesivir. I'll leave it to you.
Sir, I'm Dr. Dinkar Desai, President of the Pathologist Association. I welcome on behalf of my association.
Thank you.
We have declared the topic for you is IPD COVID treatment. What works and what does not.
Yes.
So I would like to ask you what works and what does not work. So if you enumerate first,
yes,
then it will be better for asking. Yeah.
Thank you. So the list of what works, sadly, is much, much smaller than the list of what does not work. And I enjoyed the presentations of my colleagues Shashank and Salil, which put things into perfect focus. Let me tell you that there are very few things proven to work. And in fact, only 2 drugs that we know of, and we are now about 400 days into the pandemic. By the way, we have an excess of 100,000 articles on COVID published in the course of 1 year, which must be a record. And you need, as Shashank stressed, to keep updating yourself. It's a dynamic process. So the two things that affect mortality, have been shown convincingly to affect mortality, are steroids, after a remarkable study called the Recovery Trial, and tocilizumab. Both are the only drugs known to have a mortality impact, and maybe we can discuss them later. Remdesivir is not known to have any impact on mortality, but is believed to shorten hospital duration. And those are the only three drugs I would consider in what works. I would not consider anything else. Then there are drugs which we know do not work. And if I can make one plea on this eminent platform, it is that you should not be using them. You should not be using ivermectin. We have enough evidence from a nice study called the EPIC study of 600 plus patients, which showed it is no different from giving your patient symptomatic treatment or placebo. It doesn't affect, even in mild COVID cases, the outcome. So I have never used, it has never been prescribed. It is the first thing I cancel from prescriptions when I'm called in to see a patient. So ivermectin, doxycycline, azithromycin, antibiotics of different forms, vitamins in huge doses, all do not work. Plasma does not work. We have a convincing trial now, again from the recovery group of investigators, which showed convincingly that plasma does not work. So that is the broad stage I'd like to set. And if you'd like to go ahead with any of the specific drugs, I'm happy to give you my take on them.
Dr. Udwadia, sir, this is Dr. Vedhas Nimkar.
Hi,
there has been so much of controversy with different school of thoughts coming in. Some people advocating the use of remdesivir, whereas others saying it just reduces, like you just said, it cuts short the hospitalization duration by a couple of days. So what's your take on that, sir? Remdesivir?
So remdesivir never at home, never in the mild patient. There's also a question of scarcity and shortage with this drug, so we have to use it rationally. But it is an antiviral, and we don't have too many specific antivirals. Of course, this too has been used in other viral conditions like Ebola, where it was first pressed into service. But if I had a hospitalized patient who was requiring oxygen, not all hospitalized patients require oxygen. And if that patient was within the first 7 days of his illness, then I would use remdesivir. And I would like it used on me. Here is a drug, look, which shortens your hospital stay, improves the symptoms. We've often noticed that the speed with which the fever resolves in a hospitalized patient who started on remdesivir is quite prompt as well. And even shortening hospital stay by 3 days is a worthwhile outcome, in my opinion, especially with this huge pressure on hospital beds. So yes, I would use it, but use it early, like any antibiotic or any antiviral in any condition, within the first 7, certainly within the first 10 days. No point using it if your patient comes to you at week 2 or week 3. And I would not use it in a patient who is not on oxygen. That is my criteria for the use of this drug. Again, when the patient is at a very advanced stage on a mechanical ventilator or on ECMO, then it's probably too late to be using it. So it's that in-between group of patient who needs this drug. And never more than 5 days, I should add. 5 days has been established to be as effective as 10. So why use 10?
In the first year, sir, it was hydroxychloroquine. So what about that?
Hydroxychloroquine is a drug which has really been buried now. There is so much data on it, convincingly to show that it has no role, that it should not be on anyone's pen anymore. Just like ivermectin should not be on anyone's pen anymore. For any case, it has no role. Either for prophylaxis, both these drugs, by the way, I would stress, have no role also for prophylaxis. And it pains me when states roll out ivermectin, roll out HCQS, medical associations recommend HCQS prophylaxis. Look, if there was a drug which worked for prophylaxis, there would not be 20 million Indians infected today.
Absolutely, absolutely.
Sir, one question from chat box is, what about methylene blue?
No role at all. Untried things like this should just not be tested. You need to wait for the data, convince yourself, and then start prescribing drugs like that.
So what is your take on interferon? Regulated interferon and interferon?
No, initial trials again. Some forms of interferon were part of the recovery study that we were part. Solidarity, I beg your pardon, the WHO Solidarity trial. One limb was interferon, but it was shown not to be effective. So I told you the only two medicines that work in terms of mortality are steroids and tocilizumab. Perhaps we should be spending some time discussing them.
So that brings
Sir,
us
what is
to
your
the
take?
next question, that you said tocilizumab seems to be working. So we have a lot of mucormycosis cases, which many of them attributed to the use of tocilizumab. So if you could kindly elaborate on what should be the right criteria. When do we start tocilizumab? In whom it is really helpful, and where we better avoid tocilizumab. So if you could elaborate on that, please.
Very good questions. Though I would say that most of the excess mucor that we see is because of the unrestricted, unhinged use of steroids more than tocilizumab. And again, this is a good platform for me to say that please, pulse doses of steroids, for example, clearly have no role in this setting. Use the doses of steroid recommended by Solidarity, which are a modest 6 milligrams of dexamethasone or its equivalent. And the equivalent of 6 to 8 milligrams of dexamethasone is no more than 40 milligrams twice a day of methylprednisolone. Never have I crossed this dose of steroid because excess doses don't work. And of course, steroids given too early, as Shashank and Salil have stressed, also don't work. But coming back to your question, tocilizumab also, of course, has been shown to be associated with infectious complications. Again, you must use it early if you're going to use it. And again, we have data from two big studies, REMAP-CAP and Recovery. And let me discuss these with you, because initially I was skeptical about tocilizumab. Study after study showed initially that tocilizumab was no different from placebo in terms of outcome, in terms of mortality, but these were all underpowered studies. REMAP-CAP was published in the New England Journal of Medicine a few weeks ago. It included about 800 patients, so a substantial number of patients. These were only critically ill ICU patients who were included. Anyone who required respiratory or cardiovascular support in the ICU was a candidate to get tocilizumab, and it was given within the first 2 days. And it did show that there was a fairly dramatic and substantial impact on mortality. Again, if you use tocilizumab, you have to be absolutely certain that there is no secondary infection your patient is harboring or brewing, because it does have the potential to flare this up. And again, I would stress that none of the trials which used it successfully looked at things like IL-6 and ferritin levels. In my opinion, this is a test which should be banned. Just like someone, I think Salil said that CT scans at the onset of COVID have no value and should not be done. I've never yet asked for an IL-6 or a ferritin level, because both the studies which used tocilizumab use clinical criteria of worsening oxygenation and used a high CRP more than 75. So basic parameters were used in both these studies. So the first study was the REMAP-CAP study, which included tocilizumab only in the critically ill ICU group of patients. The other was the recovery study, which made the steroids famous, as you know, about 1 year ago. And this study looked at all patients admitted across multiple NHS hospitals in the UK. They looked at large numbers of patients. I think here the number was close to 4,000. That was the strength of the recovery, because they included even smaller NHS hospitals. They could include more patients. And here they were not just ICU patients like the first study. They were any patient who was on oxygen and where the oxygen requirement was going up. 2 liters was becoming 4 liters, was becoming 6 liters. And these patients were given tocilizumab. There was no placebo in this study. The other patients received the standard of care, whatever it happened to be. And this study also showed a significant impact of tocilizumab on mortality. Now, there are so many other issues. It's scarce and difficult to get. Sadly, there is a thriving black market in all these drugs because people profit here, even from, sadly, medical crises. It's expensive as well, each single dose. I would be very wary to cross a single dose of 400 milligrams, though in both the studies, the investigators had the option of giving a second 400 milligram dose, but not crossing a total of 800 milligrams. But I think if it's going to work, then 400 milligrams is going to work. Remember that this drug is hepatotoxic as well and has problems with the liver. But it's something to consider in any really ill patient, not the average patient of COVID, so severe COVID with increasing oxygen requirements and a high CRP. So that's all I need to say on this drug. And I'm humbled by this drug because, let me finish, because in the initial stages, in fact, we wrote a little article in Shashank's journal, Japi, saying that we were not keen on this drug. But the publication in the last month of these two important studies, REMAP-CAP and recovery, have made me change my mind. So COVID is a disease which always teaches you to be humble because it's unpredictable and because research is constantly changing. Yes.
Thank you, sir, for those references to REMAP, CAP, and recovery. You have explained it so well and cleared all the doubts, I'm sure, in the mind of other panelists as well as our delegates.
My request, sir, is though in spite of all the task force members in seminars and webinars are stressing what doesn't work, actually other two speakers have also spoken, and I have learned that other task force members are also not recommending. Why the task force is not coming out with a printout list once for all, that this should not be used, this should not be used, this should not be used. Because still this time ivermectin is given profusely. Even still this hydroxychloroquine is given, and use of remdesivir, as you know well, and tocilizumab just Vedhas has pointed out.
Dinkar, those are very, very valid points. And in fact, just before I started my talk, I messaged Shashank, the previous speaker, saying that this is exactly what we needed to do. But remember, the task force is also a diverse group of people, and we all have to, in the end, vote in a democratic way on what we should be using and what we shouldn't. But I agree with you, negative recommendations are as important, equally important as positive recommendations.
Because people are spending on that, and there are complications, there are side effects of that.
Absolutely.
Even plasma is not useful, that has to be stressed strongly.
I agree, Dinkar. I agree. And we are trying to update our guidelines and recommendations as frequently as we can.
Because political organizations are happy that they can collect blood and they can store plasma, which is useless.
And famous cricketers, of course, jump on the bandwagon and recommend it as well, which is again sad.
Yes.
Yeah, but that's the whole purpose of today's conclave, that we hear it directly from the stalwarts and we come to know what's right. And I'm sure, like Dr. Udwadia said, in the next due course of time, following the democratic process, the task force will come up with the revised guidelines. I'm sure about that.
Now, if I could... Yeah,
if the task force has no unanimous opinion and majority, then individually you can publish. There is no harm.
We are working on it, Dr. Desai. That's all I can say for now.
Vedhas, can I put in a question?
Yeah, please, sir.
Good afternoon, sir. I'm Dr. Lalit Sankhe. I'm a physician. What about baricitinib? Dr. Mehul Thakkar and Dr. Om Srivastav have run some data. I've been speaking with them.
There's no published Indian data. There is a good New England Journal's medical study of baricitinib in combination with remdesivir. As you know, it's a JAK2 inhibitor. It's orally available. Look, the data is preliminary, I would say. I would not. Let me finish. I've never prescribed it to date. It was compared with steroids, by the way. So people did not get steroids and baricitinib in the New England Journal of Medicine study. So I am waiting to be convinced by further data. There are so many promising trials which then do not live up to that promise. Basically, you have to accept that the main treatment at the ICU stage is supportive care. And drugs like baricitinib and becalizumab, etc., are not substitutes for that. So I do not think I would be able to recommend it at this point in time, but you keep an open mind to it. It's a promising drug in the New England Journal of Medicine study, but it was not used with steroids. And remember, each and every one of our patients is receiving steroids at present.
Sir, I'm Dr. Anupama Verma, a pathologist. I would like Dr. Dinkar Desai stressed the need of negative recommendation, which is not required. Similarly, I want you to mention on this stage that which basic pathology tests are required first day, first week, second week, third week, so that unnecessary testing is not burdening the patient because they are already middle class people who can't affording it. So please do negative recommendation for few pathology tests also. What is exactly required, what is not required?
Very, very few tests are required. In fact, I was on seminars with colleagues from Europe and America who said in the average home-treated patient, they would not ask for a single test if the patient was mild COVID, not a single test. The very opposite of us from countries where cost is not an objection. But if you ask me to say what is probably useful. I say a blood count because I'd like to know what the lymphocyte count is for reasons that Salil mentioned. The lymphocyte neutrophil ratio is an important prognostic marker. The CRP might be useful because the trend is important as well, more than just a single CRP. When you have a CRP of 150 or 200, you certainly would be more concerned than someone who has a CRP of 5, but that can change. And possibly a D-dimer level, though I would agree that I certainly wouldn't start anticoagulation at home just because someone's D-dimer is 700, 800, or even 1,500. So these are the 3 tests that I would ask for. I would not be asking for X-rays, portable X-rays, CT scans, and the ferritin and the IL-6.
Sir, I want more elaboration of ferritin and IL-6.
They're pretty worthless tests, as I said, and I wouldn't be asking for them. I can't be more blunt than that. I've never asked for them on an outpatient basis. And very rarely in the early days when I was deciding about tocilizumab, knowing that one is an IL-6 blocker, and theoretically it makes sense to know the IL-6 levels, I used to ask for it. But now with the current recommendations on tocilizumab being used on basis of worsening hypoxia and rising CRP, I don't even ask for it in the hospital setting. But you're right, they must be the most abused tests, like ivermectin and chloroquine must be the most abused drugs.
Still the concept is like do IL-6 first and then think of tocilizumab.
That's
so this is the platform, you have clarified that doubt.
So,
and what about ABG? A word on it, ABG.
ABG is very useful in a critically ill patient. Don't be misled by your saturation. So when someone is critically ill and that all-important decision of should I put this patient on the ventilator, should I continue with HFNO, should I continue with just NIV, if you get a very low PO2 or a PF ratio, which is very low, you know this patient is going to eventually need intubation and ventilation, and then you do it earlier rather than later. So if a patient is on full non-invasive support and still has a PO2 of say 55 or 60 or below, on NIV 100%, on HFNO 60 liters and 100%, then you need to do something extra. And that something extra is usually intubation and ventilation. So in the ICU setting, not even the hospital ward setting, there the saturation is good enough for the mild to moderate case. But in the severe case, it has major implications because calculating the PF ratio gives you a good idea of who is heading towards intubation and ventilation. That's a good point.
Dr. Vedhas, Dr. Pednekar, I want to ask a question to Dr. Udwadia. See, Dr. Udwadia, when we start injection remdesivir, but now there is a availability problem with injection remdesivir, and sometimes we don't get injection remdesivir for consecutive 2 days. And in that case, if somebody starts 5-piravir, and then the remdesivir is available, can we continue both remdesivir and 5-piravir in that patient? Both antiviral drugs?
No, the answer is no. You don't. You generally, to be honest, I was the PI of the favipiravir study in this country, the only study which looked at this drug in a controlled way. And my honest take on this drug is, if at all it works, it adds little. It's okay for the mild case. It shortens your maybe viral shedding and your hospital, your hospital stay by a day or 2 at the most. But no more than that. And it's certainly not a drug to waste too much time with, if I can be blunt, even though I was the PI of the study.
Sir, I want to ask if they both drugs
but
are
don't combine them. No, there is no evidence of the combination, doctor. So
we need to have some more antiviral effect.
Maybe at some future stage, combination antiviral therapy like we have for HIV will be the standard of care. But at present, we don't know. And you're risking cumulative toxicity. Favipiravir and remdesivir cause toxicity. Liver comes to mind, for example. Kidney comes to mind. Uric acid comes to mind. And why cause additive toxicity in the hope that they will help? So when you have access to remdesivir, I would not use favipiravir. Your patient is favipiravir is only recommended in the mild case, mild to moderate case who is symptomatic.
In future, we can try and study the combination.
Possibly, Doc, but studies are also extremely difficult to do at this stage, as I've discovered through working through this pandemic. Properly scientifically conducted studies.
Good afternoon, sir. Hello, sir. I am Dr. Rahul Pandey.
Hi, Rahul.
Yeah, good afternoon, sir. So basically, what we are seeing in certain patients who are absolutely fine, clinically doing well, but they are planned for discharge, and we repeat a CRP, we find that CRP is suddenly shot up. A patient whose CRP has shot up, but he is absolutely clinically stable, maintaining oxygen well, procalcitonin is normal.
Yes.
In such patients, should we plan discharge or we should wait and see that CRP comes down?
Well, CRP, it's a good point, Rahul, and I've seen this as well, but CRP itself should not be the sole criteria for discharge. Hospital beds are so precious, as you know, and it would be a shame to hold up a patient there. It is, however, a slight red flag, maybe an orange flag, I should say. If everything else is good except a climbing CRP, maybe that is the kind of patient you might continue the steroid on for a few more days on discharge. You know that in the recovery study, steroids were stopped at the time of discharge. They weren't continued longer, indefinitely, like we are so fond of continuing. Yeah. So maybe I would continue it for a few days longer. Maybe I'd ask the patient to repeat a CRP in 5 to 7 days, but that itself is not a reason for staying on in hospital. Now, if I may, I would like to say a few points about steroids and recovery. Is that okay? Just for a couple of minutes?
Yeah, sure, please.
Important points about when not to use steroids again. Don't use steroids upfront in all patients when you see them at home. Don't use steroids in the first week because they, as you know, are immunosuppressant and they dampen your immune system. And in the first week of COVID, all that really is going to help you is the strength of your own immune system. Don't use steroids in patients who are non-hypoxic, please. Because there was one big group in the recovery trial which did worse when they received steroids. And these were the 1,550 patients in recovery overall who received steroids but were not hypoxic. When that group of patients received steroids, they actually did worse. So there is enough data to say that you should be using steroids carefully, responsibly, in the right dose. And I've told you what that right dose is, 6 milligrams of Dexa. If you want to convert it to prednisolone or Visolone, that's a drug I'm more familiar with. For home use, it's about 40 milligrams of prednisolone, 30 to 40 I'm happy to use at home. And if you want to use methylprednisolone, 40 to 80 milligrams, they used it for 7 to 10 days. Not for longer. They stopped it at hospital discharge. And responsible use of this drug, this is a drug which is as cheap as a cup of tea. We're talking of drugs like baricitinib. We're talking of expensive drugs like tocilizumab. No drug has had such an impact on 28-day mortality as dexamethasone was shown to be used in recovery. It reduced 28-day mortality by 35% in patients on ventilators. It reduced 28-day mortality by 20% in patients receiving oxygen. So this is a drug which we should all be, of course, embracing, and we have, but embracing responsibly in the right doses at the right time and for the right duration.
Sir, I'm Dr. Sita. I would like to know your take on NOACs.
On NOVAX?
Yes, sir.
Well, all patients in hospital are generally given, as you know, low molecular weight heparin if they are sick and if they have pretty severe COVID. I would only continue the NOVAX in 2 groups of patients. This is at home, I would not use it. So even if someone has a D-dimer of 2000, I would not recommend it. I would not recommend aspirin, clopidogrel, or a Novac, because there is no evidence that they work in this subset of patients. You ask them to be wary, you ask them to be active, not be in bed all the time, but there's no evidence to actually use it. But if a patient in hospital has a proven DVT after about 4 or 5 days, or a pulmonary embolism after 4 or 5 days of initial low molecular weight heparin, you would switch to a Novac. I'm comfortable with Apixaban, but you can pick your Novac as you choose. And the recommendation would be 3 to 6 months if he has an established DVT or pulmonary embolism in hospital because of COVID or non-COVID. Now, otherwise, generally continuing a Novac in someone who doesn't have a DVT is a controversial issue. No study has shown that that is effective. But suppose at the time of my discharge, like Rahul said, the high CRP, but suppose the D-dimer at the time of discharge is 5,000, 7,000, 8,000, really high. Then I see no harm in using a smaller dose of Apixaban, and there I would use 2.5 BD, the prophylactic dose, not the therapeutic dose, maybe for 2 or 3 weeks, saying that, look, this patient may be at more risk of DVT and PE once he gets home, and let's cover him for that. So those are the two situations in which I would use a Novak.
Sir, one more question I would like to ask.
Yeah.
Yeah. So when we are treating patients in ICU, started on steroids in the second week for inflammation, we see that there's an upsurge of WBC count which is going up, sometimes in the range of 21,000, 30,000. Procalcitonin may be many times normal, CRP will be on the higher side. So what is your rationale in using antibiotics in such patients?
You know, by the time a patient gets to the ICU, almost everyone is on antibiotic, and sadly, not just on antibiotics, but almost certainly on meropenem, linezolid, Targocid, so heavy antibiotics,
Yes.
which is wrong. Because you run out of antibiotics for sure in a patient in the 4th week, in the 5th week, in the 6th week of COVID. The patient who then develops a ventilator-acquired pneumonia has nothing left to go on to. So this is a great platform to make a plug for rational use of antibiotics as well. But yes, that is a diagnostic dilemma always, that being on steroids, your WBC count can go up. I would say 15 to 20,000 can occur because of steroids, but much more often is not. So you use your clinical judgment. You see what your X-ray is showing. Is it just the COVID pattern, or now is there a LOBA type consolidation coming up? You use your PCT, and of course you send off your blood cultures, your urine cultures, your tracheal cultures, and decide. But you're right that a patient on steroids can have a rise in WBC count and leukocytosis, which can confuse the issue.
So, sir, if the PCT is normal, still we should step up antibiotics, or we hold on?
It depends. I can't give a firm recommendation, but generally you would feel happier in the 3rd week, or certainly even the late 2nd week, to cover such a patient with antibiotics. Though upfront, I need to say that I do not give. I cancel doxycycline. I cancel any other antibiotic the patient is on in the 1st week of COVID, because at this stage it's a pure viral infection.
Sir, I have a question for you, sir. I am Dr. Dhiren Kalavadia.
Hi, Dhiren.
Sir, do we require to do a repeat RT-PCR for patients who are admitted before discharge?
Not
this
at all,
question is
Dhiren.
related. Yes, sir. So this question is specifically related to, because there is one big corporation-run hospital, since you are in the task force too, who are not discharging patients till they get RT-PCR positive. And since you talked about the deficiency of beds, this is one area which we would want you to address.
Sure. That's a good point, and we do have clear guidelines, and we would hope, I mean, guidelines exist, but they're seldom followed, as you know, but we have clear guidelines, and none of us should be asking for a repeat PCR, whether it's a home setting or a hospital setting, and that's because patients can shed dead virus for up to 100 days. So that is the rough figure I can give you. Up to 100 days, you can reassure the patient. 2 months, 3 months, that this is not a reinfection if he's worried, because he may not checks it again after 2 months and said, I'm still positive, have I got reinfected? There is no role for rechecking. My general rule is that a patient is not infectious after 2 weeks of his illness, if it's home and hospital. And if it's a very sick ICU patient, I would say after 3 weeks of the onset of his symptoms, irrespective of his RT-PCR. And therefore, why ask for the RT-PCR? So we shouldn't be asking for it.
So how long do you recommend isolation for such patients?
2 weeks. 2 weeks from the onset of symptoms. And then I say, go and hug your family members without worry.
So do you think it will be a game changer?
What will, sorry?
Interleukin could be a game changer. Virabin, which is being marketed by Zydus.
I don't think so. I wish there was a game changer which could dramatically turn around the course of this disease. I don't think there is going to be one.
Thanks a lot for the excellent preventive.
We'll take a last question from Dr. Chotla.
Yes. So even I am a pathologist, and to continue the question asked by my colleague, so you told about CBC, CRP and D-dimer. Could you also enlighten something about the role of LDH, ESR, procalcitonin, when and where to add them?
No, LDH has no meaning. It's such a non-specific test, isn't it? And it's not been shown to be an independent prognostic marker either. What else did you say after?
ESR and procalcitonin.
ESR, why would one ask for in a viral infection again? So no. By the way, someone has asked about 2DG. Again, I'm surprised that drugs like that get DCGI approval or near approval based on such flimsy data, you know? Why can't we be honest and say that, look, nothing has been shown to be truly effective in this disease? So ESR, coming back to you, Doc, ESR also, I've never asked for. This is not tuberculosis where ESR or temporal arteritis where a ESR of 100 or 120 has meaning. And PCT is a useful ICU test for the patient who's sick enough to be in hospital, where you're constantly worried about, should I change my antibiotics and escalate or de-escalate? I would say the PCT is a good add-on test, but certainly not in the at-home setting at all.
Dr. Udwadia, how many cases of mucormycosis you have come across?
Personally, about 10 cases, and good results with isovoconazole if it is started early enough. All of them initially on liposomal amphotericin develop renal toxicity. So this is a good oral agent, extremely expensive, but in the end, probably cheaper than liposomal amphotericin and much less toxic.
So thank you very much for the...
Sir, one
No.
important question.
Madam,
Sir, only one question.
Dr. Vedhas, please carry on.
Yeah, Dr. Udwadia, thank you so much for all those crisp responses. And you have really enlightened us about every single important aspect of this COVID-19. Thank you so much, sir.
Thank you very much.
Piyush, kindly present, sir, with virtual memento. And then over to Dr. Jahnavi Ahuja to introduce our next speaker. Piyush, will you please?
At this juncture, I welcome Dr. J. Jalal, National President of IMA, Dr. Ravi Wankhedkar, who is the Treasurer of World Medical Organization, Dr. Anil Pasnekar, ex-Vice President of IMA Maharashtra, and Dr. Subhash Pingre, who is the President-elect for IMA Maharashtra. All these dignitaries have already joined. We are running short of time. The number has crossed more than 600 on the screen, but nearly 15,000 people are online with different kinds of settings, that is Facebook and YouTube. Too many channels have also relaying our program. So we are audible and
many more people on the live feeds on the Facebook and YouTube and some other platforms. Dr. Zarir Udwadia, kindly accept this virtual token of our appreciation.
Thank you.
And I also request the participants to kindly wait for the afternoon sessions. There are a lot of questions about 2DG and about monoclonal antibodies. We have lectures coming up on that, so you can ask your queries over there. Over to Dr. Jahnavi Ahuja to introduce our next speaker.
Welcome everyone. Without any further delay, I would like to welcome our speaker for the next session, Dr. Dinkar Desai, who is the President of the Pathologist Association and President of Association of Practicing Pathologists of India. He is also the ex-Vice President and Joint Secretary of IMA Maharashtra State and ex-President of IMA Thane. He is a practicing pathologist at Thane and he holds degrees in medicine, law and management. Welcome, sir. I would also like to invite our chairpersons for this session, Dr. Parag Dharak, who is a practicing pathologist at Dadar, Mumbai. He has a keen interest in academic activities and research. Welcome, sir. I would also like to invite Dr. Swaroop Kulkarni, who is the current treasurer of Association of Practicing Pathologists of India and the Pathologist Association. He is also a leading pathologist in Thane. Welcome, sir. And may I also invite Dr. Manoj Tamhane, who is the ex-Vice President of the Pathologist Association and a leading pathologist at Thane. Welcome, sir.
Mr. Piyush, can you share my screen?
Yes, sir.
You please add Dr. Swaroop Kulkarni.
Sir, his video is not on, that's why I can't.
Okay. Swaroop, video on.
Yeah. On killer. Okay, Desai, best of luck.
Thank you. Yeah. Dr. Maharkar, thank you. So the topic of today is lab medicine backbone of prognosis and management of COVID-19. It happens that the real train is out of way and it is kept on siding because so many superfast express are to run. The superfast express like Dr. Shashank, Joshi, Dr. Salil Bendre and Dr. Zarir Udwadia. So I was waiting in the yard first at sidings for a lot of time. So the continuity of our earlier two pathology speakers, that is virologist Dr. Pragya and Dr. Jyoti, who continued about the diagnosis of COVID-19 and how lab medicine helps in that. So can you go for next slide, please? Yeah. How variant strain cases differ from the first wave. This is second wave, and we are talking about what are the new things. The new virus strain having two mutations is highly infectious and has the potential to skip the immunity developed either by the natural vaccine or natural infection or vaccine. That is why it's not uncommon to see reinfection cases and cases among vaccinated people. Newer strains are not only more transmissible but affect the younger population and can lead to more severe illness. Next. Age pattern shifting, younger patient more. The new COVID cases are not detected by routine RT-PCR test, so that is bypassing of RT-PCR is occurring, and more thrombotic complications as compared to the cases of 20. Next. Next, please. Now we come to the list of lab tests for management, and as earlier speakers have enumerated what really important tests are there. So I am giving the list out of interest and for knowledge purpose, and then I will summarize what are the important tests. CBC is the most important test, is what highlighted by all people. NLR, that is neutrophil lymphocyte ratio, RDW, eosinopenia, lymphopenia. These are the things to be looked for CBC. C-reactive protein, ferritin, IL-6, that is interleukin, ferritin, D-dimer, LDH, PCT, procalcitonin, arterial blood gas analysis, and creatine, SGOT, SGPT, bilirubin. These are the important tests which we can perform during the management of lab tests. Next, please. Now we come to the NLR, that is neutrophil lymphocyte ratio. It is the ratio of absolute neutrophil count to absolute lymphocyte count. The virus-triggered inflammation increases the NLR. Elevated NLR, as pointed out, is if it is greater than 3.5, is an independent prognostic biomarker that indicates infection severity. NLR in the elevation may be due to dysregulated expression of inflammatory cytokines, an aberrant increase of pathological low-density neutrophil, and the upregulation of genes involved in the lymphocyte cell death pathway. So these two kinds of mechanisms, they work during the inflammatory cytokines expression. NLR has the highest of sensitivity and specificity and is a superior marker to other inflammation-based prognostic scores. So next, please. So going for the NLR and knowing is very important. An elevated RDW, RBC distribution width of more than 14.5 is a very simple marker of progression I mean, and is associated with an increased risk for all causes of mortality like pulmonary disease, sepsis, influenza, cancer, complications associated with heart failure and viral hepatitis, advanced stage and grade of many cancers, and the development of diabetes, chronic obstructive pulmonary disease, stroke, anemia, and many other conditions. An increase in RDW during admission or over the period of hospitalization was associated with increased mortality. So lies the significance of RDW. Next, please. Next. Use. Yeah. Very simple test is looking for absolute eosinophil count or eosinopenia, which you can say. That has been reported in coronavirus outbreak and is the characteristic of COVID-19 pneumonia. Zero eosinophilic syndrome, and if it is there, it indicates a very bad prognosis. So looking for eosinophils or rather eosinopelia has got a lot of prognostic value. Lymphopenia is found in 80% of very critical COVID cases. So any lymphopenia, next please, any lymphopenia is indicating that the prognosis for the case is very bad. The most popular test amongst all is the C-reactive protein as of now. Measurement of C-reactive protein is useful for the detection and evaluation of infection, tissue injury, inflammatory disorders, and associated diseases. As per some studies, higher the C-reactive protein, you are supposed to use higher steroid dose. It was observed that patients with low oxygen saturation, less than 90, had significantly higher levels of C-reactive protein, median is 76.5, compared with patients with high oxygen saturation, that is SpO2 greater than 90%. Combination of eosinopenia and elevated C-reactive protein can effectively triage suspected COVID-19 patients from other patients attending the fever clinic with COVID-19-like initial symptoms. What this means? Next, please. आप जनरल प्रैक्टिस कर रहे हो और eosinopenia और elevated C-reactive protein देख रहे हो, so you have to triage the patient from your general OPD. That is most important signal and warning. Ferritin is one more popular test, has been well characterized as an acute phase reactant, as well as a mediator of immune dysregulation in severe COVID-19. So is an active player in the cytokine storm scenario that characterizes severe COVID-19. Ferritin is associated with the severity of lung involvement, but not with the worst prognosis in patients with COVID-19 disease. Next. IL-6 is the most robust indicator, interleukin 6, most robust predicator of hypoxemia. The concentration of IL-6 more than 24 pg per ml predicted the development of hypoxemia with a next please. Yeah. Next please. Yeah. Predicted the development of hypoxemia with the sensitivity of 100% and specificity of 88.9%. I repeat, there is the sensitivity is 100% prediction for hypoxemia. So interleukin 6 becomes a very important test once the patient is hospitalized. What we find on day one, the general practitioners are writing IL-6. It has no sense. The positive and negative predictive values were 76.9 and 100% respectively. Of course, this IL-6 has got a lot of errors in reporting. Simply they are because of pre-analytical causes. Pre-analytical means before the sample is really processed, these causes are mounting high and they are creating the trouble. What are they? The improper blood collection tubes. Mostly it is collected in plain tubes. The preferred is in irritated tubes. And as soon as possible, if plasma is separated, that is far better. Transport delays are occurring. Sample is collected in the morning and reaches to the lab in the evening. Temperature exposure because of the very hot climate. So all these things, they matter for interleukin 6, and so you may get very strange reports in a very normal patient. So that has to be taken with a pinch of salt. Next, please. Next, yeah. Still another most popular test among this is D-dimer. D-dimer is the product of fibrinolytic degradation of fibrin, and elevated levels indicate that there is hypercoagulable state and secondary fibrinolysis in the body. That is what the significance of D-dimer, which is extremely useful for the diagnosis of thrombotic diseases. Now it is made clear that COVID-19 is more or less a thrombotic disease, and so for the importance of D-dimer lies in this diagnosis. If D-dimer is greater than 1 microgram per mcg per ml, suspect deep vein thrombosis or pulmonary embolism. That is a warning signal. D-dimer, of course, is a wonderful prognostic marker for monitoring hospitalized patients. So once you are hospitalized, all these tests matter. Some tests are required to be done on, next please, on daily basis. Some are required on alternate day, and some are required on 2 or 3 days basis. Accordingly, the severity of the disease like mild, moderate, and severe. LDH is an enzyme implicated in the conversion of lactate to pyruvate in the cells of most body tissues and increase following tissue breakdown. It's a non-specific indicator of cellular death because in many diseases such as cancer, liver diseases, sepsis, hemolysis, LDH values are high. So it's very non-specific. But if these conditions are not there, LDH definitely helps. It's an increase in LDH by 62. What is not more than LDH value is, look at the value. If it is increases by 62.5 units per liter, this has got acceptable sensitivity and high specificity for a disease progression probability. So if you are going to make a probability of the disease progression, any rise more than 62.5 in LDH value is very sensitive and highly specific. Next, please. Procalcitonin is another investigation asked. I don't want to close down the dukan of my pathologist fellow, but of course this has very little significance. Procalcitonin is the propeptide of calcitonin devoid of hormonal activity. Normally it's produced in the C cells of thyroid. Healthy PCT levels. Can you unmute? In healthy persons, PCT levels are undetectable if it is less than 0.1 nanogram per ml. During severe infection, that is bacterial, parasitic, fungal infection with systemic manifestation, PCT levels may rise to over 100 units. PCT in initial stage is to rule out secondary co-infection and not to assess the severity of COVID. This is very important line. PCT is to be used to rule out a secondary infection, co-infection may be bacterial, may be fungal, may be parasitic, but it is not concerned with the severity of COVID. Values influenced by comorbid conditions like CKD and CCV, that also must be taken into mind. Next, please. Yeah. For monitoring purpose, when you are hospitalized, when the case is transferring from moderate to severe disease, arterial blood gas test is most useful for measuring arterial oxygen and carbon dioxide in severe cases along with the pH. This monitoring can be daily in moderate to severe cases. The evaluation of troponin, it indicates cardiac injury. LFT, not all, but mostly enzymes like SGPT, SGOT, and to some extent bilirubin, they help to indicate a liver injury of mild to moderate cases and moderate derangement in severe cases. Renal function test indicates kidney injury. So just to know what the other organs are showing signs of injury, these tests are useful in hospitalized patients. Next, please. Piyush. Next. Yeah. This is lab finding in mild, moderate, and severe cases. This is the most important chart for clinicians as well as pathologists. What is the usefulness? Mild cases, moderate cases, and severe cases. The neutrophil lymphocyte ratio, which we talked about, if it is less than 3.5 cases in mild cases, greater than 3.5 in moderate cases, and more than 5.2 in severe cases. So looking at the value of NLR, you can say mild, moderate, or severe in otherwise. C-reactive protein, less than 20 mild, 20 to 50 moderate cases, and greater than 50 in severe cases. Ferritin, less than 500, greater than 500 in moderate cases, and greater than 800 in severe cases. D-dimer value, less than 0.5 in mild, in moderate 0.5 to 1, and in severe cases it is greater than 1. LDH is less than 300, in mild cases, moderate cases 300 to 400, and severe cases greater than 400 units. IL-6 less than 5 in mild, 5 to 50 moderate, and if it is 50 or more, this indicates a severe case and the prognosis is of course very bad. So these severe cases, the investigation report itself, apart from the clinical presentation, the clinician can understand the prognosis of the case. In mild cases, the LFT is absolutely normal. moderate cases, there will be slight derangement, and a moderate derangement will occur in severe cases. Next, please. Mr. Piyush? Yeah. So that is my last best slide. Thank you very much.
Thank you, Dr. Desai. First of all, let me congratulate for selecting the most apt title for your talk. As it indicates, there is nothing indicative or diagnostic per se in all these blood investigation, but it is more of monitoring purposes why we are doing these tests.
Yes.
So, as doctors, we must understand this. Secondly, what all the talks are mentioning is most of the doctors are working aggressively defensive. So they just, you bombard the patient with all the tests, you bombard the patients with all the medicines, and then wait whether there has been a recovery which has been occurring. So as doctors, we need to show COVID responsible behavior also. And there also, I would like to congratulate you to hold this kind of conclave for the benefit of all the doctors. In the talk, you mentioned about the IL-6 also, and as the rest of the experts have already said that IL-6, what is the utility of that test should be taken into consideration, as well as the limitation of all these tests. One point I would like to mention that D-dimer, which is being done by 3 or 4 different test methodologies, has shown a variance to the tune of 25 to 30% of the value. So if one can understand a D-dimer being done in any laboratory, being shown as 500, could be 350 or 375 on another machine, and it could be 600 or 650 on the different machine with a different technology. So it was a very good talk. One thing I would like to ask, because people have been asking how frequently these tests should be done. And there is a second thing regarding eosinopenia. Is it necessary to understand whether what was the baseline eosinophil levels? Because this was something which was seen in typhoid also. But if a person is having a eosinophil baseline, which is 15%, and then there is a drop of 5%, even if it is a drop, I mean, even if it is 5%, it is to be considered as good as eosinopenia.
Yes, absolutely right.
So these are the two questions which participants.
If you have got say on day one CBC eosinophils are having good count, irrespective of absolute eosinophil count, and on 5th day you find the percentage of eosinophils had dropped down, of course that is a good indicator.
What about the frequency of the investigations to be carried out? For example, CBC, CRP, is it to be daily or maybe alternate day?
CBC, C-reactive protein is not required. Nothing is required daily. In the first OPD wise, when you are just investigating, few investigations like CBC, C-reactive protein, and to some extent some enzymes like OTPT and creatinine, that is more than sufficient. Of course, somebody may like, if it is on 4th or 5th day, you can add D-dimer to that. But asking for ferritin test, asking for LDH test, asking for IL-6 before hospitalization, I don't think it has got any significance. People write RFT and ILFT. I don't mind, because as pathologist and association, we would like to have this kind of investigations, because Baker is going so very bad. So this kind of thing, if it is coming, of course, we are receiving hardly 1 or 2 patients or 3 patients. I have received so many messages from my fellow pathologists, and we are somehow surviving and struggling. So I cannot make this message loudly, but I don't think full LFT, full RFT has any significance. In full RFT, what uric acid and what that electrolyte is going to help in early stages, I don't know.
And another thing I would like to add a small thing that over a period of last 1.5 months, I have been seeing presence of malaria also quite frequently. So every fever should not be totally seen only as COVID, but other things should be kept also in mind.
So now the malaria season is also going to come. Mosquitoes will be coming back after the first rains, and yes, malaria and dengue, they have to be ruled out. Otherwise, you may be treating COVID and the person may die because of dengue fever and malaria.
In malaria, we
fortunately, the government and the whole of India and Maharashtra state should be fortunate for one statement of Pathologists Association that for last 1 year, malaria and dengue were missing. I make this a bold statement that they were missing, and that is why there was not much chaos. And the identification of fever cases, PO cases was simple. Either it is influenza or it is COVID.
Possibly HCQ administration helped.
I don't know what perhaps COVID virus may not have allowed these parasites to grow.
Can I request some panelists to ask a couple of questions to Dr. Desai, sir?
I am asking one question. Desai,
Haji.
एक क्वेश्चन विचारतो मी.
Haji.
विचारू का?
विचारा.
Because you mentioned very two important things. One is eosinophilia, eosinopenia and lymphopenia. Does it have a significance in prognosis of the patient? You have not mentioned about suppose the patient is recovering. So what will be the status of these two cells, eosinophilia or lymphopenia?
Eosinopenia and lymphopenia, I boldly mentioned that they don't have much diagnostic but have got prognostic value.
The same thing I'm telling, whether it rises.
So that's what we were discussing, Dr. Parag and myself, that if it is in the initial stage, you will get a report of 15%, and then in the next report, if you find a drop to 5% or 2%, it is very significant.
The eosinopenia means only 0 to 4 is a value. How can you say then?
Eosinopenia?
Eosinopenia, when normal value is 0 to 4.
Yeah.
Then when do we call eosinopenia then? If it is the value
I mentioned in my lecture, sir, it is zero eosinophilic syndrome. Eosinophils are 0, 1 or 2 at the most. And if it is regular, normal count is not seen, then it is a point of worry. Yeah.
Okay, thank you.
I request Piyush to kindly present a memento to Dr. Desai, sir. Piyush, and I call upon Dr. Rekha Thote to introduce the next speaker. Piyush, can you? Yeah.
Desai, on behalf
I offer this memento to the president of association, Dr. Dinkar Desai, and I, Dr. Dinkar Desai, accept this with great honor. Thank you very much.
I would request all the delegates to give a big round of applause to Dr. Desai, sir, for being the brain behind this conclave today and being the guiding light to all of us. Huge round of applause for him. A virtual round of applause, maybe.
Yeah,
and over to you, Dr. Rekha Thote.
Thank you, sir. Now let us discuss pregnancy and COVID infection. The topic is antenatal care, modification and management in COVID era by Dr. Rishma Pai. To chair the session, I would like to invite Dr. Sudhir Nayak, sir, who is a past president of Association of Medical Consultants, Dr. Datta Panandikar, past president of IMA Thane, and Dr. Ujjwala Bardapurkar, who is a current IMA president from Bhiwandi. It is my privilege and honor to introduce our today's esteemed speaker, Dr. Rishma Pai. Dr. Rishma Pai is an eminent gynecologist and obstetrician from Lilavati, Jaslok, and Hinduja Hospital, Mumbai. She is the president of Mumbai Obstetric and Gynec Society. She is a former president of FOGSI, ISAC, and IAG. She is the only Indian selected to be on the board of International Federation of Fertility Society as associate treasurer. Welcome, Dr. Rishma Pai. Over to you, madam.
Thank you. Thank you so much. Good afternoon to all of you. Big thank you to Dr. Desai, Dr. Nimkar for thinking of the gynecologists. It's not often that we are invited on a platform where physicians and expert pathologists, etc., are speaking. So it's been a learning experience for me. I've been tuned in for a while and watching and have learned a lot. So thank you so much for this honor. I hope I can be seen and heard properly. So,
yeah, Rishma, you're fine.
Thank you. Let me begin by saying that difficult roads often lead to beautiful destinations. And today, one of the most difficult roads is the one being traveled by a woman who is pregnant during these COVID times. And so let me bring to you a different perspective from what all of you are seeing every day as physicians or pathologists or people who are looking after patients in ICU, and that is on how to manage the pregnant patients in this difficult phase of COVID. For these millions of women who have or will give birth between March 2020 and May 21, the majority or all of their care will occur under some form of coronavirus-induced restrictions. So for these women, this is not a temporary change. This is their entire pregnancy and birth experience. And so it's extremely important that we optimize their physical and mental well-being, and we make sure that they adhere to all the norms, but in somehow a pleasant and acceptable fashion. So when we are looking at this unique situation, we have to look at the effect of COVID-19 on the pregnancy, the effect of pregnancy on the severity of the infection, what are the effects on the fetus, how do you manage these patients during pregnancy, labor, and post-delivery care. So it appears, unfortunately, pregnant women do not appear to be more likely to contact the infection than the other population. However, pregnancy does alter the immune system, and there is a strong possibility that there may be more severe symptoms in this group because of the reduced immunity in their body, which occurs naturally in the pregnant state. There are many reports of preterm birth, and we'll address this in a bit. But pregnant women with heart disease are at the highest risk. And one issue which we must not forget is the increased risk of anxiety and depression and the huge increase in domestic violence all over the world. And so mental health support is also very, very important. And this has been highlighted by a very recent ICMR document as well. Many of our Indian studies at the beginning said that pregnant women are not at heightened risk. But look at this recent publication in the American Journal, which said that the COVID-19 hospitalization and case fatality results in pregnant patients was significantly higher compared to similarly aged adults. And they found that there was a hospitalization rate 3.5-fold higher than in similarly aged adults. And the fatality rate also was 13-fold higher. This is huge, the difference. And obviously, the majority of those suffering were the poorer community, the minorities, those with hypertension and obesity. And just to give you a comparison, the case fatality rate in pregnant women was 1,250 per 100,000 in comparison with the normal rate in that particular setup, which was 37 only per 100,000. So a huge increase in mortality rate. We did not see this in the first wave, but in the second wave of COVID, we in India are also experiencing higher mortality rates in pregnancy. The preterm birth rate is significantly high, and all of us have experienced this. Comparatively, 45% preterm birth rate versus 5.2% in a non-COVID infected population. So again, this is a huge increase in preterm birth. Now, COVID-19, all of us know, is a preventable condition. And true prevention is not waiting for bad things to happen. It's preventing them from happening in the first place. And particularly in this group of pregnant patients, a very vulnerable populations. If we can make modifications in our antenatal care, the entire 9 months when we are supposed to be seeing them, if we can bring about modifications, maybe we can reduce the incidence of infection. So, of course, some of the advice is very standard, your respiratory, hand hygiene, disinfections. Work from home is important. Avoiding non-essential travel is hugely important. And particularly for Indian patients, avoid these 7th month functions. It's a huge thing, and all of them call their friends and family and have the 7th month celebration. This has to be totally, decentralized. The antenatal care guidelines have come in from many different organizations. The ICMR has said that you have to reduce to minimum the antenatal visit, just about 4 visits in an entire antenatal period. And those patients who suddenly have symptoms, you can definitely delay the antenatal appointments by about a week. Tell them to keep doing the fetal kick count at home. Supposing a relative in the house has an infection, you can tell them to self-quarantine and postpone the appointments by about 2 weeks. Even if you have to go for ultrasound, you can defer this by 14 days until the patient who's having this infection is, much better. So defer appointments unless, of course, the patient is having a severe form of the infection. The Royal College has given a very clear schedule for antenatal visits. Typically, we see our patients almost 9 to 10 times in their pregnancy of 40 weeks. So the RCOG has reduced also. They've recommended that your initial visit, the first visit, you keep on combining 2 or 3 appointments and do only 1. And at each middle segment from 16 weeks to 18 weeks, just do virtual appointments. At 18 weeks, which is the anomaly scan, do a physical visit, do the entire checkup, urine, blood pressure, etc. Again, in the second half of pregnancy, continue to do virtual visits, and then maintain the appointments at about 28 weeks. The important thing is at each visit, optimize the visit. Do all the checkups, do the blood tests, give the vaccination, all in one visit. Again, your middle pregnancy, 30 weeks onwards, keep it all virtual. And towards the end of pregnancy, again, call them back for a physical appointment. So lots and lots of organizations, including our International Federation, FIGO, has recommended reduced antenatal visits. And they have said very importantly, one of the most important things we do when a patient comes to us is check her blood pressure. She can do this at home. Measuring weight has not been shown to improve outcomes. Checking heartbeat every time they come has not shown to change pregnancy outcomes. There is insufficient evidence that measuring fundal height improves outcomes. In fact, somebody has even recommended a drive-through prenatal care. The patient comes in her own car and you just check her little BP, check the heart rate, and send the patient off. So many things the patient can do at home and will not worsen her conditions of pregnancy. Australian hospitals have said that your antenatal visit should be linked to immunization. So your first antenatal visit, give her influenza vaccine. Second appointment at 28 weeks, give the Tdap vaccination. And towards the end of pregnancy, do your ultrasound at the same visit. And so all recommendations are to reduce the antenatal visits to approximately 4. However, this is different for women who are at high risk for complications. There you have to give continuity of care. So women who are obese, lower social strata, have hypertension, diabetes, all of them, you have to continue to look after them as you would in the non-COVID pandemic times. A huge issue erupting everywhere today is about the COVID-19 vaccination in pregnancy. And this study, again, from the American Journal, said that it's a real matter of concern that the exclusion of pregnant patients from COVID-19 trials was done. It's a huge mistake because this is a very high-risk group. And because we did not include them in the trials, we don't have any good information whether they should be given vaccination or not. We should have included pregnant women in the trial, and we missed out on a huge opportunity. So earlier on this year, the International Federation of Fertility Society, the European Society for Human Reproduction, they all said that there are so many different vaccines coming in. Unfortunately for us, none of the vaccines are live attenuated vaccine. For example, like how the rubella and the varicella used to be. In pregnancy, only live attenuated virus vaccines are dangerous. So none of the current vaccines belong to that category, and hopefully they will be safe in pregnancy. The Royal College very recently, in fact, just a few days earlier, has said, and these are important for us because we have been using the same AstraZeneca Covishield vaccine, which was used in the UK. And they have come out just 1 week ago that all under 30s should be offered either the Pfizer or the Moderna, not the Oxford AstraZeneca, because the heightened risk of blood clots. And they are offering all pregnant patients the option of vaccine. This is new, just come out a few days ago, that you should offer pregnant patient vaccine, but not the Covishield. They should be given the mRNA vaccine. And this is because of a huge study from the US. 90,000 pregnant women have been vaccinated with the mRNA vaccines quite safely. So these rare risks of blood clots, thrombosis, thrombocytopenia because of the other vaccines is real. Our federation, our All India Federation, has said that in India, the Covishield, the Covaxin, the Sputnik, all of them are basically either viral vector vaccination or inactivated whole virus vaccination. They should be safe in pregnancy. They probably are safe in pregnancy. But as there is no data, we cannot at the present moment recommend these vaccines because no studies have been done. The government of India has actually said it is contraindicated pregnancy and lactation for vaccination. And we are not allowed to give vaccination to this group of women. However, just 2 days ago, and we all know COVID is such a dynamic, daily changing scenario, 2 days ago, the government has said that they are looking at it and they may begin to allow. In fact, our federation has said that we should give vaccinations to pregnant and lactating women. But please note, as per the RCOG guidelines, the vaccines available in India, the Covishield may have high risks. The Covaxin, there are no studies in pregnancy. And so maybe if and when the mRNA vaccines come in, we should be able to give them to our pregnant and lactating mothers. Lot of questions today about vaccination during the menstrual cycle. So please note, no changing of the vaccination administration if the woman is menstruating. No need for a pregnancy test before administrating the vaccine. If inadvertently a pregnant woman in early pregnancy is given the vaccine, you don't have to advise abortion. The pregnant woman who's already infected, remember, she may get infected later on as well, and you can give her a vaccine when it is allowed. Pregnant women with comorbidities, this is a high-risk group, and so whenever they are allowed, we should vaccinate them. So also for breastfeeding mothers. A very important aspect, fortunately, was opened up by the Medical Council in partnership with the government, and that was allowing us to do telemedicine. All of us know that these digital technologies have been there for decades, but in obstetric practice, it was never being used. And so with the opening up of telemedicine, a lot of online antenatal education, a lot of telehealth consultation visits, even before they come to us, we do a teleconsultation. So the time spent face-to-face is absolutely minimum. And these digital apps have helped hugely the patients because many problems can be solved without face-to-face interactions. And so you can see at every level, from home monitoring of blood pressure, sugar, consultation with specialists, communication, mental health issues, postpartum lactation supports, all can be done via telemedicine. Of course, when they visit us, we have to adapt our centers. And these are some pictures from my clinic. We have definitely changed. We've definitely included distancing. We've improved ventilation. We've replaced in certain clinics AC with air exchange machines. I've put up UV lights in all the clinics, which are put on between patients or after the clinic is over. We've divided our staff into mini teams. We are doing a lot of telemedicine, and the appointments are totally spaced out so patients don't wait. We've limited the patients, the numbers, and we've reduced our consultation time. You can see in my clinic, I've put a glass barrier between the patient and the doctor's table. So trying to make as many safety measures as is possible. Yet, despite all precautions, if the patient does turn out to be pregnant, what do we do? I think a lot has been discussed about investigations and tests, and I'm not really going to go into it. The presentation is very classic, not different at all for patients who are pregnant. Classic symptoms of fever and cough, etc. The tests, again, are typical. The RT-PCR is right now the gold standard. Sometimes in a rush, we have to do a rapid antigen test because hospitals are not admitting patients unless a COVID-19 test is done, the RT-PCR. And, patients come in labor at all times, so they may not have the test. Fortunately, now the ID Now test has come, which is a 13-minute, very accurate test with a very good sensitivity and specificity. Of course, antibodies is really more to determine a past infection, not really relevant for current infections at all. And the investigations, again, I think we've just had a wonderful talk. We don't need to harp on that. The only thing I want to highlight is the CT chest. People are scared in pregnancy to do an X-ray or to do a CT scan. Please note that all pregnant women suspected of COVID-19 can receive a low-dose chest CT. The typical features on the CT will help you diagnose quickly the condition and give care. So don't shy away from X-ray with a shield or CT chest if necessary. How do we intervene in various scenarios? We have to tell the patient that if she tests positive, she will have to deliver at a very dedicated COVID facility. So the moment she does develops any kind of symptoms, immediate test is done. And of course, like I said, if the symptoms are mild, home quarantine, delay your antenatal visits, but be in constant touch with them on the phone and defer their ultrasound, defer everything. Tell them to monitor BP, tell them to monitor parameters, oxygen saturation, fetal kick count at home. And you can definitely defer your appointments for early, simple cases. Severe cases, of course, have to be handled in a hospital facility.
Little fast, madam.
So just running through some of the drugs, we've all discussed them, but in pregnancy, all of us know situation is very, very different. Aspirin, we can safely use if the need requires, because all of us have used aspirin in thousands of patients, even in the first trimester. So also steroids, many patients are given steroids for various reasons, including in the first trimester and of course in latter half for lung maturation. So steroids are definitely recommended when you're treating pregnant patients with COVID. Remdesivir, there are not many studies, but a recent trial has come out and it has said that you can give it in pregnancy if the benefits outweigh the risks. There's a series of 86 patients who were given remdesivir and there was no major problem. They recovered quite well. Tocilizumab, everybody has been talking about it, but in pregnancy, adverse effects have been described, including congenital malformations, miscarriages, and preterm births. So malformation rate of 4.5, miscarriage rate of 20% has been found. So you have to be very careful when using these drugs. Hydroxychloroquine, I think basically safe in pregnancy, though it's not known to be very effective in COVID. So also azithromycin, safe in pregnancy, but not very effective in COVID, I believe. The lopinavir, ritonavir, again, do not suggest an increased risk of malformation. So you can use these drugs safely if you think they have any value. And the interferons, there is, again, these are all UK Teratology Information Services come out very recently, which I'm quoting. They don't show any reduction in mortality and they are not recommended. So these are all guidelines which have come out very recently from the UK. Remember, of course, another very important part in pregnancy. Pregnancy as it is a thrombogenic state, higher risk of thrombosis in pregnancy. But we know that the COVID-19 thromboembolic events are either microvascular thrombosis, which is immunothrombosis, or of course, there is a hospital-associated venous thrombosis. And pregnancy being prothrombotic, we are always worried and we are very liberal with recommending the use of heparin, low molecular weight heparin in pregnancy. So though there is not much evidence for aspirin, it can be used if so recommended. There is no real recommendation that even heparin works, but if the physician so thinks, it can be safely used. Severe cases, I think we are not in a position to manage them. We have to send them over to our physician colleagues. But remember, ICU, you have to obviously look after them as you would any other COVID-19 patient with ventilation, with renal replacement therapy, all the support systems. Our importance of pregnancy comes in, supposing the patient is less than 28 weeks and she's serious, what do? We have to give her supportive treatment, and you may want to consider that if she has has to be delivered just for her life-saving situation, then you may have to actually deliver her early. However, if she's more than 28 weeks, most of the time the fetuses can be salvaged. Give her dexamethasone for lung maturation, and you can terminate the pregnancy and expect the baby to do quite well. So in labor, of course, always look after her oxygen saturation, look for any signs of sepsis, continuously monitor the heart rate. Don't decide to do a cesarean just because the patient has COVID. Depending on her obstetric conditions, normal delivery or a cesarean can be planned. You can give spinal or epidural, and let the patient's progress of labor and her medical condition decide about cesarean or LSCS delivery. Of course, she's delivering normally. You can shorten second stage with a vacuum or a forceps. Postnatally, remember that there is the possibility of transmission to the baby if the mother is COVID positive. So think about temporarily separating. The mother can express out breast milk with a breast pump, and a healthy person can give that milk to the baby who is isolated. Make sure if the mother is breastfeeding that she's very well masked and taking care of hygiene, because she can transmit infection to the baby. What about the effects on the baby? There's no data suggesting increased risk of miscarriage or teratogenicity, no MTP required. Remember, vertical transmission from the mother through the placenta to the baby has been reported. It is possible. We don't know whether breast milk really transmits, but close contact of the mother and baby can definitely transmit infection to the baby. This study by the ICMR of a review of 50 international studies is quite alarming. 8% mother-to-child transmission, 8% babies having respiratory distress, 20% preterm births, 9% fetal distress, 6 stillbirths, and 4 neonatal deaths. So quite alarming series here. And I've put this picture out. This is a real life picture of a baby with a little shield. In Korea, they're putting all newborn babies a face shield because we know that they can be infected. So we know that maternal antibodies go to the babies. It is depending on the severity of the infection and the time between the infection that the mother gets and when she delivers. And maybe these antibodies will be protective to the baby. So there is definite transmission of antibodies via placenta to the baby and via breast milk to the babies. So let me end by saying that the risk of severe COVID-19 during pregnancy may be higher than in the general population. Vertical transmission is plausible, but we don't really know the effects of it. Steroid use can be done safely. Thromboprophylaxis should be done liberally. They may be encouraged to breastfeed, but whether you want to express and give the baby, maybe that will be a better option. And of course, make sure that you take care of the mental health of the patient along with her physical well-being. So really, even the darkest night will end and the sun will rise. We are all hoping and praying that this dark night of COVID will end soon. Thank you. Thank you very much.
Rishma Pai.
Thank you, Rishma, for an excellent presentation. I think all of us as gynecologists will appreciate the clear-cut guidelines which you have already enunciated in your this thing, but there will be a few questions. Anybody from... yeah, Dr. Datta?
Yeah, no, I just wanted to congratulate Rishma. She is always phenomenal. Her studies are crisp and she has very strong take-home messages. So just for the people who are in this, some very strong take-home messages from Rishma. You can take the vaccine anytime during the menses. You don't need to avoid the vaccine if you're on infertility treatment. If you're planning a baby, please take the vaccine, because I think today it is more important than even planning a baby. If you take the vaccine and if your urine test comes positive 15 days later, please don't abort. It's not an indication to abort. Pregnancy, Dr. Rishma said very clearly that though all the nodal organizations are recommending that pregnant women should be vaccinated, the government has not yet given us the green signal. I just wanted to confirm, Rishma, from you about breastfeeding mothers, because there are a lot of mothers who have delivered who constantly message or call up to ask whether they can take the vaccine.
Yeah, so at the moment, the Government of India has not recommended pregnancy or lactation. Both are contraindications at the present moment. But just 2 days ago, there is a release from the Government of India that they are reconsidering this. And in a few, just in a few days, they hope to release guidelines that they're making it open, and they will probably make it open for all kinds of vaccines. And that is why I put out the RCOG, Royal College study, which has come out literally this week, which is saying that they have stopped AstraZeneca equivalent Covishield vaccine from pregnant women and from under 30 women. They are not giving it to this group because of the increased risk of thrombosis. So we have to consider, even if the government allows us, whether we should be giving the Covishield vaccine to this group, or we should await the other vaccines which are coming in, preferably the mRNA, because the 90,000 patients study which has come from the USA is only on the mRNA. On Covaxin, Covishield, we have like 0 studies. So whether we want to give our pregnant patients, we want to vaccinate them for sure, but whether we want to vaccinate them with these vaccines is another issue.
Hello, Dr. Rishma ma'am, I would like to add a point here. There has been studies which have come up from US. These are pertaining to the mRNA vaccines, the Pfizer one and the Moderna one. Yes. Of course, the sample size is quite small, but it says that those patients who were enrolled into the studies and now delivered, the mothers have delivered their babies. There is an evidence that even there is a transfer of anti-COVID specific antibodies from the mother to the newborn baby. So that's another reason there that we should be vaccinating the mothers, so that there is a immunity passed on, or the antibodies passed on to their neonates. But of course, like as you said, that Covishield has a propensity to develop DIC and the thromboembolic phenomena. So we have to, in our country, mRNA vaccines as of today are not yet available. But I'm sure in the near future they would be. And till then, we should be a little cautious about vaccinating mothers in our country with Covishield.
It's very important because antibodies have been found in majority of the children who are born to COVID positive mothers. So there is definitely a possibility of a protective benefit in the children, and even breast milk, they may be transmitting protective antibodies. So there is definitely a role to play. But in the patients who are not infected, it's a bit of a dilemma because we don't have a choice of vaccination right now. So in principle, we all agree that we should vaccinate pregnant and lactating women, but the vaccine that we have not yet proven to be safe, and we have unfortunately no studies in this with this vaccine group. So awaiting the mRNA vaccines, or whether we want to experiment with our pregnant ladies, is another issue.
Thank you very much. Thank you very much,
Hello,
Dr.
sir,
Rishma Pai.
I will take a quick question from Dr. Bardapurkar. Dr.
Yeah.
Bardapurkar, please.
Yeah, just I want to ask Dr. Rishma Pai, what about infertility patient? Should we allow them to go for active treatment of fertility before vaccination?
Yes.
Should we?
So, we run IVF centers all over the country. And every single day, we are getting many, many queries about patients who are waiting for their fertility treatment. And the guidelines are very clear from across the world. Every single international fertility organization has said that for women who are older, who have a low AMH, who have endometriosis, whose fertility is low, please do not delay treatment for the sake of either vaccination or, because there is COVID in the area. Go ahead with fertility treatment. All our young patients, our otherwise healthy patients who have no urgency for pregnancy, we are advising them to go ahead and get your vaccination. Wait it out after your second dose for about a month or two, which is the recommendation after second dose, and then come back. Supposing many of them have frozen embryos kept with us, they want to do a transfer of the embryos. So this is the guideline that we are giving them. However, unfortunately, again, this 18 plus vaccination has taken a real beating, and our young patients who are infertile are not getting vaccinated. So there's a never-ending delay for these people. And it is really all international organizations are recommending do not delay fertility. Those who are getting pregnant naturally, nobody's telling them to not become pregnant because there's COVID in the air. And so we are not deferring pregnancy limitlessly.
Thank you very much, Dr. Rishma Pai.
Take ask question. We are planning baby. Should we go ahead with the pregnancy in this era?
Sorry,
we are not immunized. That is a common question asked.
I couldn't hear the whole question. Sorry, the first part.
Generally, common question asked by a couple interested in childbearing.
Yes.
We are planning baby now, but
Yes.
this is COVID era and we are not immunized. So what should we do? How to go ahead? That is a common question used by the couple.
Yes, I think this is everybody has said that you have to empower the woman with making the choice, give her the pros and cons, because there's no right and wrong answer in today's times. I personally would prefer that if I like women to plan their pregnancies. I always advise them that nothing should be haphazard. Even if you're having a natural conception, plan when you want to have your baby. So I would recommend that if they can get vaccinated, wait for 2 months after your second shot, and then go ahead and plan your pregnancy. Yesterday at our conference, Gynae conference, we had Anushka Sharma, who just delivered recently as our guest of honor. And she was telling us how it was to go through COVID because she conceived soon after the COVID pandemic broke out, and how careful she had to be and how anxious she was because she had her entire pregnancy during COVID times. And so, but I think if you're careful, if your doctors are clued in and you are sensible, I think you can go through pregnancy very safely, even in this COVID time, because this is never ending. There'll be second, third wave and fourth wave, who knows? And our country's immunization rate is only 2%. So I don't see an end to this very quickly.
One question on my personal I have received. If 26 weeks COVID pregnant patient cures and her physician is not advise her low molecular weight pregnant heparin to her, would you personally continue her on low molecular weight heparin till term?
Controversial question, because like I said, most of the COVID, this is immunothrombosis, right, in the small vessels, and the other is DVT. So what is the patient really, what are we giving thromboprophylaxis for? Having said that, I personally would give thromboprophylaxis because it is pretty safe in pregnancy. We give it to so many of our patients with recurrent pregnancy losses. We give it throughout the pregnancy, Apla syndrome. We give it routinely. It's very safe in pregnancy. So even if we can save that one risk of thrombosis or embolism, I think it's worth it. So I would definitely treat significant COVID infections with low molecular weight heparin for sure.
Thank you very much. And
Piyush, please present the trophy to ma'am, and over to Dr. Dinkar Desai sir for the next very important panel discussion. I request Dr. Rishma Pai to kindly accept our token of appreciation, this virtual trophy, and I thank you very much for joining in and sharing your perspective and the important dimension in COVID, that is pregnancy and COVID. Thank you very much, ma'am. Dr. Desai, sir.
Thank you so much. Pleasure to be here. Thank you all.
Dr. Bhagyashree Ahirao.
Please mute everybody except Dr. Desai.
Dr. Bhagyashree Ahirao and Dr. Rajendra Kulkarni.
Yes.
Dr. Rajendra Kulkarni is the chairman of Action Committee, Maharashtra IMA, and Dr. Bhagyashree Ahirao is joint secretary of the Pathologist Association. She comes from Dhule. She is a practicing pathologist, and Dr. Rajendra is from Nashik. So please continue. Dr. Bhagyashree first.
Yes.
Okay. Thank you, sir. Very good morning to everybody. It is my pleasure and honor to introduce patron of our Dhule IMA, Dr. Gangakhedkar, sir. He is a renowned general and laparoscopic surgeon since last 32 years. Currently, he is a treasurer of World Medical Association, former president of SARS Medical Association, and past president, National IMA. He is also board member of NABH and MUHS. He has received numerous state and national awards till date. He has given voice to injustice towards doctors and defending their interest in this pandemic and also during his work period through various means of media. I welcome you, sir, to this panel discussion. Over to Dr. Rajendra Kulkarni, sir. Thank you.
Thank you, Dr. Bhagyashree, ma'am. I first congratulate Dr. Dinkar Desai for this wonderful conclave, and with regards to our treasurer, our leader, Dr. Gangakhedkar, sir, I take the privilege of welcoming another panelist of this panel discussion, Dr. Anil Pasnekar, sir. Dr. Anil Pasnekar was National Vice President of IMA. He was State IMA President also. He was President of IMA Mumbai. He has
mission Dharavi in the first wave of COVID-19 last year, the project due to which the spread of corona was curtailed very significantly in Dharavi, and this mission of his has been acclaimed internationally also. He's a very social person, having personal relations with many government officials and political leaders, which he always used for the benefit of the fraternity. A very joyful, ever smiling, and friend of the world. So I have a privilege to present to you Dr. Anil Pasnekar. Another panelist of today's panel discussion is Dr. Subhash Salunkhe, who is a president-elect of IMA Maharashtra State. He was secretary of IMA Maharashtra State. He is a senior general practitioner with experience of more than 4 decades. And he has gracefully retired from his practice to pursue his own passion of writing and reading and work of IMA. He was member of the executive committee of Maharashtra Medical Council. He is a prolific writer and very effective orator. Was member of Advertising Standards Council also. He is expert in legal and constitutional matters of IMA. So we have the chairpersons for this today's session. The first chairperson is Dr. Rajan Sancheti, sir. Welcome, sir. He is treasurer of IMA Pune. He's serving as RMO at Bharati Medical College Rural Health Training Center. He has pursued his medical education from Government Medical College of Miraj. He has worked as BTO extensively and has collected more than 80,000 blood bags in his tenure. He has received many awards for his philanthropic activities, and the recent one has been he was awarded Corona Warriors Award from none other than Governor of Maharashtra, Mr. Bhagat Singh Koshari. Another chairperson is Dr. Rajiv Agrawal, a pediatrician from Mira Bhayandar. He is director of Kasturi Medicare Private Limited. He is currently treasurer of IMA Maharashtra State. He is member of IMA Junior Doctors Network of Headquarters. He is CWC member and is convener of Financial Manual of IMA Headquarters. Welcome, Dr. Rajiv. Another chairperson is Dr. Dhiren Kalavadia, another pediatrician from Chembur. He was treasurer of IMA Maharashtra State last year. He is president of IMA Chembur and very active IMA leader. So I welcome all of you, and I request Dr. Rajan Sancheti, sir, to introduce the another panelist, none other than our national president, Dr. J. Jalan, sir. Over to you, Dr. Rajan, sir.
Thank you. This is a privilege, I would say, to be amidst about 3 Padmashrees are there, epidemiologists are there, and it is an honor to introduce our national president, Dr. J. Jailal. Sir is MS, a laparoscopic surgeon from Stanley Medical College, DLS, FICS, FHOM. Sir has also done MBA from Canada. Really, I would say, astounding and surprising. Sir is professor of surgery at Tirunelveli Medical College. So also national head of IMA UNESCO Bioethics Haifa, member of board of study TN Dr. MGR Medical University, honorary professor in academic medical college specialty. Sir has held a lot of position as a state president, Tamil Nadu Medical Association, council member of TN Nurses Midwife, Senate member of Tamil Nadu Medical University, Vice President of Commonwealth Medical Association, President of Rotary Marthandam, National Trustee Christian Medical Association of India. Sir has held position in various IMA association, member of various organizations, Minimal Access Surgery, Red Cross, and so many others. Has also been felicitated for many of the awards. Best award is Best Teachers from MGR University, also felicitated by Kanyakumari District Collector and Government of Tamil Nadu. Sir has, I would say, a lot of publications and again, one of the textbook of family medicine, 30 research work he has published, and main thing I would like to say that love your neighbor as you love yourself. A great saying from him. What I am today is gift of God. What I become tomorrow is gift to the society, gift to the world. So I introduce our beloved Dr. J.A. Jailal, President of IMA, another dynamic leader on his toes since the pandemic, I would say, started. So I request J.A. Jailal, our President, to come forth. Thank you, sir.
Thank you.
Thank you.
I
Thank you,
welcome all the
sir.
panelists.
Yes.
Dr. Jailal is busy in some other meeting, so he will be coming in short time. I welcome all the dignitaries in the panel discussion. Dr. Ravi sir, who is our World Medical Association Treasurer. Dr. Anil Pasnikar sir, he is ex-Senior Vice President of IMA Maharashtra State, and Dr. Subhash Salunkhe sir is President-elect for IMA Maharashtra State. I start with Dr. Subhash Salunkhe sir. You have worked for basically ethical practice, and most of the things is you have raised the voice for general practitioners and ethical general practice. So my question to you is, sir, how do we empower GPs to make them our formidable first line of defense in COVID fight?
Thank you, Dr. Dinkar Desai, for giving me this opportunity. National Health Scheme in UK, it is said that the family doctors are the gatekeepers of the expenditure on health of that country. In our country also,
Sir, you are little less audible.
Now can you hear me?
Yeah, properly.
So I said that in National Health Scheme of UK, family doctors are doing the role of gatekeepers, controlling the expenditure on health of that country. Now here also, we should take advantage of the family doctors and try to fight out this pandemic which has occurred after 100 years. As the learned speakers have all confessed that the modern medicine has no hesitation in saying that it's a new disease.
Not audible, sir. Not audible.
Can you?
Yeah, I can hear it. It is audible, sir.
Yeah.
I can hear it very properly.
So what I was saying was, pandemic which has come after 100 years, we should make use of the family doctors. And as all of us know, 80 to 85% patients are either symptomless or mildly symptomatic. So family doctors should be empowered and should be respected by the administrators and the politicians at large, and not trying to abuse them. The language which was used in the first wave was not acceptable to the medical fraternity. It was a sort of they were threatening that we will cancel your registration and whatnot. So anyway, coming to the management, first and foremost, I suppose, in this pandemic, a case of fever, unless proved otherwise, you should take it as COVID. You should have a high index of suspicion, and you should ask for basic tests and try and prove whether it is COVID or otherwise. If it is COVID, then you should try and assess the severity by making use of pulse oximeter, talking to the patient himself or herself, so that you can make out whether patient is breathless while talking to you, asking 2 questions to know the exact status of symptoms and trying to assess the signs. Accordingly, asking for questions using the 6-minute walk test to pick up cases which may turn out to be really problematic, going from mild to moderate or moderate to severe. So you should know what is your limitation in managing patients who are having mild symptoms at home by isolation, but you should not stretch yourself, and at a proper time with use of 6 minutes walk test, pulse, oxygen, pulse oximeter, trying to assess the respiration by talking to the patient by video call. We should have our antennas always raised, and at a proper time, patient should be referred to a proper center. That is all I would like to say. And making use of family doctors who are available in the Nimkar corner. Also, the IMA Maharashtra state has 45,000 members. We have 220 branches. So we are spread all over the length and breadth of Maharashtra. So it's my sincere request to the government officials to make use of this workforce in this pandemic. Thank you.
Surely, sir.
In fact, here I will say, like to say something that we are the general practitioners, are the primary healthcare workers of the society. So here, whether you are a allopathic, Ayurvedic, or anyone else practicing, but the thing is that the first patient is going to come to you, and then you are going to decide how to handle the patients. And on that basis, also our Chief Minister has started the Maza Doctor program all over the Maharashtra, and it is getting the huge support from all over the Maharashtra, because we are the primary healthcare workers. Patient is going to come to us with a good faith and all. Which information is going to impart with us is definitely not going to impart with the BMC or the state government doctors. And here our duty is that to guide them very properly, to reassure them that they are going to be all right, what kind of tests are needed, what kind of quarantine isolation is needed, and what kind of treatment they can follow it out and all. Now they can become the home quarantine and where they should be admitted in the hospital. So
in this regard, Dr. Anil sir, your name is taken very proudly for the Dharavi pattern for the last first wave, rather, you can say.
Yes, sir.
So, can you explain in little brief what was the Dharavi pattern and how you have succeeded?
कसं होतं की धारावी पॅटर्नला इम्पॉर्टन्स का आलं त्याच्या पाठची पार्श्वभूमी आपण समजून घेऊया की धारावी इज अ ह्यूजली पॉप्युलेटेड area in 2.5 kilometers of radius. 9 lakhs people are staying. It is as good as the population of the New York City, and at the same time they are very low socioeconomic, poor, little bit illiterate, but they are the business minded people. But the thing is that because of the low literacy, some hygienic problem always over there and all. So Pune, Mumbai and all over India, they are thinking it is just like the Anubomb. If it will get explode, whole Mumbai, Maharashtra and whole India will get under the waves of the Dharavi. So the Dharavi, the thing is that when the Dharavi is always irritated, it is always made a joke about the Dharavi, always tease about the Dharavi, always shows low respect and all. But when the people of the Dharavi get together and when the doctors, the police departments, the BMC, and with the help of the people, when they made a miracle, the whole world taken a setback. In fact, the Chief Minister, Mr. Uddhavji Thackeray, has appreciated myself, Dr. Anil Pashnekar and Dr. Shivkumar Uttare, openly in the forum, that the way this duo had done the work in the Dharavi, it is appreciable, commendable. He said that he has informed it to the Mr. Modi ji, our Prime Minister, and Modi ji said this pattern should not be limited to the Dharavi, but should not be limited to the Mumbai, Maharashtra, but it should be implemented all over the India. At the same time, the WHO has well appreciated the Dharavi pattern. So what is this Dharavi pattern? Dharavi pattern is nothing but the conglomerations of the efficient working by the primary healthcare workers, general practitioners, by the BMC and state governments help, by the help from the police departments to do the sanitary works to keep the law and order, and by the good cooperation from the layman's people of the Dharavi. Friends, when the Dharavi pattern, when the corona started from the December, January, February, 23rd March, first lockdown was there, and the first death occurred in Dharavi on the 3rd of April at the Baliga Nagar. The whole country has taken a setback. What will happen now? Dharavi started burning now. At that time, the Mr. Rahul Shewai, the member of parliament, has come to me and said, Pashnekar sir, we have to do something for the Dharavi. Only my clinic was open in Dharavi. Nobody was open in the Dharavi. I said, no problem, sir. We'll do it for the Dharavi. The thing is that I had said that we should take the help of the BMC also, because they knows the paraphernalia of the area. They have the manpower and all. So he said, what is your planning? Well, sir, we should select the areas, hotspots, and we will do the door-to-door survey over there. So he said, but sir, you are only the one doctor is working. I said, tomorrow morning, it was the 8th of the April, 5 o'clock. I said, tomorrow morning, 50 doctors will be there on the road. So Municipal Commissioner was there, Kiran Digavkar, and this one, Rahul Shewai, sir, Member of Parliament. They started laughing. They started looking at each other and started laughing. But on the 9th of the April morning, when they saw the 50 doctors on the road, on just my one call, they absolutely saluted me. What a capacity this person has. Miracle. Absolutely miracle. That not a single person was there on the road, not a single clinic was open, but Dr. Pashnekar sir has आह्वान केलं लोकांना की we have to work for the people of the Dharavi, and 50 doctors came out of their shell directly on the road to serve the Dharavi people and all. That was the greatness of my colleagues, that they have the faith on me. And Dr. Utture sir, as always, has joined me with as a big brother, as a great leader along with me. And then we started serving the 5 hotspots in Dharavi. That is the Baliga, that is a Muslim Nagar, Madina Nagar, Social Nagar, Mukund Nagar, and Kalyanwadi, Vaibhavwadi. And there we went door to door along with the BMC's nursing staff, BMC's the ASHA workers, BMC doctors. Here we started asking people, first of all, taken very surprised that the thing is that everyone is afraid, everyone is confused. Sorry, and this doctor, they are coming to our door to door to ask us, how are you? Are you having any cold fever? Are you having the history of the travel? Are you came in contact with the corona positive patients and all? People started feeling great and all, and on their own they come to give us the information that he is having cold fever. He has came from the Kerala, Kanyakumari, or Delhi, Hyderabad. This person was in contact with the corona positive patients and all. By this way, we have segregated 4,000 patients in a quarantine. Then we sent 483 people for the lab testings. Out of that, 20% came positive. Just see, in the first phase itself, we catch hold of this 20% positive people and we send them into the quarantine. Can you imagine if this 20% would have spread into the all over the Dharavi? What would have happened? It would have got burst like anything. And by catch holding of this 20% people, we saved literally Dharavi. And this is a success story of the Dharavi pattern. After this, Mr. Praveen Pardeshi, at that time, the BMC Commissioner, he appreciated us. Chief Minister Modi ji has appreciated us. Chief Minister Uddhav Thackeray has appreciated us. Modi ji has appreciated us. We got the praise from all over the world also. Friends, here we have to fight day and night with the administration also. When Praveen Pardeshi said that after that, this was the first phase. In the first phase to run with the COVID, this one PPE kit from the morning to evening, it was really a miracle. Means without drinking water, without urinations, without having a food, we used to work from 9 9 o'clock to 5 o'clock. And after that, people started getting maize crouching heat was there. The BMC people started fainting down. So BMC commissioner said that we will open all the clinics now, but the fewer patients should be sent to the BMC and the state government doctors only. No fewer patients should be seen into the private clinic. At that time, in the roundtable meeting, I put my foot down. I said, sir, sorry to say, but the 70% of the healthcare system is taken care by the private practitioners, and only 30% care is taken by the BMC and state governments. If you put the 100% load on them, they will collapse under the pressure, and you will not able to do the justice to stop the corona. Somehow he says what I am saying, and he said is there and there also. Yes, you can see the fewer patients. I said, sir, the thing is that the private practice, the people is having more faith on the private practitioners. They come with the faith, they come with the priority to their private practitioners, and they open up there very properly in front of the private practitioners, which they will not able to open up with the BMC or the state government doctors. And here, if we found that their symptoms are just like the corona, so we can guide them for the investigations, we can guide them for the quarantine, we can guide them for the isolation, and at the same time we can isolate the people around him for the quarantine. By this way, we'll be able to stop the spread of the corona very properly. Praveen Pardeshi has appreciated my views, and he said, yes, what you are saying is has a sense. Again, they said that only BMC and state governments can see the send the patient to the RT-PCR. I said, just after examining patients, if after examining the patient, if you don't have the rights to send for the RT-PCR, what is the use of the examining the patient? So he said, okay, we will get the things for the RT-PCR also. So by this, for each and everything, we will fight it out. That we want to see the patients, we can send the patient for the RT-PCR, we can send the patient for the quarantine, we can send the patient for the isolation. Here I appreciate by the way we have given the help to the BMC. BMC also has given very good help from them. They have given us the PPE kit, they have given us they have sanitized our clinics and all. They have given us the authority to send the patients for the RT-PCR test, quarantine, isolations. At the same time, we used to have a round-the-clock meeting at the BMC office and with the member of parliament, MLA, MPs and all were involved and all. Friends, after that, the third stage was there. In the third stage, the thing is that first stage was the door-to-door survey. Second stage was the seeing the patients in the clinic. Third stage was more important, that the public awareness programs. The public awareness programs, we have to taken the major task that in Dharavi, although the big towers are there now, 23 floor, 688 towers are there in Dharavi, but still 60% people are staying into the 10 by 10 room, where 10 to 12 people are there, and they have to use the public toilets. There are 45 public toilets. Each public toilet is having 10 to 12 rooms, and each public toilet is used by 1,200 to 1,500 people per day. So the chances of major spread was from this public toilet. So we use the Kerala model that before going to the toilet, wash your hands, legs with the soap, go to the toilet. After coming from the toilet, wash your hand, legs, and then go to your house. And after coming from toilet, the BMC and the fire brigade used to sanitize that toilets and all. So that this we done it for nearly 6 months regularly, and by this way we have stopped the spread and all, friends. But the major thing is that the public awareness programs from the clinic, from the police department, by using the drone, from the public systems, public audio systems and all. Here we used to explain the people what is this corona, how you get the infection of the corona, that nosocomial infection is there, so that you have to wear the mask. The virus is thick, it can't fly more than the 1 meter, so keep the 3 feet distance, social distancing. The virus touches the surface and sticks the surface. If you touch the surface and you will put the same hand in the nose and the throat, so nose and the face, then we will get the infection. So wash the hands, sanitize your hands. So we used to educate them very properly about how the things are happening and all. At the same time, you used to tell them that just see the lockdown is there, you are not moving out of the house, so indulge in your area of interest activities, dancing or karaoke or singing or the playing the games and some in your house itself, cards and all. Talk to the more part was the depression, so that you talk to your near and dear relatives, express yourself and all, and do the daily exercise, yoga, surya namaskar, something like that. That which will build up your immunity also, which build up your good health also, and you will have the positivity also. So that was going all the time around in this corona model. So I would like to say the successful Dharavi pattern is the conglomeration unity shown by the private medical practitioners of Dharavi area, the necessary helping hand given by the Member of Parliament Rahul Shewale, BMC, state government and police departments, but the cooperation given by the Dharavi people, although they are the laymen, but the thing is that they are very kind, cordial, cooperative, and they respect you like anything and all. Dharavi is not like, Dharavi is a real picture of the India. How you say we are a cosmopolitan. In Dharavi, there are people from the Kanyakumari to the Jammu and from the Arunachal Pradesh to the West Bengal. So you see the real picture of the India is in Dharavi. So thank you very much for patiently listening. I hope I have done the justice to my topic.
Yeah. Thank you very much, Dr. Anil. And like you also, we took leap from your book. And in Thane, we formed a Thane Rapid Action Corona team, and which has helped to TMC Corporation. And the contribution was 70% from our side and 30% from TMC. Now I request Dr. Wankhedkar sir. Dr. Ravi sir. Yeah. Welcome. And sir, please unmute yourself. Dr. Ravi sir.
Sir, please unmute yourself, sir.
Yeah.
Thank you, Dr. Dinkar Desai, the phalanx of the chairpersons, my fellow panelists, and I should really appreciate Dr. Desai for calling so many speakers and so many topics and trying to cramp in one day so that you are not able to give justice to single topic or single speaker. The only reason I am hanging because I know the role of pathologist, radiologist and anesthetist in the life of surgeon. And it is out of my respect and love out to pathologist I am hanging on to this seminar. Well, let me complete now. Listen, yes, I have been listening for the last 6 hours. This is no way. And let me also congratulate you for arranging a panel discussion without a heading of panel discussion. And having said this to all my fellow colleagues and doctors, just to be very, very brief, because I know we are already running 2 hours late. This pandemic, management of this pandemic, there are 2 aspects. One, it is bad science, bad politics and bad governance, whatever state we are into. And the second thing, as a physicians, may you be of any faculty, what is needed are the art of medicine, which plays more than the science of medicine. Because the science being a novel coronavirus, the science is still, we are also are learning. But then what is more important is the empathy, the communication skills, the ethicality. All these things come into play while managing this pandemic. And hence it is my humble request to be more ethical, to apply your scientific mind, use evidence-based medicine, not eminence-based medicine, and to develop good communication skills and have empathy in this time of crisis. Thank you. Jai Hind, Jai IMA.
Sir, I have some questions for you. Hello, sir.
Sorry, Dr. Desai. I've been waiting long. Wish
Sir,
you all the best.
I am extremely sorry, sir, but I want to hear from you. You said some time back. Okay. So we conclude with this panel discussion and we move on to next panel discussion. Chairman, sir.
So Desai sir, we'll have to take Dr. Pradeep Uppal's lecture. I call upon the Dr. Jayesh Boricha to kindly introduce Dr. Pradeep Uppal. Dr. Jayesh Boricha.
Thank you, Vedhas. It's an honor to introduce Dr. Pradeep Uppal sir. He is a director and the head of a department, ENT department of Jupiter Hospital. He was a Mumbai University topper as well as a gold medalist in all ENT exams like DORL, MS and DNB medicine. He is a pioneer and having a largest series of cochlear implant in the region, and he external ENT section of Atlas of Pediatric Infection Diseases. As well as I call upon panel chairperson Dr. G.B. Kulkarni as well as Dr. R.R. Marandani. Both of them are ENT specialists. Over to Dr. Pradeep Uppal sir.
Yeah. Wait, can I get my screen? Hello, am I audible?
Yeah, you are audible. Yeah.
Okay. I'm just sharing a screen.
बरं ठीक आहे आणि what about Shrikant?
Desai sir, can I start?
Yeah, surely.
Okay. Good afternoon, everyone. At the onset, I would like to thank Dr. Desai and the whole organizing team for giving this wonderful opportunity. I'm going to talk about mucormycosis. My talk will be in a two-part. The first part will try to decode mucormycosis and try to see why it is so devastating. And second part, I'll invite you to a guided tour on how we tackle a case of mucormycosis. Friends, mucormycosis is caused by the fungus, and this mucor spores is everywhere. For all you know, when you're listening to me, you might be inhaling some mucor spores, but nothing to worry. These spores will go from the nose, and from the nose, it travels into nasopharynx and into the gut. In healthy person, there's no problem at all. But in immunocompromised patient, in diabetic patient, these people are prone to mucormycosis. Mucormycosis has always existed. Only we started talking now because there's a sudden spurt in a second wave. This is a paper from my alma mater, Sion Hospital. The point to stress is in 2017, they have presented 17 cases of mucormycosis. The point to stress is mucor was always there and it will be there. If you see mucor, it can affect any part of the body, but today we are going to talk about rhinocerebral and rhino-orbital cerebral mucormycosis. Patient who has a diabetes, who gets a COVID infection and is treated with corticosteroid and immunomodulator is very, very prone to get mucormycosis. Stressing on this 3 point, we should not forget these patients with organ transplant and hematological malignancies. They too are very, very prone to this mucormycosis. Now, question is why there is a sudden spurt of mucormycosis? What is the difference? In wave 1, patient was diabetic, patient had a COVID, treated with steroid, and same thing in the wave 2. So why there is a sudden thing? We don't have a very strong evidence-based data, but it's general belief that maybe we have used steroid very liberally. In a first wave, the treatment wasn't standardized, so people were reluctant to use steroid. But in the second wave, almost every patient was given steroid without monitoring. Many times, patients who were at home, they couldn't monitor their sugar. Second, more important is this new mutant strain of COVID, especially in Maharashtra, which has been named as 617.2, which is more invasive and more transmissible. Maybe this is the reason why we are getting mucor. If you understand a person, mucor is there everywhere. It is not affecting us because the immunity is good. Person who's diabetic, if he gets COVID, his immunity goes down. And if he's treated with corticosteroid or immunomodulator, the immunity goes severely down. And this corticosteroid acts like a fuel in a fire. And these patients are very, very prone. Second thing is if they get diabetic ketoacidosis, the mucor become very virulent. Mucor flourishes on this iron in the serum. In normal people, there is no free iron in the serum. So the mortality is very, very high. Why mortality is high? Because this infection starts in the nose, and the nose shares a common boundary with the eye and the brain. You'll be surprised to know that the wall between the eye and the nose and eye and the brain is as thin as the cover of the book. That means it is 0.5 millimeter. So it easily travels to the neighboring area. And plus, don't forget, the new strain has created a path for them. New strain has an ability to damage the epithelium. So the mucor gets ready-made. The normal mucor, which was in the air, now goes in the body. It flourishes because of this COVID, and then it invades the deeper structure because this strain has created a path for it. And second important way of the spread is angio invasion. What I mean by that is this mucor invades the blood vessel, blocks the arterioles, causes infarct, the gangrene is formed, and this is what we see as a black crust. Now, where it goes, it's up to mucor. It may go to the orbit or it may go to the brain, and accordingly we name it rhino-orbital or rhino-cerebral. As far as the management is concerned, one point we have to understand that mucor is a medical disease to be treated with antifungal treatment as soon as possible. But the area where amphotericin cannot reach has to be removed radically. As I've told you, in angio invasion, the arteriole gets blocked. When the arteriole gets blocked, the amphotericin cannot reach. If the blood cannot reach, how can amphotericin will reach? So this part has to be radically debrided. Extensive debridement is the key. Now, I've told you the basics about the mucor. I'll invite you to come and walk through with me and see how we manage a case of mucor. In an outpatient department, a 40-year-old patient visits in OPD with the classical symptoms of sinusitis. Pre-COVID era, you don't require anything. Within a second, the patient would have been diagnosed as sinusitis and put on a treatment. But today, on further history taking, you see the red flags. There's a history of COVID, diabetes, and patient taking a steroid. Immediately, a provisional diagnosis is switched to mucormycosis. The point to stress is the symptom of mucormycosis exactly the same a symptom of sinusitis. So in a sinusitis symptom, if you see this red flag, please think of mucormycosis. Now, the moment you suspect there's a mucormycosis, without any delay, we put an endoscope in OPD only and see, oh, we saw the black crust. I'm sure you are able to see this black crust, but we have to prove that this is a mucor. So what we do is immediately collect in this container and send to our microbiology department. Microbiologist mounts on a potassium hydroxide, sees under the microscope, and the diagnosis is confirmed. They used to give us the diagnosis in less than half an hour, 30 minutes, 20 minutes. I just spoke to microbiologists at how so easily you are giving us a quick diagnosis. They said it's very, very easy. This hyphae are typically brown like a ribbon. They are irregularly branched, and septae are far and few. In the textbooks, mucor is called as a lid lifter. What does that mean? When the microbiologists used to grow this mucor in a petri dish, next day morning when they go, the lid has been lifted up because the mucor grows in such a tremendous amount that it lifts the lid. Now, most of these patients has comorbidity. They cannot come to the OPD. Now, case which I've shown you was an OPD. Now, this patient was a diabetic, has a kidney problem, has other lot of problem, cannot come. So we cannot wait. If you wait for them to walk and come to the OPD, the mucor have already invaded into the orbit and into the brain. So almost most of the ENT surgeon have this. Bedside, we do nasal endoscopy. We can see the clear fungus. It's collected and sent for, again, smear to the microbiology department. Now, once the mucor is confirmed, now it is a teamwork is of paramount importance. I'll once again say it's a teamwork. All the people mentioned on this list are very, very important. As soon as the patient is told about it, the next steps are very critical. We have a set protocol. Immediately patient is admitted, imaging is done. ID specialist starts antifungal depending on the patient's general condition. Anesthetist sees how fast we can make the patient fit. If blood thinner, it is stopped and patient is posted for radical debridement. But before we do this, always and always we call a multidisciplinary meeting with the patient and a family, explaining them in depth about what we are planning, what we are contemplating, what is going to be the outcome. This is perhaps one of the most important part of mucor management. We sit with the radiologist and see the CT scan and MRI. The MRI with the contrast is a gold standard test. What is the principle? Principle is you give a dye. Now this dye will reach every part of the body, including the nose, which has a blood supply. Some area where there is an angio invasion, where there is an infarct, where there is a necrosis, this blood will never reach, so the dye won't reach. So if the dye is not reaching, that means the amphotericin will never reach. So this wide area we have to excise. How wide, how big, we discuss with the radiologist, mark on a console and imprint in our mind so that in operation theater, we are going to remove that. In operation theater, we use a HD camera and monitor and go and remove it. We remove till every bit. How deep we have to go, one, the radiologist has told us, and second, on table, we decide wherever the fungus is going. Important point is the first surgery is the best chance. So we have to be radical. To make you understand what you do, I want you to see this coronal CT scan. These are the two eyes, the nose and the brain, and all the gray area is a disease and the black is normal. To make you more understand, this is a normal CT scan, two eyes, nose, and whatever black thing we see is a sinus. This is what we want to achieve. So what we do, we put an endoscope, open the mouth of the maxillary sinus, remove the diseases wherever in the roof. And when we remove this disease, at this stage, almost every ENT surgeon, if he's junior, is scared. If he's a senior, he's careful. Why so? Because if you see, there's a very thin bone between the brain and the nose. So there is a chance that while removing this disease, we may enter the brain and cause CSF leak, or we may...
So a little fast.
I cannot go fast. I'll take my own 14 minutes. I won't take much time. I will take all time which has been given to me. If you want, I can stop it. So once we remove this thing, all the disease is removed. But the important point is, we have to see the sinus later on. We have to see the sinus whether recurrence is there or no. For that, we remove this part of the disease. Now, whenever there's a danger area, we use this navigation system. There's a beautiful system which tells us what lies beneath. Just like a navigation tells you what is there, whether there's a traffic jam, what is there, image guided tells us how to go about. Post-operatively, we put an endoscope and see every 10 days. If there is a crust formation, then we ask for, again, imaging. Unfortunately, many times patients come very late and endoscopic debridement is not possible. So here the head and neck and onco neurosurgeon play a big role. Now, this is a case who couldn't pursue a treatment for different reasons. We have done a good surgery, but post-op, she said, I want to go home. She didn't take amphotericin C properly. After 15 days when she came, the fungus has invaded in the brain. The point to stress is the medical treatment of amphotericin is very, very important even after this. There are some good patients. It was 2 years back operated, though disfigured, was living a very healthy life. So if you do a complete treatment and proper amphotericin, it will be good. Now, this patient was referred to us just 8 days, 10 days back with a mucor. I've never seen such kind of mucor. Generally, it spreads like a carpet type. The whole skin becomes black. Now there's a burr hole in it. So we sent the swab. It came negative. We took a deep biopsy. And what is showing is some skin infection. So remember, don't get too carried away. All that black is not mucor. To summarize, mucormycosis is difficult to treat. The good team is essential. Treatment is extremely expensive. And how long treatment will last and how many repeat surgeries, there's no clear answer. But just remember, only way we can reduce the mortality is by treating early, and only way we can treat early is by diagnosing early, and only way we can diagnose early is by examining the nose often. The last slide, take-home message for the high-risk patient. For ENT, please do nasal endoscopy as soon as possible, even if it's a bedside. Radical excision is needed, and this kind of surgery has to preferably done in an institute where the other faculty is there. For treating physician, before discharging the patient, make it a point to get the nose examined. If you're suspecting mucor and sending to your ENT colleague, please stop the blood thinner and obviously steroid to be used judicially. All the patient you explain that after the COVID, you see after the COVID patient is little euphoric. They feel they've conquered. They forget, they lower their guard. So you tell them if there's a nasal blockage, discharge, or facial pain or eye, please report to the doctor. And most important thing, why mucor is occurring is perhaps poor hygiene after the COVID. So they have to do a nasal irrigation. They have to keep their oral hygiene good and keep their blood sugar in control. Thank you very much for your patient hearing.
Thank you, Dr. Uppal sir, for that wonderful presentation and all those pictures from your practice which you have included that make it more interesting and more informative, sir.
Thank you. Thank you.
It's really exhaustive and really nice. I would like to request Piyush to present Dr. Uppal sir with a memento, virtual memento, in appreciation of his help.
Thank you. Thank you very much.
On behalf of Pathologist Association, sir, we are grateful to you.
Thank you, Dr. Desai. Sorry, I couldn't cut it in between.
For a preparation which you have made in very short time. Thank you very much. Yeah.
I would like to request Dr. Supriya Chinchorkar to please come and introduce our esteemed panelists for our policymakers panel discussion, which is coming up. Over to you, Dr. Supriya Chinchorkar.
Thank you so much, Dr. Vedhas. Good afternoon, friends. It's been an amazing session since the morning, and I guess lunchtime in and around, but interesting panel discussion right now. So I think I would like all of you to please draw your attention to this important panel. It gives me great pleasure to introduce the very important speakers here today. We have with us Padmashree Dr. Raman Gangakhedkar. He is an eminent scientist and he served as the head of Epidemiology and Communicable Diseases Division of the ICMR Delhi at the beginning of the COVID pandemic. He previously served as the director of the National AIDS Research Institute, that is known as NARI, in Pune. He was awarded the prestigious Padmashree Award in 2020 for his unmatched work in the field of HIV and AIDS. It's a great honor, sir, to have you here with us today. I also take pleasure in inviting Dr. Subhash Salunkhe ji. He is the advisor to the Maharashtra government for the COVID and the former Director General of Health Services, Government of Maharashtra. He is an expert in public health with over 3 decades of experience, and he serves as the Senior Advisor of Public Health Foundation of India, also known as PHFI, and the Director at the IIPH Bhubaneswar. Another eminent panelist we have here today is Dr. Sudha Rao. She is a renowned pediatric endocrinologist and the head of department at the Wadia Hospital, Mumbai. She has been in charge of the pediatric COVID department at the Wadia Hospital for over 1 year now. And to have this panel discussion, may I call upon our esteemed chairpersons for today. It is a proud privilege to invite all the past presidents of IMA Thane today here, Senior Cardiologist Dr. Anil Tambe, Senior Cardiologist Dr. B.K. Mahavarkar, Senior Pediatrician Dr. Avinash Wagle, and along with them, may I invite the President of AMC, Dr. Professor Sushmita Bhattnagar. Over to you all, sir and madam. Thank you so much.
At the onset, I would like to ask Dr. Raman Gangakhedkar, sir. He's an eminent epidemiologist and a scientist. Sir, if you could briefly tell us what all factors have really led to this explosive current wave.
I think.
Piyush, please mute everybody except Gangakhedkar, sir.
नाही ते चालू नाहीये अजून सुरू व्हायचंय.
Piyush, please mute everybody except Gangakhedkar, sir.
Of all things that we have to remember is the vulnerability got exaggerated mainly because people came out of their own households who were unexposed due to various reasons which were super spreading events. The super spreading events of like Gram Panchayat election that took place in Vidarbha. Then you see the festival season that came, the weddings that came. They were perhaps far more important in terms of structural issues that were existent. The complacency played its own. So people, even if they were infected, if some of them were mild, especially among those when the lockdown was getting lifted, the schools and colleges were open, and therefore perhaps you saw some asymptomatic infections occurring. The infections entered houses, and a household always has a enhanced vulnerability because you won't have safe distancing, you won't have COVID appropriate behavior, and you have a family tradition of eating together. When everybody would be without masks, it got exaggerated. Now people tend to talk about variants as often, but unfortunately these are speculative issues because there is no evidence to suggest so far, beyond in-lab evidence if it is there, that the transmission efficiency is increased of these variants as such, but it needs to be shown robustly into a human cohort, which is yet to happen, though you can't deny that variants may also be responsible for spread that occurred, but you would perhaps think that it is COVID appropriate behavior which became most important issue in terms of non-adherence to it and the infection spread in an explosive manner.
Yes, sir. Sir, I remember having read your interview where you had speculated long before, I guess in the month of January, if I'm not mistaken, that this second wave, when it comes, it's going to be explosive and it's going to be far more lethal, and large number of patients are going to get infected than the first wave. So from the epidemiological point of view and from the vast experience that you have, what really can be done so that this so-called future third wave or the next waves, fourth, fifth and sixth waves, can they be prevented? So can you please briefly guide us what exactly can we do now?
One thing is we will have to tell people to adhere to COVID appropriate behavior. COVID appropriate behaviors are not going to go for next couple of years time unless we have a very effective drug that becomes available, which can perhaps ensure that it is a potent antiviral and there is no more a threat to life. Second issue is perhaps a very potent vaccine which could come, but apparently the way variants are coming up, perhaps such a vaccine would continue to be a issue which could get delayed in terms of its discoveries, or the challenge would be that you will perhaps be something like a mirage where you chase the herd immunity mainly because the variants are emerging. So essentially it is COVID appropriate behavior, whether it is variant, whether it is vaccine that you are getting, perhaps it has far more protective action compared to rest of the issues. The second issue that we need to remember is we need to rapidly immunize the population. We need to go by age prioritization because you want to minimize hospitalization so that you can not only reduce the mortality and morbidity due to it, but also ensure that the more asymptomatic population does not come to the hospital for vaccination, and vaccine sites itself vaccination sites becoming super spreaders, which could affect the entire health outcomes in a very difficult manner. So essentially, you saturate the population, 45 years plus population first, then you go to 18 years plus population, knowing fully well that not only the vaccine efficacy is low in younger population because they are going to get mild and asymptomatic infections, so indirect effect is also going to be lesser to break the chain of transmission, but also that if the variants are coming up, they are lowering the efficacy of vaccine. So it could pose dual challenges to my mind. Third thing is we need to prepare our systems, and especially the primary healthcare systems, because you need to recognize that these waves so far had been more urban and phenomena, which is now changing because of vulnerabilities that exist in the rural area. So we need to ensure that we will be able to provide healthcare to those who live in the rural population. Third thing which I would say is people are speculating more about third wave. To my mind, third wave will require a longer interval between second and third wave compared to first and second wave, the way we got it. However, this is a time that you are going to get to utilize the best way for preparing your healthcare infrastructure. And what is most important is you should be able to vaccinate people rapidly during this particular period and finish the task of saturation. If that is not going to happen, and if the outbreak continues to be active, then in those cases you might see a newer variant coming in, which could challenge the development of third wave. It could make it early, and even the peak could be very high. So it's all up to us, basically at individual level. If you mobilize the community and ensure that COVID appropriate behavior adherence is intensified, we will still be able to make a huge difference to my mind. But we need to be prepared for the way people are thinking as of now, that if the third wave becomes very difficult to handle, we need to prepare our healthcare infrastructure to mitigate the impact on health systems.
Thank you so much, sir, for that perspective. You have addressed this very important issue because a lot of people keep asking that why vaccination not be denied.
Dr. Vedhas, 1 minute, please.
आदरणीय पालकमंत्री जॉईन झालेले आहेत.
डॉक्टर आपले पालकमंत्री ठाण्याचे डॉक्टर श्री एकनाथजी शिंदे, आम्ही तुम्हाला आता डॉक्टरच म्हणून टाकतोय कारण तुम्ही माझे आरोग्यमंत्री आहात आणि आम्हाला आता आमच्यापेक्षा तुम्हाला त्यातली सखोल जास्त माहिती झाली आहे. त्यामुळे मी आपलं प्रथम स्वागत करतो. आणखीन डॉक्टर जयलाल, नॅशनल प्रेसिडेंट ऑफ IMA, हे आपल्या इथे पुन्हा स्थानापन्न झालेत. खूप वेळ सर वाट पाहत होते, परंतु आमचे लेक्चर्स अननेसेसरी सारखी प्रोलॉंग होतात आणि टॉपिक्स ते एवढे आहेत. शिंदे साहेब, आम्ही सकाळपासून हा सत्र चालू केले आहे, ते संध्याकाळपर्यंत चालणार आहे आणि व्हायरॉलॉजी पासून पॅथॉलॉजी, रेडिओलॉजी पासून पीडियाट्रिक, गायनेकॉलॉजी, इतक्या सगळ्या ब्रँचेस मध्ये ENT, आता म्युकर मायकोसिसवर आपण लेक्चर ऐकलं उपल सरांचं, त्या सगळ्या विषयावर आणि शिवाय मग IMA ऑर्गनायझेशनचे रोल, या सगळ्याच गोष्टीमध्ये पीडियाट्रिक्सचा आता नवीन वेळ येणार आहे, त्यातल्या डॉक्टर सुधाराव आता आपल्या बरोबर आहेत. या सगळ्यांच्या रमण गंगाखेडकर सर हे आहेत तिथे, ICMR चे माजी अध्यक्ष आहेत. आणखीन त्यांचा एपिडेमिओलॉजीचा चांगला अभ्यास आहे. तसे सगळेच टॉप लोक आहेत. सकाळी शशांक जोशी सर, आणखीन उदवाडिया सर, ललित संखे सर हे आपल्याला ऍड्रेस करून गेले. तर या विषयात एक 5 मिनिटं प्रथम आपण शिंदे सर बोलतील आणि त्याच्यानंतर जयलाल सर आम्हाला थोडा ऍड्रेस करतील अशी मी विनंती करतो.
आता सुरू आहे ना देसाई सर, आता याच्यामध्ये तुमचं पॅनल डिस्कशन सुरू आहे सकाळपासून. आता मी
पण पॅनलिस्ट आहात.
मी आता गंगाखेडकर सरांना ऐकत होतो आणि अशी मोठी माणसं सगळी आज सकाळपासून मार्गदर्शन करतायत आणि मी आपल्या सगळ्यांच मनापासून या ठिकाणी आपलं स्वागत करतो. मी आत्ताच मगाशी CM साहेबांच्या बरोबर VC वर मी होतो. काल देखील डॉक्टर आशिष भूमकर आणि त्यांची टीम होती, बाकी शशांक जोशी, राहुल पंडित सगळेच होते. नवीन जो म्युकर मायकोसिस जो आहे तो आपल्याला एक नवीन प्रादुर्भाव, नवीन जे काही संकट आहे त्या बाबतीमध्ये त्यांनी त्यांच्या कालच्या सेशनमध्ये लाईव्ह सर्जरी देखील केल्या, त्या देखील मी पाहिल्या. आणि जे काही आता हे कोविडचं संकट गेले वर्षभरापासून आपण सगळेजण अनुभवतोय आणि आपण सगळ्याच प्रकारे सगळ्याच पद्धतीने हे कोविडचं संकट कमी कसं होईल या दृष्टीने प्रयत्न करतायत. मुख्यमंत्री महोदय देखील त्यांनी देखील टास्क फोर्स तयार केला आहे. आपल्या सगळ्यांचं मार्गदर्शन सातत्याने राज्याला मिळतंय आणि जे ट्रीटमेंट करतायत डॉक्टर्स त्यांना प्रोटोकॉल आणि गाईडलाईन म्हणजे आता स्टिरॉइड, रेमडेसिवीर, आणखी इतर टॉस्लिझुमाब, इतर जी काही मेडिसिन्स आहेत ही कशा प्रकारची वापरायची हे शेवटी तुम्ही सांगताय. तुम्ही सगळं प्रोटोकॉल आणि गाईडलाईन आपण देताय. त्यामुळेच हे जे काही सुरुवातीच्या काळात जे काही समज गैरसमज आणि ट्रीटमेंट होती त्याच्यामध्ये लाईन ऑफ ट्रीटमेंटमध्ये जे काही डिफरन्सेस होते ते आपल्याला अनुभव त्याचे आपण घेतले. त्याच्यामध्ये सुरुवातीला काही लोक डेथ रेट सुरुवातीला जास्त होता. मग ते आपण अशाच या पॅनल डिस्कशनमुळे त्यांना कळलं की बाबा कुठलं औषध माइल्ड टू मॉडरेट, मॉडरेट टू सिव्हिअर ह्या सगळ्या ज्या काही आजारांना पेशंटला मग कुठल्या औषधं द्यायची, कुठली औषधं कुणाला पायाला लागू होत आहेत, ह्या सगळ्या गोष्टी ज्या आहेत हे तुम्ही सगळे जे तज्ञ डॉक्टर्स आहात या सगळ्यांच्या मार्गदर्शनामुळे आपण पहिली जी लाट आली त्याच्यामध्ये सुरुवातीला तर एवढी परिस्थिती गंभीर होती मधल्या काळामध्ये की बेडच मिळत नव्हते. ऑक्सिजनचा आपल्याला नंतर थोडा प्रॉब्लेम झाला. औषधांचा तुटवडा, रेमडेसिवीरचा तुटवडा जाणवला की त्यावेळेस देखील सगळेच म्हणजे रेमडेसिवीरसाठी सगळे वेड्यासारखे पेशंटचे नातेवाईक फिरत होते. नंतर मग आपण तो प्रोटोकॉल आणि गाईडलाईन त्यांना ट्रीटमेंट करणाऱ्या डॉक्टरांना दिल्यानंतर मग ते कुणाला द्यायचं, कुठल्या वेळेत द्यायचं, कधी द्यायचं, त्याचा परिणाम कुठे चांगला होऊ शकतो हे सगळं मी डॉक्टर नाहीये पण घरी डॉक्टर असल्यामुळे श्रीकांत त्यामुळे काही गोष्टी मला तो सांगत असतो आणि अशा प्रकारच्या तुमच्या VC-द्वारे जे काही डिस्कशन मध्ये काही गोष्टी ऐकतोय मी.
आजच्या बैठकीमध्ये साहेब सकाळपासून जी चर्चासत्र चालू आहे त्याच्यामध्ये जी पूर्वीच्या काळामध्ये जी औषधं वापरली गेली होती ती सगळीच निरुपयोगी आहेत अशा पद्धतीचं एक निवेदन झालंय आणि आम्ही टास्क फोर्सला अशी सूचना केली आहे. म्हणजे प्लाझ्मा देण्याबद्दल सुद्धा नकारात्मक आहे दृष्टिकोन. रेमडेसिवीरचा तर अत्यंत अल्प स्वरूपाचा वापर आहे आणि पूर्वीची जी हायड्रॉक्सिक्लोरोक्विनोलिन, आणखीन आयबरमेक्टिन, फॅव्हिपिराविर ही सगळी जी औषधं दिली जात होती, अझिथ्रोमायसिन वगैरे, ही सुद्धा निरुपयोगी आहेत असं आताच्या शास्त्रीय बैठकीमध्ये टास्क फोर्सच्या कमिटीच्या सगळ्याच जवळजवळ सदस्यांनी अधोरेखित केलं. पण त्या लोकांचं जे विधान आहे त्याला थोडीशी शासकीय स्वरूपाची मान्यता देऊन हे सर्क्युलर करून सगळ्या डॉक्टरांच्या पर्यंत हे पोहोचेल की ही औषधं आता फारशी वापरू नका. इव्हन टॉस्लिझुमाब हे सुद्धा औषध खूप घातक ठरतंय अशा पद्धतीचा निष्कर्ष इथं निघाला. तर आपल्याला
याच्यामध्ये अधिकृतपणे मी काही मला बोलू इच्छित नाही. शेवटी तुम्ही ट्रीटमेंट तुम्ही करताय, तुम्हाला आलेले अनुभव तुम्ही सांगताय आणि आजच्या पॅनल डिस्कशन मध्ये देखील आपण ते व्यक्त केले असतील. यामध्ये एवढंच आहे की जे आपलं स्टेट लेवलचं टास्क फोर्स आहे ते देखील आपल्याला वेळोवेळी या तुम्हाला देखील शशांक जोशी आणि जॉईन झाले असतील सकाळी. आणि याच्यामध्ये एवढंच आहे की आता आपल्याला गेल्या वर्षभराचा जो अनुभव आलेला आहे यामधून आपण खूप काही शिकलेलो आहोत. त्यामुळे डेथ रेट कमी करणे, रिकव्हरी रेट वाढवणे यावर आपला फोकस सगळ्यांचा तुमचाही आहे. आणि प्रत्येक डॉक्टरकडे जो कोणी पेशंट जातो तो पेशंट बरा झाला पाहिजे हीच भावना तुमच्या सगळ्या डॉक्टरांची असते. त्यामुळे या बाबतीमध्ये जो काही प्रोटोकॉल आहे, कुठली औषधं वापरायची कुठली नाही वापरायची ते आपण सगळे तज्ञ आहात. त्यामुळे नक्कीच आपण ठरवाल त्याप्रमाणे आपण त्याची लाईन ऑफ ऍक्शन मी CM साहेबांना देखील या बाबतीमध्ये सांगू शकतो. पण एवढंच आहे की आता जी काही तिसरी वेळ, जी काही तिसरी लाट जी काही आपण सगळ्यांनी अंदाज व्यक्त केलेला आहे त्याच्यामध्ये लहान मुलांना जास्ती मोठ्या प्रमाणावर बाधा होऊ शकते अशा प्रकारचं जे काही निदान काढलेलं आहे. त्यामुळे राज्य स्तरावर देखील आणि मी आपल्या MMR क्षेत्रामध्ये देखील सगळ्यात महापालिका आणि सगळ्यांना सांगितलंय, अगदी प्रायव्हेट जे आपले हॉस्पिटल्स आहेत त्यांना देखील की बाबा आपलं पिडियाट्रिक वॉर्ड आणि पिडियाट्रिक वॉर्डसाठी आणि मुलांसाठी लागणारी जी काही यंत्र, इक्विपमेंट, ज्या काही गोष्टी आहेत त्या आपल्याला सज्ज अलर्ट राहण्याची आवश्यकता आहे. या बाबतीमध्ये देखील आम्ही सुरुवात ठाण्यामध्ये केलेली आहे. मुख्यमंत्री महोदयांनी त्या बाबतीमध्ये सर्वांनाच सूचना दिलेल्या आहेत, निर्देश दिलेले आहेत की लहान मुलांना जेव्हा कोविड पॉझिटिव्हची बाधा होते त्यावेळेस नक्कीच त्यांचे पॅरेंट्स जे आहेत हे पॅनिक सिच्युएशन मोठ्या प्रमाणावर तयार होते. त्यामुळे आपल्याला त्याची देखील तयारी या ठिकाणी आपण सगळेजण करतो आहोत. म्युकोरमायकोसिसच्या बाबतीमध्ये देखील मगाच्या सेशनमध्ये मुख्यमंत्री महोदयांच्या ती देखील चर्चा झाली. शुगरचं प्रमाण वाढल्यानंतर त्याचं काय ते स्टेरॉइड दिल्यामुळे किंवा आणखी काही कारणं असू शकतील, परंतु त्याच्यात डॉक्टर भूमकर आणि उपकल्पन आपले ENT सर्जन आहेत यांनाही माहिती आहे आणि त्यांनी देखील कालच्या सेशनमध्ये सांगितलं की शुगरचं प्रमाण वाढल्यामुळे हा जो काही आजार होतोय, मग ते रक्तातलं जे काही आयनचं प्रमाण आहे, हिमोग्लोबिन मधलं फ्री आयनचं, ह्या सगळ्या ज्या काही बाबी आहेत ह्या टेक्निकल आणि आपल्या सगळ्या आपल्या क्षेत्राशी म्हणजे मेडिकल फील्डशी सगळ्या ज्या काही जुळलेल्या आहेत, या बाबतीमध्ये देखील हा म्युकोरमायकोसिस हा आजार जो आहे त्याच्यानंतर तो ब्लॅक फंगस काळी बुरशीमुळे होतोय, मग तो नाकावाटे डोळ्यावाटे मेंदूमध्ये जातोय. या सगळ्या गोष्टी आपल्याला सगळ्या माहित आहेत आणि म्हणून एक नवीन आपल्याकडे चॅलेंज येत आहेत आपल्या समोर आणि त्याचा मुकाबला आपल्याला सगळ्यांना मिळून करायचा आहे आणि तुम्ही ते अगदी करताय. खऱ्या अर्थाने अशा या कोविडच्या संकटामध्ये दुसरी लाट आपली आली आहे. आता काही प्रमाणामध्ये नंबर्स थोडे खाली येत आहेत, ही चांगली बाब आहे, परंतु तरी सुद्धा आपल्याला गाफील राहून चालणार नाही. आपल्याला आम्ही तर कॉर्पोरेशन लेवलला, काउन्सिल लेवलला मोठ्या प्रमाणावर फील्ड हॉस्पिटल, कोविड सेंटर, त्याच्यामध्ये CCC असेल, DCH असेल, ICU असतील, या सगळ्यावर आम्ही काम करतोय. परंतु शेवटी किती सगळं काही केलं, आम्ही यंत्रणा मोठी उभी केली, सगळं मोठ्या हजार 2,000 बेडची आम्ही मोठ्या फॅसिलिटीज उभ्या केल्या. शेवटी हे सगळं केलं तरी शेवटी डॉक्टर हा सगळ्यात महत्वाचा भाग आहे आणि त्यामुळे तुमचा रोल जो आहे अतिशय महत्वाचा आहे. मी तर डॉक्टरला देवासमान मानतो. तुम्ही खऱ्या अर्थाने देवदूत आहात सगळे, असं म्हटलं तर ते वावगं ठरणार नाही, कारण शेवटी तुम्ही रात्रंदिवस या कोविडमध्ये काम करताय. हे पॅन्डेमिक जे आहे हे आपल्याला अनपेक्षित होता, हे जे काही संकट आहे, आणि तुम्ही सगळं म्हणजे कितीतरी डॉक्टर्स त्याच्यामध्ये बाधित झाले आणि कुठलंही आपल्या कौटुंबाचा विचार न करता झोकून देऊन तुम्ही काम करता. आम्हाला देखील सुरुवातीच्या काळात आणि आता सेकंड वेव्ह मध्ये पण पहाटे 3 वाजता, 3:30 वाजता, 4 वाजता देखील पेशंटच्या नातेवाईकांचे फोन यायचे आणि आम्ही डॉक्टरांना देखील फोन करायचो, पण डॉक्टर ते फोन रिसीव्ह करायचे. एवढी म्हणजे हे मोठं खऱ्या अर्थाने आपलं योगदान मोठं आहे आणि आपल्या सगळ्यांच्यामुळे जे काही रुग्णांचे प्राण वाचतायत याला आपण सगळेजण कारणीभूत आहात. त्यामुळे सरकारच्या वतीने जे काही आवश्यक बाबी ज्या लागतील त्या नक्कीच आम्ही आपल्या सोबत आहोत. जेव्हा अशा पॅनल डिस्कशन मधून आपल्याला जे काही नवीन ट्रीटमेंटचे आपल्याला काही विषय येतील, लाईन ऑफ ट्रीटमेंट म्हणजे त्यामध्ये जे काही नवीन आपल्याला करता येऊ शकेल, जेणेकरून कुठलंही आव्हान नवीन आलं. आता नवीन स्ट्रेन येत आहेत, मल्टी व्हेरियंट हे झालंय, म्युटेशन मध्ये गेलाय आणि त्यामुळे सुरुवातीचे जे सिम्पटम होते आता बदलले. सुरुवातीला फक्त ताप यायचा, हेडेक व्हायचा, आता माणसाला पोटात दुखतंय, डिसेंट्री होते, अनेक डोळे दुखतायत. हे नवीन जे काही सिम्पटम्स आहेत हे सगळे माझ्यापेक्षा आपल्याला जास्ती माहिती आहे. त्यामुळे आपण यावर काम करताय. आपण अशा प्रकारच्या पॅनल डिस्कशन आपल्यामध्ये खूप लोक, गंगाखेडकर सरांसारखे आणि इतरही लोक जे सिनियर मोस्ट आहेत, जे तज्ज्ञ आहेत, त्यांना आपले ठाण्यातलेही आहेत, राज्यातलेही लोक आपले जॉईन झालेले आहेत. इथे मला तांबे देखील दिसत आहेत आणि इतर सगळेच लोक यामध्ये आपण काम करताय. हे खऱ्या अर्थाने
सुभाष साळुंखे साहेब पण आहे.
सुभाष साळुंखे सर पण आहेत इकडे, सगळेच जण आहेत. मी सगळ्यांचीच नावं घेत नाही मुद्दाम, पण आपल्या सगळ्यांच्याच मुळे हे जे काही राज्याचं जे संकट आहे राज्यातलं, ते आज आपण थोपवू शकतोय. आणि आपल्याला सगळ्यांना माहित आहे की इतर राज्यांची जर आपण तुलना केली तर आणि महाराष्ट्राची तुलना केली तर आपल्याकडे आपण कुठलीही आकडेवारी, आपण सगळी ट्रान्सपरन्सी आपण ठेवलेली आहे. याच्यामध्ये कुठलंही लपवाछपवीचं काम आपलं राज्य सरकार करत नाही. मुख्यमंत्री महोदयांचे तसे स्पष्ट निर्देश आहेत की आपण या संकटाला सामोरं जात असताना आपल्याला प्रत्येक माणसाचा जीव महत्वाचा आहे. प्रत्येक माणसाला आपल्याला बरं करायचं आहे. शेवटी प्रयत्न करणं हे तुमच्या आमच्या हातामध्ये असतं आणि शेवटी प्रयत्न आपण चांगला केला की आपल्याला यशही मिळतं. आणि म्हणून मी इतर राज्यांवर कुठे टीका करणार नाही, परंतु आपल्या राज्यामध्ये तुमच्यासारखे जे डॉक्टर्स आहेत हे सगळे मनापासून मेहनत करतायत, रात्रंदिवस मेहनत करतायत. म्हणूनच आज आपण पहिल्या लाटेमध्ये देखील आपण मोठ्या प्रमाणावर हे कोविड संकट कंट्रोल करू शकलो. दुसरी लाट या ठिकाणी आलेली आहे. आता थोडे थोडे नंबर्स कमी होत आहेत, खाली येत आहेत. यामध्ये हे सुदैवाची आणि चांगले बाब आहे. त्यामुळे भविष्यात देखील आपण कुठलंही संकट आलं तरी सुद्धा आपण यामध्ये तयार राहूया. यामध्ये आपल्या सगळ्यांसारखं मार्गदर्शन, टास्क फोर्सचं मार्गदर्शन हे नक्कीच आपलं रिकव्हरी रेट वाढवण्यामध्ये कामी येईल. मी आपल्याला एवढंच सांगेन की जेव्हा कधीही आपल्याला शेवटी आजच्या संकटात तुमचा रोल महत्वाचा आहे आमच्या लोकांपेक्षा, परंतु कुठेही काही आपल्याला सहकार्य, कुठली अडचण असेल तर नक्की अगदी बिनदिक्कतपणे आपण कधीही सांगा. आणि शेवटी डॉक्टर्स आणि पेशंट हे जे काही नातं आहे हे आपल्याला मी मगाशीच सांगितलं की परमेश्वरानंतर डॉक्टरचं स्थान हे महत्वाचं आहे, कारण तोच रुग्णाला, पेशंटला वाचवत असतो, जीवदान देत असतो. त्यामुळे आम्ही सगळेच जण, मी स्वतः आपल्याला आपल्या कामाला सल्यूट करतो, आपल्या कामाला अभिवादन करतो. आणि आपण कधी काही असलं तरी नक्की एक पालकमंत्री किंवा मिनिस्टर म्हणून नाही, तर एक आपल्या कुटुंबातलं, एक परिवारातला एक माणूस, सदस्य म्हणून कधी कुठलीही अडचण असली तर सांगा. नक्की मी आपल्या सोबत आहे, सरकार आपल्या सोबत आहे, मुख्यमंत्री आपल्या सोबत आहेत, एवढंच या प्रसंगी सांगतो. आणि मी तुमच्या या कामाला, आजच्या जे काही पॅनल डिस्कशन आहे त्याला मी शुभेच्छा देतो.
साहेब, आता ऍक्च्युली 500 लोक ऑनलाईन आहे, परंतु युट्यूब आणखीन फेसबुक याच्या माध्यमातून सुमारे 15,000 महाराष्ट्रातले कोविड वॉरियर्स किंवा आपण ज्यांना इंटेन्सिव्हिस्ट आणखीन पॅथॉलॉजिस्ट म्हणतो, हा कार्यक्रम मुळामध्ये पॅथॉलॉजिस्ट राज्य पातळीवरच्या अधिवेशन आणि असोसिएशनने आपण केलेलं आहे. आमची पॅथॉलॉजिस्ट असोसिएशनची एक छोटी मागणी आहे, टेस्टिंग, ट्रीटमेंट असं त्रिसूत्री आपण केली, पण याच्यामध्ये टास्क फोर्समध्ये टेस्टिंगचे जे मुख्य लोक आहेत त्याच्यामध्ये पॅथॉलॉजिस्ट, मायक्रोबायोलॉजिस्ट यातला कोणीच आपण टास्क फोर्सवर घेतला नाही. तेव्हा एका कुठल्या तरी व्यक्तीची, कारण बऱ्याच वेळेला तर मागच्या अँटीजेन टेस्टिंगचे प्रॉब्लेम्स आले, RT-PCR साठी भरपूर मोठ्या रांका लागल्या, 5-5 दिवस रिपोर्ट मिळत होते. याच्याविषयीची सूचना करणारा आमच्यातला एक मधला दुवा आपल्या टास्क फोर्स मध्ये आपण घ्यावा अशी सूचना
मी सीएम साहेबांना सांगतोय.
जी सर,
नक्की सांग.
आणि
साळुंखे साहेब काहीतरी म्हणतायत.
जी
सर, धन्यवाद. आपल्या उपस्थितीचा फायदा घेऊन फक्त 5 मिनिटं आपल्या समोर मी राज्याच्या बद्दल, मागच्या म्हणजे या दुसऱ्या वेव्ह बद्दल आपल्याकडे बरीच कॉन्ट्रोवर्सी झाली की आपण अँटिसिपेट केलं नाही देश पातळीवरती, आणि ज्या काही गोष्टी झाल्या. आता आपण तिसऱ्या वेव्हच्या संदर्भात खूप चर्चा करतोय. आज मितीला तिसरी वेव्ह केव्हा येईल याचा निश्चित अंदाज कुणीच देऊ शकत नाही. आज मितीला आपल्याला हे समजून घ्यावं लागेल की राज्यामधल्या मुंबई, पुण्यासह शहरामधनं आपल्याला प्लॅटोइंग आणि डिक्लाइन दिसायला सुरुवात झालेली आहे, परंतु ग्रामीण भागामध्ये तशी स्थिती नाही. सर, दुसरी परिस्थिती लक्षात घेऊ आपण की ग्रामीण भागातील जे काही हेल्थ इन्फ्रास्ट्रक्चर, शासकीय आणि खाजगी, या दोन्हीची जर आपण स्थिती पाहिली तर आपल्याला खूप मोठं काम करावं लागणार आहे. ही दुसरी बाब आहे. तिसरी बाब अशी आहे की आता आपण मगाशी म्हणाला की तिसऱ्या वेव्ह मध्ये पिडियाट्रिक पॉप्युलेशन किंवा लहान मुलांच्या संदर्भामध्ये बऱ्यापैकी गंभीर प्रश्न निर्माण होण्याची शक्यता आहे. तथापि या बाबतीमध्ये सन्माननीय मुख्यमंत्री महोदयांनी अतिशय प्रोएक्टिव्हली, आणि सर मला खरोखर आपल्या शासनाचं केवळ तुम्ही आहात म्हणून म्हणायचं नाही, तर मुख्यमंत्र्यांचं खरोखर कौतुक करावं वाटतं प्रोएक्टिव्हनेससाठी. इतर कुठल्याही राज्यामध्ये असं झालेलं नाही की मुख्यमंत्र्यांनी स्वतः पिडियाट्रिशियनची 4 तास 10 नंतर रात्री मीटिंग घ्यावी आणि एक साधारणतः कशा पद्धतीने प्रोटोकॉल डेव्हलप करावा याची चर्चा झाली. बीजे मेडिकल कॉलेज मधल्या प्रोफेसर ऑफ पिडियाट्रिक्स यांच्याबरोबर बसून तसा, आणि मुंबई मधल्या मंडळींच्या बसून बऱ्यापैकी चांगला प्रोटोकॉल तयार झाला. शासकीय स्तरावरती तो ऑलरेडी पोहोचलाय. थोडक्यात काय की यावेळी आपण प्रोएक्टिव्हली बऱ्याच गोष्टी करतो. पण सर हे लक्षात घ्या, जून आणि जुलै म्हणजे आपल्याला आता या क्षणी ज्या काही केसेस दिसत आहेत ते प्लॅटूइंग व्हायला एवढा फास्ट आपलं होणार नाही. आपल्याकडे जून जुलैमध्ये अजूनही केसेस वाढतील किंवा केसेस पेक्षा क्रिटिकल केसेस वाढतील आणि हॉस्पिटलवरचा जो काही भर आहे, हॉस्पिटलवरचा जो दबाव आहे तो पुढच्या 2 महिन्यात कमी होणार नाही. आणि एकच मिनिटामध्ये तेव्हा मला असं म्हणायचं की पुढच्या 2च महिन्यामध्ये आपल्याला या सगळ्या हॉस्पिटलची तयारी प्रायव्हेट आणि पब्लिक याच्यासाठी आपल्याला तयारी करावीच लागेल. आणि लास्ट पॉइंट सर, जरी केसेस कमी झाले तरी लोकांना असं वाटतं कामा नये की आता रिलॅक्सेशन मिळालंय, पूर्वीचे दिवस परत आणा, परत आपले म्हणजे राजकीय कार्यक्रम, धार्मिक कार्यक्रम आणि वगैरे वगैरे कार्यक्रम करा. हात जोडून विनंती आहे सर, डिसेंबर पर्यंत आपल्याला काहीही करून रिस्ट्रिक्शन ठेवावे लागतील. लोक तयार होणार नाहीत सहजासहजी, पण त्यातनं कसा मार्ग काढायचा हा चॅलेंज तुमच्या समोर राहणार आहे.
डॉक्टर जयलाल सर,
बिलकुल.
Dr. Jailal sir, he is our IMA national president and he is waiting for a long time. I am very sorry to the panelists. I will give you 5 minutes for Dr. Jailal sir's address. शिंदे साहेब ते आपले राष्ट्रीय अध्यक्ष आहेत इंडियन मेडिकल असोसिएशनचे आणि ते आपला विचार म्हणतात. डॉक्टर जयलाल सर.
Thank you very much, beloved and respected Honorable Minister for Health, Dr. Eknath Shinde ji. The person, Dr. Desai, the past Vice President of Indian Medical Association, Dr. Anil Bhave, and distinguished leaders of IMA, Dr. Sanchetti, and other leaders. I am extremely happy and delighted to hear the lecture of our Honorable Minister today. I remember with gratitude the way in which he has taken a bold stand when the coronal was introduced, and he was said in the Indian Medical Association, if it is not supporting it, we will not allow that to come into India, come into Maharashtra. That is a scientific temperament and the determination our Honorable Minister is having to ensure that the scientific proceedings or scientific temper with which only the care for the COVID or care for our patients should be happen place. And on behalf of Indian Medical Association, we would like to congratulate Honorable Chief Minister and the Honorable Health Minister of Maharashtra for their extreme step and innovative coordinated effort they have taken to plateau the COVID cases in Maharashtra, and even to the extent the Supreme Court and even Indian Medical Association as a whole, we now proclaim as a Maharashtra model. And another model which we always say is a Dharavi model, where the Honorable Health Minister, the Indian Medical Association led by Dr. Anil Bhave, Dr. Utre, they were able to do a marvelous work in controlling the COVID pandemic in Dharavi. That is also recognized not only by whole of India. I was told it was WHO and UNO also recognize that. So you Maharashtra always do a lot of good work. I could little understand from the speak of Dr. our Honorable Health Minister. He was saying, I am not speaking to you as a minister, but as a member of your family. And that is what we always feel. And as we are involving in this work, with a very difficult work of the controlling this COVID pandemic, when the minister himself is able to identify with the doctors, identify with the healthcare workers as a family member, and stimulate them and invoke them and motivate them, I'm sure that is the reason why that Maharashtra could see that such a success rate in controlling this COVID pandemic. So on behalf of the Indian Medical Association, I would like to extend my profuse thanks and gratitude for the minister, Honorable Minister, and the CM for your innovative work. I must also say that yesterday we had a discussion with the government of India. They asked, what is your stake? I said, you look into Maharashtra, and so many other issues are there. But one of the very important thing, the COVID task force which they constituted, the very dynamic people who are involving actively with the COVID patients, people like Shashank, Joshi, and other people who are able to express their views from the ground reality, which the government was able to coordinate and execute. And that is the reason for the success. If you see many states, or even the government of India, the people who never see COVID cases, people who never involved in the COVID work, they sit in the ivory tower and they try to formulate the decision, formulate the protocol, formulate the policies that always go in when we practically using that in the ground reality. That will be the difficult one that will happen. So I once again thank Maharashtra for you the people who are really involving in the COVID task force and ensuring that you are getting a success. And I also thank Dr. Dinkar Desai for taking this arrangement for calling all the pathologists, all the people who are involved in the COVID to have this innovative session in which lot of discussions you are having on the do's and don'ts on the COVID and the ifs and buts of the COVID management. I congratulate you. My appeal to Honorable Chief Minister is one of the issues we are facing is the amphotericin shortage. It was learned from, we searched in the government, and last year, 7 of indigenous companies, Indian companies were given permission to start amphotericin. But at the instant and at the effort of some US company, all their permissions were withdrawn. So now none of the companies are having the permission in India. We need to now depend upon the US-based or the foreign-based companies to get the amphotericin. I have today written to the DCGE and the Prime Minister to give the short-term permission for the Indian companies to give amphotericin, because we have enough strength. I mean, India is a hub for pharmaceutical hub. So we have enough strength to produce drugs and produce things, but only thing we get a problem with the DCGE where in the giving the permission. So I have written to the Prime Minister to get the permission to the Indian companies to produce the amphotericin drugs. So I do not want to take much of your time because you want to hear for a lot of panel discussion. I only extend my warm greetings on behalf of all the warriors who are working on the front line. And before I close, I just want to make a fervent appeal to Honorable Eknath Shinde ji. 13 of our colleagues of doctors have died in this second wave, and more than 40 people have died in the first wave. And I appeal to you as a family member, please take care of our family who have lost their life, and it is a great loss to the medical fraternity and their family. And I want your paternal affection to extend it to the people who have lost their life in the COVID war, and they should be considered as COVID war, martyrs, and adequate support should be given to them. Thank you very much, all of you, for this opportunity, and looking forward to a wonderful session.
Thank you, Dr. Jairaj, sir. And thank you, Dr. Rajan Shetty, who is treasurer of Pune IMA.
Desai
जी
मी जरा
बोला सर
प्रेसिडेंट आपले जयलाल आहेत हो IMA चे हो हा रिस्पेक्टेड डॉक्टर जयलाल प्रेसिडेंट ऑफ IMA. I want to thank you for appreciating Maharashtra model. Thank you.
Yes. So, Piyush, can you present the memento?
Somebody is just phone.
Mr. Piyush? नहीं तो नहीं
प्रेसिडेंट जयलाल जयलाल सरांचा घे पियुष.
Yes. Dr. Jairaj sir, this is a practical difficulty in online meetings. In regular meetings, this is there. You can give it. Now this is a virtual thing. Can you remove the Piyush?
Yes, sir.
So thank you. And we continue the panel discussion, and I come to Raman Gangakhedkar. Sorry for the delay.
Thank you very much, sir.
The question to you is, can we achieve herd immunity on nationwide level? Dr. Raman sir. Please unmute yourself, sir.
Yeah. No, I think the issue of herd immunity is perhaps one of those issues which are debatable issues. This is something which we have to think at the backdrop of variants that tend to emerge. If the variants tend to emerge and they can challenge the immunity, whether it is from natural infection or from vaccine, which is vaccine-induced immunity, no, herd immunity continues to remain then a mirage. No, the closer you will go, if a new variant comes, a section of the population will be perhaps protected, and a section of the population perhaps will also be exposed to a larger degree to the variant. So, to me, thinking of herd immunity as one of the intermediate points may not be prudent at this point in time, when the virus is replicating and producing the variants at a very rapid rate than you would have had expected for this particular virus, which otherwise is a slowly mutating virus. To me, no, herd immunity, if we believe more in herd immunity, it can set up a kind of a complacency towards the COVID appropriate behaviors adherence. So to me, you need to be cautious when we deal about herd immunity in public place.
Can future waves be prevented? As an epidemiologist, I would like to have your opinion.
He already answered that, sir. He already answered that. Yeah. Sir, I request Dr. Desai, sir, to ask the next question to our panelist, Dr. Subhash Salunkhe, sir.
Dr. Subhash Salunkhe, sir, is not seen on the screen. Mr. Piyush?
I'm there.
Yeah, he's
there. So your video was not on, so I could not ask.
No problem, yes.
Yeah. How to address the vaccine hesitancy?
Well, let us try and understand. We are in a very dynamic situation. This vaccine hesitancy, if you look at the situation in Maharashtra, particularly in the urban areas, Pune, Mumbai, and all urban areas, you will start feeling where is the hesitancy. People are literally standing in queues. The senior citizens are waiting in queue for hours together to get the vaccination. So you have on one hand the situations in Maharashtra in urban area, while there will be not a similar situation in the rural area, say in the Northeast, where in the Northeast the vaccine is supplied, but the uptake is quite low. So the vaccine hesitancy is a dynamic process, and it needs to be tackled by the concerned states, by the concerned district administration. And I feel the vaccine hesitancy is countered when there are a lot of critical cases and deaths are occurring. So that is a natural phenomena. But I think as a nation, we could have done better right in the beginning. Even before 16th January, if there would have been a communication strategy to counter vaccine hesitancy, it would have been better. But right now, I feel examples of the states and examples of the district need to be taken into consideration. And it is a continuous process. We should try to ensure that vaccines which is supplied is fully uptake takes place. As a matter of fact, uptake of the vaccine in initial period was not as much in the doctors and in the nurses, that is healthcare providers. That is unfortunate. But now I think things are changing slowly.
Yeah. मी आता मगाशी बोलत असताना शिंदे साहेबांना आमचा पॅथॉलॉजिस्टचा कन्सर्न सांगितला. आपण कोविडचे महाराष्ट्राचे ऍडवायझर आहात की पॅथॉलॉजिस्ट असोसिएशनचा कोणीच माणूस या टास्क फोर्स मध्ये नाही. आता तुम्ही पीडियाट्रिक्सचा वेगळा टास्क फोर्स तयार केला, पण पॅथॉलॉजीचा जो आरटीपीसीआर, अँटीजेन टेस्टिंग या अशा अनेक गोष्टी ज्या आहेत त्याच्या संबंधित किंवा कोविडमध्ये टेस्टिंग काय करायचं हे मी मगाशी लेक्चरमध्ये सांगितलं. पण याविषयी आमचा कोणताच दुवा महाराष्ट्र सरकारच्या आताच्या टास्क फोर्स मध्ये नाही आहे. हे आमचं दुखणं आहे. म्हणजे
या बाबतीमध्ये शिंदे सरांनी सांगितलं की ते सन्माननीय मुख्यमंत्र्यांशी बोलतील. मी आपले सेक्रेटरी आणि आपल्या टास्क फोर्सचे जे अध्यक्ष आहेत त्यांच्यापर्यंत आम्ही उद्याच मिटिंग असेल ती, त्यावेळी निश्चितपणे हा मुद्दा त्यांच्या समोर आपण तुमच्या वतीने मी मांडतो.
आणि आमच्या असोसिएशन तर्फे आणखीन एक मागणी आहे तुम्हालाही आहे. आणखीन रमण सर हे ICMR चे माजी प्रमुख आहेत. ICMR ने जो आता नियम तयार केला, मराठी दोघांनी चालेल नाही का? ICMR ने जो आता नियम केला त्याच्यामध्ये एनेबल अक्रेडिटेड लॅबोरेटरीजनाच फक्त ही मान्यता दिली. वस्तुतः सुप्रीम कोर्टाच्या निर्णयानुसार जे MD पॅथॉलॉजिस्ट आणि मायक्रोबायोलॉजिस्ट आहेत त्यांनाच फक्त सहीचा अधिकार आहे. एनएबीएल अक्रेडिटेड लॅबमध्ये PhD पण असू शकतात, MSc असू शकतात आणि त्यांना सही करायचा अधिकार नाही. पण याच्या विरुद्ध जाऊन ICMR ने जे नियम काढलाय त्याच्यामध्ये कॉर्पोरेट लॅबचं भलं कसं होईल याच्यासाठी फक्त या लॅबनंच फक्त परवानगी दिलेली आहे, एनएबीएल अक्रेडिटेड. महाराष्ट्रामध्ये सुमारे आता इथं तुम्ही ऑनलाईनच पाहता 1000 पॅथॉलॉजिस्ट आहेत आणि जे सुरुवातीच्या काळापासून अँटीजेन टेस्टिंग आणखी अँटीबॉडी टेस्टिंग करण्यासाठी उत्सुक होते, परंतु त्यांच्यासाठी कोणतीच योजना झाली नाही. आणि अँटीजेन टेस्टिंग मध्यंतर अशी तरी मारामारी झाली की रिपोर्ट 8-8 दिवस मिळत नाहीये. मग त्या पेशंटचं करायचं काय, अशी परिस्थिती किऑसची निर्माण झाली होती जेव्हा एकदम सेकंड वेव्ह सुरुवातीला झाली. आता थोडंसं रॅशनल केलंय. आता तुम्ही ते दुसऱ्यांदा टेस्टिंग करायचं नाही म्हणून सांगितलं, मग ते ट्रॅव्हलर्ससाठी तुम्ही कमी केलं. हा सगळा तुमच्या आयोजनाचा भाग झाला. पण ते सुद्धा आपल्याला करता आलं असतं आणि मास स्क्रीनिंग मध्ये आम्ही पॅथॉलॉजिस्टचा रोल त्याच्यामध्ये मुख्य झाला असता, पण तो आम्हाला करायला परवानगी आजही मिळत नाहीये. ही आमची मुख्य अडचण आहे.
मला असं वाटतं की याबद्दल एक पत्र पाठवावं.
आम्ही ऑलरेडी 3 पत्र पाठवून दिले सर. ऑलरेडी माझी 3 पत्र.
याच्यामध्ये एक प्रॉब्लेम काय आहे, ते सुप्रीम कोर्टनी जे काय म्हणलं होतं त्याच्या विरुद्धात जाऊन त्या NMLनी एक स्टेटमेंट दिलंय. नॅशनल काय ती जी MCIच्या जागी जी बॉडी उभी केली आहे
NMC,
त्यांनी हे अलाउ केलेलं, त्यांनी अलाउ केलेलं आहे. त्यामुळे हे सगळे विचित्र इश्यूज उभे राहायला लागले. त्याच्यामध्ये कोहेरन्स राहिला नाहीये. तर मला असं वाटतं की परत रिपीट करावं रिमाइंडर. दॅट इज द बेस्ट वे टू हँडल इट.
सुभाष सर, महाराष्ट्र लेवलवर अँटीजेन टेस्टिंग साठी आपण परवानगी देऊ शकता?
नाही, याच्या संदर्भामध्ये डॉक्टर गंगाखेडकरांनी जसं सांगितलं तसं जेव्हा ICMR कडनं किंवा NMC कडनं, नॅशनल मेडिकल काउन्सिल आता जे तयार झालेलं आहे, त्यांच्याकडनं जर गाईडलाईन्स आल्या तर त्याचं डिस्क्रिप्शन स्टेटवर राहणार नाही. त्यामुळे आपल्याला त्या लेवलवरतीच प्रयत्न करावे लागतील. तथापि एक मात्र नक्की की आपला रोल याच्यामध्ये निश्चितपणे अधिक सध्याच्या ज्या स्थिती आहे त्याच्यापेक्षा आणखी कसा इफेक्टिव्हली राहील. आणि केवळ स्टेट लेवलवरती नव्हे, कारण तुमचा प्रेझेन्स हा संपूर्ण राज्यामध्ये प्रत्येक जिल्ह्यामध्ये आहे. त्याबरोबर तुमचा प्रेझेन्स हा सगळ्या मेडिकल कॉलेजमधनं आहे. तेव्हा तुमचं
ICMRचा जो पासवर्ड आणि कोड आहे ना, तो तर जे अप्लाय करणार आहे सगळेच काही 10,000 पॅथॉलॉजिस्ट अप्लाय नाही करणार आहेत.
बरोबर.
आणि त्यातले काही 20, 25, 100 करतील. त्यांना तुम्ही कोड देऊन टाका तुमच्या डिस्ट्रिक्ट यंत्रणेतून. ज्या जिल्ह्यामध्ये तुम्ही सिव्हिल सर्जन किंवा डिस्ट्रिक्ट कलेक्टर यांच्याकडे अप्लाय करायची आम्हाला व्यवस्था द्या. त्यांच्या माध्यमातून आम्ही पासवर्ड आणि कोड घेऊ.
आपण
शेवटी काय ICMR कडे रेकॉर्ड राहिलं पाहिजे की कोण अँटीजेन टेस्टिंग मध्ये पॉझिटिव्ह आहे आणि कोण निगेटिव्ह आहे.
पण हा स्टेट लेवल पॉलिसी निर्णय असल्यामुळे माझी विनंती आपल्याला अशी राहील की आपण हे ऍड्रेस करूया सेक्रेटरी मेडिकल एज्युकेशन आणि सेक्रेटरी हेल्थला. जरूर.
जी सर, जी सर. So thank you very much for.
I would like to call upon Dr. Sudha Rao madam. Sudha Rao madam, if you could please be on the screen. Piyush.
Vedhas sir, I have 2 things for Dr. Subhash sir and Dr. Gangakhedkar. मी एक पॅथॉलॉजिस्ट आहे सर, तर मी रॅपिड अँटीजेन टेस्टची मला परवानगी आहे. पण आपलं कॅपिंग 150 रुपीजचं आहे. आणि सर, फर्स्ट बिग प्रॉब्लेम इज ऍब्सोल्युटली किट्स आर नॉट अवेलेबल आणि आहेत तर 170 रुपीज 180 रुपीजला मिळत आहेत. हाऊ टू हँडल दिस सिच्युएशन?
याच्यासाठी टास्क फोर्स वरती आम्हाला घ्या. म्हणजे आम्ही सगळे बरोबर सांगतो रेट किती आहेत.
दुसरा एक प्रॉब्लेम. अच्छा ठीक आहे, लेट्स हँडल दिस. हे बोला सर.
आपण आता म्हणताय तो विषयाला आमच्या दोघांपैकीही इमिजिएटली त्याच्यावर उत्तर येस किंवा नो देणं अशक्य आहे. परंतु आपण ही जी प्रोसेस आता आपण म्हणतोय की तुमच्या प्रेझेन्सचं कॉग्निजन्स हे स्टेट लेवलवरती सेक्रेटरीच्या लेवलवरती घेणं आवश्यक आहे. तिथपर्यंत आम्ही मदत करू. आणि याबरोबर आता देसाई सरांना जे सांगितलं आपण की तुम्ही जरूर कम्युनिकेट या 2 सेक्रेटरीजला, सेक्रेटरी मेडिकल एज्युकेशन अँड ऍडिशनल चीफ सेक्रेटरी हेल्थ यांच्यापर्यंत जाऊ द्या. म्हणजे मग हा टास्क फोर्स मध्ये विषय घेऊ. आता हे नक्की की कॅपिंग जेव्हा केलं जातं त्यावेळी सुद्धा या कॅपिंग करताना जसं सन्माननीय आरोग्यमंत्री टोपे साहेब यांच्याकडे जी कमिटी आहे त्याच्यामध्ये सेक्रेटरीज आणि डॉक्टर शिंदे जे आपल्या राजीव गांधी योजनेचे किंवा महात्मा फुले योजनेचे प्रमुख आहेत, तर त्यांच्या समोर हे मांडावं लागेल हे कसं रिझनेबल आहे किंवा अनरिझनेबल आहे. आणि ही जी अडचण आहे सध्या अवेलेबिलिटी ऑफ द किट्सची, ही आपल्याला मांडावी लागणार. धन्यवाद.
सर दुसरं एक आहे की एखादा GR असा काढता येईल का की पॅथॉलॉजी लॅब शुड गिव्ह द रिपोर्ट्स बाय मीन्स ऑफ सॉफ्ट कॉपीज ओनली, कारण डॉक्टर्सचा आणि पेशंटचा खूप जास्त फोर्स आहे फॉर हार्ड कॉपीज. वी आर गिव्हिंग फोमाइट्स इन द फॉर्म ऑफ हार्ड कॉपीज. पेशंटची एक चक्कर लॅबमध्ये वाढते, किंवा जर होम सॅम्पल हॉस्पिटल सॅम्पल कलेक्शन असेल तर आपला एक टेक्निशियन जातोय, तर एक GR काढला तर आम्हाला सोपं जाईल सर हे कन्व्हिन्स करायला.
नाही डॉक्टर अनुपमा, प्लीज अंडरस्टँड की हा अशा प्रकारचा GR थ्रूआउट द स्टेट ऍप्लिकेबल राहतो, आणि ऍक्सेस टू दी इंटरनेट इन द रूरल एरिया इज रिअली अ चॅलेंज. आजही तुम्हाला वॅक्सिनेशन मध्ये हे लक्षात येतं की ग्रामीण भागातल्या लोकांना हे सेशन सुरू केव्हा झालं आणि संपलं केव्हा हे कळतही नाहीये, आणि शहरातली मंडळी येऊन ते वॅक्सिनेशन करून घेऊन गेले. आता आपण 18 ते 44 बंद केलं म्हणून तो इश्यू थोडा आता सध्या तात्पुरता स्टॉप झाला, पण हा अतिशय गंभीर प्रश्न आहे की ऍक्सेस टू इंटरनेट, म्हणून हे केवळ नुसतं सॉफ्ट कॉपी दिली तर ज्या लोकांना गरज आहे त्याच्यात खूप अडचणी होतील. हा एक मोठा प्रश्न निर्माण होऊ शकतो. पण हे दोन्ही म्हणजे हार्ड कॉपी आणि सॉफ्ट कॉपी असं बॅलन्सिंग कसं करता येईल याच्याबद्दल विचार जरूर करता येऊ शकतो.
अर्बन वर्सेस रुरल काही असे नियम काढता आले तर मग तसं बघू शकता तुम्ही.
चालेल.
Yeah, I think we'll go ahead further. Dr. Sudhara, madam, I would like to ask you quickly. There is a talk from the experts that this pediatric age group is going to get affected more in the next future wave. So, what unique challenges does it really pose? You are an eminent pediatrician from Vadia Hospital. So, if you could give us that perspective, ma'am.
Yeah, thank you, Dr. Vedhas, and it was very informative and insightful looking at all of you discussed since morning. And I'm not only looking after the COVID-19 ward in Vadia Children's for the last, say, 18 months and more, but I've also been recently designated as a task force member for the pediatric COVID task force of the state of Maharashtra. Now, when we look at the prediction or the estimated burden of cases of pediatric COVID in the coming years to come in the third wave, so-called, most of it is based on a hypothesis and estimation which has happened based on statistics available in the previous first wave and second wave. We all know children were affected nearly 1 to 2% of total COVID cases in the first wave. It has increased to 4 to 6% in the second wave. And the biostatistical or epidemiological estimate is to increase to up to 10% of the total cases in the third wave. Though actually the numbers are not much, but I guess the sheer number of percentage of population of groups which are between 0 to say 18 years, as of today 0 to 6 years constitute nearly 6% of the total population, and another 12% which is from 6 to 18 years. So we are looking at large number of people, and unfortunately we don't have epidemiological number of antibody positivity in these children, and we have not vaccinated them. So we do need to be prepared, though it is a hypothesis and an estimation. I guess we need to be prepared with a large number of children, not only in terms of percentages, but also actual numbers coming to us with COVID. Now, this is very unique. The children with COVID is very unique because we are treating from perinatal COVID, that is soon after birth in the first 7 days, a newborn. Later on, coming in the neonatal period, that is the first 28 days of life, we have a childhood manifestation, and then, of course, the adolescent one. So, in children, COVID is not only acute COVID, but we also see a continuum post the spike is down in the form of the hyperinflammatory hypercoagulable syndrome of MISC and MISN. So, we do have a continuity of seriously ill children coming despite the tipping down of the COVID wave. So in terms of preparedness, I guess the ground level at the PHC or at the rural hospital or sub-district hospitals and so on and so forth, a large force of people, personnel who are trained to take care of children, not only in terms of assessing their vital signs and normal cutoffs, but also being able to perform procedures like putting an IV line, calculating dose, age-appropriate dosing of drugs, etc., needs to be a major focus of training, looking at the fact that this COVID wave this time has come more from rural also. rural area also. So the task force has a big task in going down to the rural areas and training the caregivers, doctors as well as paramedical personnel in looking after children. And it has been mentioned by the adult task force also that children will need a special kind of equipments, especially in the form of ventilators. For example, you would need ventilators which could be universal, useful across the age group, or dedicated to pediatric population. So the equipments would be maybe an additional preparedness which would be required from the government part. As far as drugs are concerned, the treatment is similar, but in the MIS-C-N or MIS-C scenarios and in the Kawasaki disease syndrome of cases, we do use a lot of intravenous immunoglobulin. And I guess that is another drug which we foresee could be in short supply once this wave comes through, and that would be another preparedness which we would need to have in terms of having enough stock of IVIG. These would be some of the challenges which I feel would be there when we deal with this third wave.
Thank you so much, ma'am, for sharing that perspective. Piyush, I request you to kindly present our token of appreciation to Dr. Gangakhedkar sir, Dr. Salunkhe sir, and to Dr. Rao, ma'am. Piyush, if you could present them with trophies, and I request all our esteemed panelists to kindly accept this on behalf of us, the organizers. Piyush?
Yes, sir, I am on it.
So thank you very much, Dr. Sudha Rao.
Thank you very much. Thank you.
Dr. Salunkhe sir's trophy and Dr. Raman Gangakhedkar sir's. And next, as we move on, we come to a very different perspective, which is a very important perspective in COVID, that is mental health. And to introduce our next speaker, I call upon Dr. Shailesh Umate, psychiatrist from Thane. Dr. Shailesh Umate.
जेवायला गेला.
Dr. Shailesh Umate, are you there?
जेवायला गेला म्हणाल.
He's online.
Okay, Dr. Deepak Vaid. Dr. Anjali Deshpande.
Yes, sir, boliye.
Dr. Deepak, you are there?
Yes, I am there. Very much.
Piyush, अभी स्क्रीन पे डॉक्टर दीपक वैद को लेना. Dr. Anjali Deshpande.
Yes, sir, I am there.
Dr. Mansi Umate, Maithri Umate.
आमचं भांडण झालं. भांडण
दौऱ्याला कुठे पळवलं?
मैथिली आणि माझं भांडण झालं म्हणून ते गेले काल रात्री.
शैलेश कुठे? अरे बायकोला वॉर्निंग दिली आधी मी जाईन मग तू यायचं. चल सुरू कर.
अहो आमचं भांडण झालं म्हणतोय ना, तुम्हाला नाही कळत का?
सुरू कर.
Hello. Yeah, I'm there, sir.
I know.
Please bring Dr. Harish Shetty on the screen. Dr. Harish Shetty, please.
Piyush, please bring Dr. Harish Shetty sir on the screen. Yeah, he's there. And Dr. Shailesh Umate, please unmute yourself. I think there are some issues with his net connection. So our speaker today is Dr. Harish Shetty. He is the eminent psychiatrist from Mumbai attached to LH Randani Hospital. He has vast experience in the field of school mental health and in the fields of disaster mental health. So with this brief introduction,
Vedhas? Dr. Shailesh is there talking.
Yeah, can you hear me, Vedhas?
Yeah, you can.
Yeah, we can hear you.
You go ahead.
Yeah, I think you can see me also. I'm so sorry.
Yeah, now we can see you.
Some goof up with the network. So I'm here to introduce our panelists and
Harish Shetty, sir. Vedhas, may I take over?
Yeah, sure.
Yeah. For today's, I would like to invite the today's chairperson on the stage or in the virtual meeting, Dr. Anjali Deshpande, who is a consultant psychiatrist in Thane. She and I, both of us, we have joined venture. We have started a venture of Insight Mind Care Center, which is a 30 to 40 bedded psychiatric hospital. And in pandemic, she has served all the people who had mental health issues. That's very good. Welcome, Anjali, here. And it is my privilege to introduce Dr. Maithili Umate, who is a psychiatrist and associate professor in JJ Medical College. She has her own unit. And also, I'm very privileged to introduce Dr. Deepak Bede, who is a consultant physician, who was a ex-AMC president, very dynamic personality. He has a WhatsApp group of hospitals, and where he deals with various problems of hospitals in that group, motivates all the physicians and all the hospital owners throughout the Bombay and Thane city, so that whatever problem that happens regarding hospital administration, running the hospital, he's always there to help us all. Dr. Deepak Bede has done immense work when he was a AMC president. Welcome, sir. And thank you for being a panelist over here. And with this, I introduce today's speaker, Dr. Harish Shetty, sir. As Dr. Harish Shetty always says, there is no need for introduction to him. Yes, sir. You are very famous. In fact, many times I wonder, many of these academicians, in their introduction, they say, itne paper publish kiya hai, itna ye kiya hai. But sir, for you, I would like to say one thing. आपके इतने students हैं, not just Thane, Mumbai, across Maharashtra, all over. And every student is always willing to learn from you. So you have all over the place, you have the students who are always wanted to learn from you, wanted to hear from you. Not just students, but the doctors of belonging to all pathies. They are impressed by you. General population, they are impressed by you. Harish Shetty matlab logon ka psychiatrist. I say, with this small introduction, the stage is yours, sir. Please start with your talk. I'm delighted to hear you. Thank you, sir.
I'm so happy to have Shailesh, Maithili, Anjali, Deepak Bede also. Shailesh, Maithili and Anjali are mental health leaders of the country. They are some of the finest psychiatrists, very enthusiastic, very active. Maithili is doing fantastic work at JJ Hospital, helping a lot of children with disability. Shailesh and Anjali outside the hospital and also at the mental hospital. Thank you for this kind introduction. People, psychiatrists, me. A fantastic pathology association I'm sorry about that. And I'm so happy to be here. Very, very happy to be here. Eknath Shinde sir, what a beautiful presentation. And thank you, Vedhas, for inviting me. And I'm so happy. Let me first say, what was the backdrop of the country when the disaster struck? The backdrop of the country was on December 2019, ICMR, Minister of Health and Welfare, and many other organizations released a report. And that report said that 1 out of 7 Indians are mentally ill, 20 crore Indians are mentally ill in India. That 2016, Niman's report said 1 out of 10, now it's 1 out of 7. And so that was the backdrop on which COVID attacked us. Apart from that, the National Crime Research Bureau 2019 released a report that said that 1 out of 3 people who end their lives by suicide have family problems. 1 out of 4 people who end their lives by suicide are daily wage laborers. And more girls end their life by suicide under the age of 18. So these are some damaging figures. 4 out of 10 women who end their life by suicide are Indian women. So in the backdrop, we had something known as COVID epidemic. When you look at this epidemic, yesterday I had an interesting thought. The interesting thought was that this epidemic is also a feurodemic. And what is a feurodemic? let me share 3 important differences between this disaster and all the disasters that happened before. If you have an earthquake, if you have a cyclone, the impact phase is just once. Cyclone आली आणि नंतर बंद झालं. वावाजोडात आवी आणि पती गेलो. And हादरा झाला आणि झालं. But this so impact phase is only once. So every disaster has a pre-impact phase, impact phase, immediate post-impact phase, and late post-impact phase. In this disaster, the impact phase continues. It does not stop. It's a continuous impact phase. That's the one big difference between this disaster and the other disaster. The second most important difference is fatalism was the mechanism of coping in the other disasters. काय करायचं का आपल्या हातात काय नाही वय सगळं देवाच्या हातात आहे दगड पडली डोक्यात मेलो आपल्या हातात काय देवनी सगळं केलंय but in this disaster the cause is science. So they talk about anger against not getting beds, anger against not getting oxygen or the medication. So this disaster is not about fatalism, but it's about science because when people of science told the mosques, churches, and temples to close down, they actually closed down. The third important difference between this disaster and the earlier disaster is the enemy here is invisible, whereas the enemy there was visible. The water killed people, the stones killed people, and the riots, human beings killed others. So these are 3 important differences. And when the enemy is invisible, the fear is high. So there's a word which I coined just yesterday, fear plus epidemic is fearodemic. And what exactly is this? The fearodemic is normal in a pandemic of this magnitude. The fearodemic manifests in different intensities and there are various strategies that we need to do. So there's a list of 21 strategies I have enumerated, but that could be hundreds more also. 3 or 4 important things which I would want to share and stop is that being engaged in little activities brings down fear. Staying connected with loved ones. Research has shown that there was a meta-analysis of all the interventions done during the first disaster, first pandemic. That is the first wave. And they found 3 important points, the data points. And the first one was perception of safety. मैं safe हूँ, मी safe आहे. 2 मास्क घालतो आणि कोणालाही हात नाही लावत घरी की बाहेर. Perception of safety is one of the most important indicators of good mental health. And the second was staying connected. And the third was non-psychiatric interventions also work around the time of disaster. And the second meta-analysis done some months back in South Asian countries said that around 40% of people would have depressive symptoms, around 30% of people would have anxiety symptoms. So when I say stay connected, it's important that you stay connected with your safe space. Don't stay connected with very anxious people. When you stay connected with very anxious people, anxiety actually multiplies. So it's important that where you stay connected. My dear friends, even if you're a pathologist, you'll have a lot of people calling up and saying, "Mera bhai mar gaya, maza bhau gela, maji ai geli." At that time, you can't say, "We'll do RT-PCR test." You'll have to give generic advice. Every doctor is a mental health soldier and a frontline counselor. So what is very important to say? 3 things. One is that if somebody has passed away, remember 3 things can happen. You might become numb. When you become numb, the fearodemic is there in your mind. You might not be able to respond to this because of fear, because you become numb. And if you respond to the person, there are 3 responses people give. One is genuine condolences, helps the other and helps you also. But then there are others who are very inquisitive and behave like Sherlock Holmes. काय झालं? कुठे ऍडमिट केलं? मग फर्स्ट डेला काय झालं? मग सेकंड डेला ऑक्सिजन किती होतं? And those who behave like Sherlock Holmes are very anxious and they cause a lot of damage to people who have lost somebody. So 3 things to tell people who have lost somebody is very important. One is, तुम्हाला अश्रू येईल, थांबवायचं नाही, काही लाज नाही त्याच्यात, रडा हो. Family that weeps together heals together. Family that avoids meeting each other, that is the true recipe, a real recipe for future psychiatric disturbances. And what happens there? The father says, I can't cry in front of my sons because my wife died. And he says it will really affect them. Kids say that I don't want to trouble my father, he's gone to hell. And though we feel like crying when I remember my mother, we don't want to trouble. So when everybody would not want to trouble each other, everybody would fall ill. And that I think is very, very important for us. So 1 or 2 messages for all those who have lost their family members. Remember, manage the avoidance, don't avoid emotions, and see that people genuinely cry, and also tell them that if there's something I could do for you, I'm there for you. So the tone is important. Also, when people are in quarantine, very important. What are the things that the family member should do when they talk to those people in quarantine? 24 कलाक ऑक्सिमीटर मध्ये ऑक्सिजन किती आहे विचारायचं नाही. एकदा विचारा, नंतर त्याला सांगा तिथे आतल्या रूम मध्ये वॉक कर रे. Keep walking inside the room, keep laughing आणि विचार. माझा मुलगा जेव्हा आत होता, मी त्याला विचारायचं, तू कसं रे 24 दिवस आत बसला, कसं बसतो रे तू चायला? आणि तो पण म्हणला, डॅडी मी तुम्हाला शिव्या देणार असं काय विचारू नका. एवढं पकून जातो. आणि दिस सॉर्ट ऑफ अ शेअरिंग हेल्प पीपल मच बेटर देन सेइंग आय विल गिव्ह यू फूड. तुला प्रॉन्स पाहिजे का, तुला मच्छी पाहिजे का, तुला मटन पाहिजे का, किंवा तुला डाळ पाहिजे का, किंवा मी नक्की तुला आणखीन चांगलं ऑक्सिमीटर आणतो. जे ऑक्सिमीटर होतं तुझं चायनीज, आय गेट युअर पीपल. बट लॉट ऑफ मेडिकल टॉक्स that does not help the person who's in quarantine. At the same time, when you want to call up a family member who's in hospital, and maybe he could be in ICU. My first cousin is in ICU just now with 60 liters of oxygen. I'm in touch with him on WhatsApp, and I've gone to see him also in the ward. What is important to say at that point of time? Anxious communication destroys the confidence. So futuristic communication. अरे तो आल्यावर पार्टी करायचा नक्की आणि बाहेर याचं approximate date त्यांना द्यायचं. So what happens is he or she becomes future positive in spite of 60 liters of oxygen. And what is also very important to share is that share good things that is happening around him. And I also found that when the patients who are discharged from the ICU, talk to those patients who are inside the ICU as they leave. तुम भी घर आने के बाद मेरे को फोन करना. These are the things that work. So use simple interventions, simple talks. Don't ask for parameters. If you want to ask for parameters, talk to the doctor concerned. Don't talk to the patient. So these are simple things which you need to actually do, and that is very important. Now this Piyush fellow is supposed to put my slides, but I don't see him at all. He's forgotten, and I'm asking him to put the title slide here if he's around and if he's awake. And if he's not putting it perfectly all right, I don't think he is able to understand what I'm saying.
Yes, actually.
So when he moves this slide to the second slide, I would like to share something very, very important. Pay full attention to this. What is the communication landscape of a doctor in COVID? Number one, there are 5 types of communication. One is reflexive. You will become all right. Sagla honar ठीक. And you reflexly answer. Second is reactive. बोला ना कुछ भी हो सकता है COVID में. I got this call from an update doctor. Then my close member of the family who's hospitalized now called me up. Said, we can't say anything. Anything can happen. That is a reactive communication. The third is rhetorical, very impressive communication. This is not genuine at all. There is a Marathi definition for that. वक्तृत्व व लेखन या शब्दाचा प्रभावीपणे वापर करण्याची कला does not work. Okay. Fourth is reclusive communication. थोडा शब्द, मोजकं शब्द, कंजूस माणूस, इमोशन पण शेअर नाही करत, आणि he is not able to really communicate with the person probably who has got the infection, or probably he is on quarantine. The last is the most important communication. That is reflective communication, which means what? I am in touch with my feelings. I feel very scared whether this guy will leave the hospital alive. I feel very confident and happy that this guy will leave the hospital. I missed something in this fellow when his steroids were on, and he had increased sugar, which I did not miss. So a lot of feelings. And reflective communication के लिए और भी कुछ important है. And as Piyush shifts the slide to the next one, I would like to say, अभी मुझे बीच में कोई रोकेंगे नहीं है, टाइम हो गया, टाइम कम है, 1 घंटा में रुका तुम्हारे लिए, सबके लिए. आता कोणी मला थांबू शकत नाही, लक्षात घ्या. आम्ही 4 लोक आहोत तिथे, दीपक भाई, अंजली, मैथिली, शैलेश आणि मी. टोन वर्सेस वर्ड्स. तो लाइजा, लाइफ इज ऑल अबाउट लाइजा. ask मैथिली, शी विल नॉट टेल शैलेश, हे आय लव्ह यू, असं नाही म्हणतो ते, आय लव्ह यू. लाइजा. काय मैथिली? सकाळी बोललो मी त्याला. So the tone of the doctor cannot be maintained just by informing. Tone maintain कर चल, तो ऐसा नहीं होता है वो. टोन मेंटेन होने के लिए और भी काम करना पड़ता है, आणखीन काम केलं पाहिजे. आणि मी म्हणतो तो काय काम. आणि जेव्हा आम्ही, when we are tired, our tone is not good. When we are stressed, our tone is not good. When we have not slept well, our tone is not good. When we are asked multiple same questions but the related, our tone is not good. So what do we do? And as Piyush changes the slide, I would like to tell you what to do so that we maintain our tone most of the time. Awareness of feelings is very important. So mind always goes through a chain of feelings. कभी थोड़ा उदास लगता है, कभी गुस्सा आता है, कभी मत्सर आता है, साला अपने को गोल्ड मेडल पर ये साला पास नहीं होता था, उसका प्रैक्टिस अपने से ज्यादा. एक बार ऐसा भी लगता है कि यार डर लगता है अपने को क्या होगा. एक बार खुश भी लगती है, you feel very happy, and sometimes you experience the feeling of love. Allow the emotions to go, because it's like the ragas of Indian music. And what is very important here is be aware of your feelings. Look, watch the feelings as it comes and goes, watch the thoughts as it comes and goes, watch the sensation in the body as it comes and goes. And if you have to be witness to your feelings, to your thoughts and your sensations, you have to practice some form of meditation, either yoga or vipassana or whatever, Shambhavi Mahamudra or Sudarshan Kriya or Shunya, whatever, or even silence for half an hour helps you to watch. And people who are able to identify feeling, acknowledge feeling, accept feeling, experience feeling, and really who are able to exhaust the feeling, they're able to watch their feelings. When they watch the feelings, the tone automatically is taken care of. That would not mean that our tone has to be very soft all the time. Anger is also compassion. तू औषध का बंद केलं रे, मला राग येतो, तू औषध बंद केलं. That's also love in India. अरे डॉक्टरना किती राग आला, मी औषध बंद केलं, त्यानं माझ्यावर किती प्रेम आहे, किती रिस्पेक्ट आहे. So it's not that we need to talk like Buddha all the time. Anger is also compassion. When anger is genuine, it is compassion. Okay, so it's important to be aware of your feelings so that you maintain the tone. The tone cannot be a tone of Gautam Buddha all the time. Anger sometimes is also a sign of compassion, and pure anger can only be there when you love that person. Imagine, my dear doctors, experts in pathology, you shout at your child, but you don't shout at your neighbor's child, because neighbor's child is nothing to कुछ लेना देना नहीं अपने को. अपना बच्चा angry क्योंकि अपने को प्यार है. Next. So be aware of your feeling. At the same time, remember the word repeat. Very, very important to maintain your health. Rest. Or in case if you are flooded with RT-PCR and इधर से फोन, जल्दी report दो, उधर से फोन, report दो, भेजो. Dr. Totla said, why should I send a printed report? I would want to send only a online report. So, but still, कभी कभी एक मिनट बीच में माइक्रो प्राणायाम करने का. योग is not about चटाई एक तास खाली उपाशी पोट. No, micro pranayam is also very good. So at the time of rest, you can do pranayam, which is a micro pranayam. If you are in your labs and if you have to sit on the chair for a long time, you're going to get screwed. वर खाली जायचं आणि थोडा बाहेर हिंडून यायचं. चाय प्यायची आवश्यकता नाही, तुकडा मारण्याची पण आवश्यकता नाही. हिंडून यायचं बाहेर. Little change in the physiology of the body helps you feel better. Eat right, huh? I have heard all the pathologists stay awake at night. आणि बायको झोपल्यावर तुम्ही नेटफ्लिक्स आणि अमेझॉन मध्ये बेगम लोकांना बघता, असं मला गुप्त सिक्रेट सोर्सेसनी सांगितलंय. करू नका असे, लवकर झोपा. इट्स इम्पॉर्टंट दॅट यू ईट राईट अँड यू स्लीप राईट, because sleep is one of the most important things. There's a lot of research that says sleep deprivation is worse than insomnia. Altruism, manje those who volunteer in some COVID activity, they find meaning in life. Meaning in life is the most important antidepressant during a pandemic. अल्ट्रुइझम, मी मदत करतोय. मी प्रत्येक RT-PCR जे रिपोर्ट मध्ये 10 रुपये काढून मी कुठेतरी डोनेट करतो. 10 आणि 100 मी कुठेतरी जाऊन करतो डोनेट. Or I'm doing some good work for my patients or for my doctors. I heard that somebody who has a WhatsApp list of all hospitals helping other hospitals. What happens? Meaning in life, changes brain chemistry, and that I think is very, very important. Now, about exercise, one small word. Have you heard about the word black dog? These guys know. My friend Shailesh, Maithili, Anjali know. Black dog is not the whiskey which some people drink. It's a 4-minute movie by the World Health Organization, and black dog is a word which Winston Churchill used for his own depression. Watch that film. Show it to all your friends and relatives. Exercise can dissolve stress and can also help mild depression. Last is tame your senses. घ्यायचं नाही म्हणजे नाही. Tame your senses. मला तो आवडतो, मला ती आवडते, करोनामध्ये आवडणं नाही. हे पण घेऊन पुष्कळ दिवस आले हात लावायचे. No, honestly, if you stop your alcohol, as of now, at the time of corona, your liver and stomach will dance with joy inside your body. And these are the things which you need to actually do. As we move to the next slide. So allow me to share also one small thing, and as I slowly close. Fear plus epidemic is causing apathy and antipathy. Now, what is empathy? Empathy is that I feel very sad when somebody died. I feel very sad at my friend's plight. But empathy is always unequal. Huh? If my son is unwell, I'll take him to the doctor. If somebody else's son is unwell, I will give the address of the doctor to that person. I will not go. So empathy is unequal. But I feel, थोड़ा खराब लगता है, थोड़ा इतना भी खराब लगा means you are there. But what is happening during the epidemic? Because of Purodemic, सगळं tight. We have to preserve ourselves. One hospital में अपने को सोचने का नहीं. So I still remember when a son told his father, don't go to the hospital to see your sister who's out of the COVID ward, is in a general ward because she has other issues like emphysema. She's out of RT-PCR, and the doctor was treating this lady, called the brother. When the brother was about to leave the hospital, the son said, you should not go anywhere. I'm very concerned about you. And the father said, I'm going to see my sister. He said, no, if something happens to you, he's saying, I'm going to see my sister. I'll be safe, I'll come back. And that's the time when he said, I don't care about your sister, I care about you. This is apathy. And pandemic causes apathy because the more people die, compassion goes down. Everybody is worried about the self-preservation virus. Self-preservation, which is one of the most important behaviors of human race as of now, might cause apathy towards others who are actually suffering. So you need to be guarded here. At the same time, if the boy says, why do you want to go to the hospital? Antipathy. So let your empathy be alive. Empathy is alive when you care for somebody else, you can care for yourself much better. If the boy says, Daddy, go, it's your sister. And you please come back. And that is empathy. And you need to teach the children, teach others empathy. At this point of time, the father also told the son, you will do the same with your sister and your brother once you grow up. So this entire apathy and antipathy which I watch, apart from the million sunshine stories, which we see, is also something we need to be very careful about. Next slide. So my dear friends, I recently did a talk on resilience secrets for the pandemic, for a college which has hundreds of young students between the age of 16 to 25. But these secrets are the same for you and me, which means what? Let me tell you, my dear friends, my two heroes in my life, apart from my parents, and Professor Vig, and Professor Murthy, is Baba Saheb Ambedkar and Chhatrapati Shivaji. I have read the history of Ambedkar ji across time, many times, and I was wondering, for me, Chaudhar Tale Satyagraha is one of the most inspiring moments. And when I shared this with all the students of this college, Wilson College, I don't think any student knows anything about Ambedkar, very little. But to see that this man could persevere, persist, have patience, was pragmatic, and had presence of mind, Resilience can come from stories of people whom you revere. It could be a father, it could be a mother, it could be a grandfather, grandmother. And Chhatrapati Shivaji, at the age of 15, he counted 10 fingers only in his pocket when we counted 11 fingers. At the age of 15, he challenged the might of the Mughal Empire. So resilience comes from history. Resilience comes from your past, where you really overcame a difficult situation. Resilience can come from your parents, from their own struggles. So what is important is let us gather the seeds of resilience from within us, past positive experiences, from people around, from people whom we are inspired with, and fight the pandemic. At the end, I would like to thank Vedhas and the association for inviting me to share small nuggets, even for a very short time. At the same time, I would like to say that pathologists are also frontline mental health workers, and they need to understand that they need to answer calls of people in the neighborhood and use simple mental health tips. I will share my blogs with Vedhas and Shailesh and Anjali and Maithili and see to it that those 3-4 articles, which are very important, would reach you. I am deeply grateful to all of you for inviting me. I am really happy to meet our Mr. Eknathji Shinde also. Thank you, Vedhas and everybody. And I was very happy to see the backdrop of Doctor of Pathologist was asking himself to be on the task force. I saw the Mumbai-Pune old highway behind him. What a magnificent sight. What a magnificent. So I learned how to put all that behind my screen also for the next talk. I'll ask my son. And thank you, everybody.
Thank you, Dr. Shetty, sir. And you must thank our convener for today, Dr. Dinkar Desai, sir, who happens to be the...
Same. I was speaking about him.
Yeah, Dr. Desai, sir, the president of
he had
TPA.
Brilliant arguments in front of the ICMR chief. I like those arguments. I love the way he put across his point so beautifully.
Yeah, and the audience is not just pathologists, but from all super specialties and specialties they're attending. I myself represent physicians, and there are many of them. I'm a physician myself. So your talk is really nice and exhaustive, and you've made it very simple with the tidbits from the real life. It was something really rejuvenating, if I may say so. Dr. Shailesh, you would want to add something? Dr. Maithili, ma'am?
Yes, sir. Very wonderful talk. As I always like it and make some notes of it with me. Family that weeps together, heals together is excellent. Take home message to all of us. In fact, I today request to all of physicians who treat all the COVID patients, and they are also disturbed sometimes. So I request them to talk to each other, share their sorrows. They can talk to our psychiatrist colleagues and friends also कि आज अच्छा नहीं लग रहा है, आज बहुत सारे पेशेंट का डेथ हुआ या जो भी कुछ हुआ. So all they can share so that they shouldn't carry out the burden for the next time. So that is my advice to all of you. Apart from this, anything that Anjali or Maithili can add, or Dr. Deepak Bed?
All 4 of them are very brilliant doctors in their own fields. Phenomenal.
I'll just add on one thing.
Yeah, Deepak.
I think one psychiatrist should be in the task force of the government. And probably the government will develop some empathy towards the healthcare workers also in that case.
Yes, absolutely.
True.
Sir has made a very strong point there. And that's so true.
In fact, I have written to the health minister, center, state, and I also have submitted a module for mental health relief. And let's see what happens. We'll keep on pushing. In life, psychiatrists have learned to knock at the wall slowly so that one day the wall falls. But we are in a hurry. We want to see the wall falling at the earliest.
That's wonderful.
Yes.
Yeah. May I request Piyush to kindly present the memento to Dr. Shetty, sir, please. Piyush, over to you.
Is this visible, sir?
Yeah, we can see it.
Right.
No, I cannot see. कुणाला दिसला? मला नाही दिसला. का तोही व्हर्च्युअलच आहे मोमेंटो.
आला येतोय.
नुसती हवा दिली आहे फक्त.
Guys, thank you.
Desai sir, may I request you to present Dr. Shetty sir with the memento for his excellent talk.
हा घ्या सर.
घेतली.
मोमेंटो घेतला.
घेतलं. आणि तुमचं जे बॅकड्रॉप मध्ये तुम्ही जेव्हा जाता तेव्हा एक साप असं वरती येतो. काय तो असं एक साप असा येतो वरती.
साप?
हा. When you leave the place in that backdrop, there's something which comes like this. You did not.
Okay, I'll answer that. That's not SAP, but it is a virtual background when you use and a person moves. This is a shadow of that person that looks like a snake.
Sir, it is Tatsang Monastery from Bhutan that I visited last and उसके बाद कुछ कहा जाने का नहीं हुआ. मैंने थाना का बॉर्डर भी नहीं.
हमने सीखा आज आपसे how to put points very assertively and with a lot of respect. Beautifully, sir. Beautiful.
अभी राजेश टोपे सर भी आने वाले हैं. उनके सामने भी यही होने वाला है.
उसके पहले मैं निकलता हूँ सर.
जी सर. धन्यवाद. मंडळ आभारी आहे. मंडळ आभारी आहे. चला पुढे. बरा. Dr. Isha Pansare, can you take over?
Yes, sir. Yes. Good afternoon, everyone. I feel privileged to be part of such a huge virtual platform of knowledge exchange. First, I would like to introduce chairperson for this session. Dr. Sanjay Pingulkar is physician at TMC Thane and done lot of work in vaccination. Dr. V.N. Joshi, our ex-Thane IMA president and a grassroots worker of IMA Thane. And Dr. Ram Chandani. Sir had just completed yesterday his 75th birthday. He is ex-senior vice president and pillar of IMA Thane. Now, it gives me immense pleasure to welcome our eminent speaker, Dr. Vedhas Nimkar, renowned consulting physician with Jupiter Hospital Thane and Dr. Nimkar Clinic. Sir is secretary of IMA Thane chapter. He is first physician to conduct COVID education and awareness program for general population at the beginning of pandemic. Being a clinical expert on COVID vaccination, Dr. Nimkar has successfully conducted multiple vaccine classes for doctors. Today, sir is going to enlighten us with next generation vaccine and future trend. Over to you, sir.
Thank you, Dr. Pansare ma'am, for the kind introduction. Piyush, if you may share the presentation on the screen.
Whether your voice is not, your voice is slow.
Whether your voice is not audible.
Dr. Vedhas, we are running short of time.
Can you hear me well now?
Dr. Vedhas, we are running short of time. So
yes,
please.
Yeah. So I wouldn't take much time because there are many more speakers coming up. I would just take 10 minutes. So next generation vaccines and the future trends. So next slide, please. Yeah, this picture says it all. After all the darkness that was brought in by the last unpredictable year, 2020, dawned the new year or 2021. And along with it, brought the ray of hope in the form of vaccines. We all thought that now the end of this pandemic seems to be very near. So let's see what it holds. Next slide, please. As my topic says, it's about future vaccines. So I'm not going to really delve deep into the existing vaccines. We have already talked about it multiple times. But just for the sake of clarity, I'm just enumerating all the various vaccine platforms or the technologies which are available and some of the common examples. The first vaccine in the world was mRNA vaccine, the Pfizer-BioNTech, the Moderna, and now upcoming Genova SGT Bio candidate, which is going to be launched in near future in India. And then the mainstay of vaccination in many of the third world countries, poorer countries, and also India, the Oxford AstraZeneca or Covishield, as we know here, and Sputnik, and the J&J, which is to be launched very soon. These are the vaccines based on adenovirus vector platform, where they use an adenovirus, be it human or chimpanzee, as a vector to deliver the antigens of COVID virus. And then the indigenous vaccine from India, Covaxin by Bharat Biotech, and also the Chinese vaccines of Sinovac and Sinopharm. They are the killed whole virion vaccines, the age-old technology where the entire virus is inactivated or killed and used in the making of the vaccine. And then a futuristic technology like protein subunit vaccines, where the antigens of the COVID virus are synthesized, synthetically manufactured, embedded into the lipid nanoparticles and injected, which our immune system recognizes and mounts a response against. And DNA plasmid vaccine, which is again being launched in India by Zydus Cadila, multi-peptide vaccine by United Biotech in Taiwan, live attenuated intranasal vaccine by Codagenics SII. We'll discuss some of these important candidates in next slides. And virus-like particle vaccines by Medicago and Spy Biotech by Oxford University and Serum Institute of India. Next slide, please. So we come to this question often that most of the doctors, almost all of the doctors, I would say, are already vaccinated with 2 doses of Covishield or Covaxin. So why do we need vaccines again? Why are we still talking about vaccines? So there are certain limitations which we all know of the present generation vaccines. The vaccines used in our country have somewhat lower efficacy compared to these mRNA vaccines, which have figures in the range of 92%, 95%, depending upon the geography and the spread of the variants. Whereas the other vaccines which we use, they have established efficacy between 50% to 90%. When we say efficacy is higher or lower, this is efficacy against the mild to moderate disease, mind you that. And the protection against the severe disease, hospitalizations and death is almost 90% plus for all of the present generation vaccines. So this lower efficacy may not stop the transmission of the disease, and thereby from epidemiological point of view, this vaccination may not be of 100% use in stopping the future waves, but all the same it is very important from the point of the disease progression that once we are vaccinated, we are nearly sure about not developing a severe disease or the death. And that's the importance of getting vaccinated with whichever vaccine is available to us right now. So this lower efficacy rates may lead to the evolution of further mutations and stronger variants because like we discussed, in spite of vaccinations, there'll be more and more people getting infected or so-called immune escape phenomenon, as we call it. mRNA vaccines, we say they have better efficacy, but they have some extreme storage temperature requirements. In the Pfizer vaccine needs to be stored at minus 70 degrees. Moderna needs to be stored at minus 20 degrees. So that is not very easy and convenient in a country with little limitation in resources like ours. And also there are concerns about adverse events, especially after the debacle, I would say, of some of the adenovirus vector vaccines having a large number of patients reporting the thromboembolic phenomena and so-called blood clotting. So there are certain concerns. Next slide, please. Next slide, please. Yeah, so which future vaccines? I have just picked up the candidates which are going to be launched in India, and we will discuss them in little details. So first and foremost that comes to mind is Johnson & Johnson and Biological E from Hyderabad. They're going to launch the vaccine which is based on the human adenovirus vector. ADV5 is the vector used there. And the benefits of this particular vaccine is the ease of administration and easy dosing, because it is going to be a single shot or a single dose vaccine. So thereby naturally the logistics are improved. The patient compliance will improve because you have to give only one single shot. There have been various published studies from South Africa, from UK, from US, and it has shown an efficacy rate of 72% against the original or the Wuhan version of the virus, as well as against the so-called UK variant or B117 variant. There are concerns about thrombosis and thrombocytopenia, or the so-called blood clotting events, and for which this vaccine was momentarily paused in the United States. However, the US CDC and US FDA have given it a go-ahead, saying that the incidences of such events are extremely rare. They are perhaps at less than 1 in a million. So the benefits clearly outweigh the risks, and therefore we must use this vaccine, which is going to be launched soon in India, and it's perhaps going to be a big part of our vaccination drive. Next slide, please. The second indigenous vaccine to come from India is by Zydus Cadila. It employs a unique technology of plasmid DNA. What it does is it uses a plasmid to inject the DNA into our bodies and makes our body's cells to act as small factories which can manufacture. The DNA gets converted into a messenger RNA which encodes the proteins which represent the surface proteins of the COVID-19 virus or the SARS-CoV-2, and thereby the body produces mounts an immune response. It produces antibodies. This particular vaccine basically targets the membrane protein of the virus. The flip side to it is that the efficacy data is not yet available. The phase 3 trials are still going on. The data is expected by June or the next month, and it has to be given as 3 doses. So on the logistics side and from the patient compliance side, this may get further a little difficult because 3 doses, already 2 dosages we are seeing what kind of situation we are facing with shortages of vaccine and dosages getting delayed. So 3 doses is something which is worrisome. But good part is also the trials are ongoing in the pediatric age group of 12 to 17. And when it gets approved, it may get approved for that age group as well. Next slide, please. The next one to come would be the Novavax and Serum Institute of India vaccine, which has been branded as Covovax in India. It employs a unique technology of protein subunit, synthetically manufactured proteins or the antigens of SARS-CoV-2 are embedded into lipid nanoparticles. They also use a saponin-based adjuvant to increase the potency. It's their own patented adjuvant. And the efficacy is really good. The efficacy is of 96.4% against the mild to moderate disease for the original Wuhan strain. It's 86% against the British or the Kent variant B117. It's 55% against B1351 South African variant. The data for the so-called Indian variant or B1617 is not yet available. It is a 2-dose vaccine. It is easy to store at the refrigeration temperatures of 2 to 8 degrees. And so far, whatever studies have been published from South Africa and UK, a large number of participants have been included in these studies. It has been found to be 100% effective against the severe disease. Again, the beauty of this particular platform is if the need be, and the vaccine needs to be tweaked in future against the variants, that can be rapidly deployed. So that's the point about Covovax. And again, Serum Institute of India having a large manufacturing capacity can perhaps manufacture this in large numbers, and we can speed up the vaccination process once this vaccine gets launched by, say, early September is the tentative time schedule. Next slide, please. The another vaccine which is in the pipeline, it is just undergoing phase 2-3 clinical studies in UK, is again by an American company, Codagenics, and Serum Institute of India co-developing it. It has been labeled Covivac in India. This is a unique vaccine. It's an altogether different platform. It is an intranasal vaccine. So naturally, there is ease of administration, no pricking, less trained manpower is required. It's a single dose vaccine. Perhaps patients can self-administer it. So that way, it's going to be a game changer. It is a live attenuated virus. They have used their own patented technology to weaken this COVID virus. And from whatever preliminary animal studies as well as early immunogenicity data is available from humans, the immune response is seen against all the proteins of SARS-CoV-2, not just the surface protein, but also the nucleocapsid protein, the membrane protein, etc. So perhaps a better mounted immune response, and thereby possibly it will be efficacious against the variants also. And there won't be so-called immune escape phenomenon. However, these things may change as the more and more data comes in. But these are the preliminary observations. So you can certainly call this a ray of hope. And if this vaccine is proven successful and highly efficacious, it can become a mainstay of the vaccination program by the end of this year or early next year. Next slide, please. Another indigenous candidate, which is also an intranasal vaccine, because intranasal vaccines seem to be the flavor of the future, is by Bharat Biotech and University of Washington at St. Louis, BBV154. This is a technical name. They haven't launched a brand name yet. It uses a chimpanzee adenovirus vector to deliver the payload. It's an intranasal vaccine with single dose, again, ease of administration, and patients can self-administer it. In the preliminary data, it is showing a broader immune response in the form of both systemic neutralizing IgG antibodies, also the mucosal IgA antibodies in the buccal mucosa and in the upper respiratory tract. And also it is mounting a good T cell response in the immunogenicity studies. So this is a really three-pronged response. High neutralizing titer will protect you against even a mild to moderate disease. The mucosal immunity will protect you against the entry of the virus, the portal, as we say. So perhaps this may even stop the transmission. It has the potential to stop the transmission, which would be the characteristic of an ideal vaccine. And T cell response will be the backbone of the long-term immunity in the form of cellular immunity. So if proved successful in the clinical trials, this candidate really truly has a potential to launch a three-pronged response and be a complete candidate. So we eagerly await this. Again, this would be at least 6 months to 10 months away. So let us hope and pray that this vaccine works and it can bring an end to the pandemic. So what is the path forward? Next slide, please. Next slide, please. Yeah. So what exactly are the scenarios we are going to face in near future in this very year? Booster doses. Many people ask these questions that do we really need to take a third dose or do we need boosters? And if yes, then when? And if when, which one? So the trials are ongoing for boosters. Moderna, Pfizer, Oxford all have launched booster specifics, the booster specific for newer variants like B117 and B1351 and even the Indian variant now. Because these boosters in the preliminary studies have shown increased efficacy. They have shown longevity of the immune response increases with the third dose. There are studies going on with both the things, the third dose of an existing vaccine candidate or a single dose of a new variant specific vaccine. So both are in trials and the data is expected by middle to third quarter of this year. However, we all must be really prepared. An annual vaccination seems to be very likely scenario. It's perhaps going to be a ritual for a foreseeable future. Next 4 or 5 years, we may have to go through this ritual of taking annual shots to protect us against the new variants that may emerge in future. So we should be mentally prepared for that. And there is no harm in it, in increasing or boosting the levels of our protection. The mRNA platforms, which have proven to be very successful in the first phase, are also rapidly adaptable platforms. It's very easy to modify in the matter of weeks and create a new vaccine, and followed by the regulatory approval, if expedited in say 3 to 4 months, a new vaccine can be launched for specifically for a new variant of concern, which may emerge in future or even the existing ones. The other common question that comes is, can we mix the vaccines? Can we mix the different vaccines? Again, a very leading study, Conclave trial, is going on from the team of Oxford. They have launched 2 arms. One is Oxford and Pfizer combination, and another is vice versa. First dose of Pfizer followed by the second dose of Oxford or Covishield. This preliminary data for the side effects has emerged just last week. This is just in. It has shown that the frequency of side effects like fever, myalgias, pain at injection sites, headaches, fatigue is much more when the vaccines are mixed. However, they have also noted that none of the untoward effects seen in the subjects were so severe that any of them required hospitalization or so. So this is, I would say, small price to pay to get vaccinated. Why this question of mixing the vaccine comes is for 2 reasons. As we know, world over, there is shortage of vaccines. So we may have at one point in time to think about mix the 2 different companies' vaccines, whatever different platforms are available. And secondly, if it is shown that the mRNA vaccines, which are not yet available in India, but they are in foreseeable future, they're expected to be launched. And if it is proved that the existing vaccines in India in the form of Covishield or Covaxin may not be very effective against the newer variants of concern, then we may have to take another technology-based vaccine as a booster shot or a repeat next vaccination. So that's where this mixing thing comes in. there is also a possibility, theoretically, of increased efficiency due to due to introducing 2 different vaccine platforms, and thereby our immune system launches double-fold response. So this data is expected by month of July or so. Once that is available in the future talks that we hold, we can perhaps elaborate that. As of now, the data is not available. Even though Oxford has planned a further step, a second study, Conclave 2, whereby they will include Moderna and Novavax, this vaccine, additionally to the Oxford Covishield and Pfizer. So we really must await this data before we can finally say the final word on the mixing of the vaccines. Next slide, please. So which are the futuristic vaccine technologies? These are already in the pipeline. These all are going to get launched in foreseeable future. That's few months from now. But another important technology that comes to mind is virus-like particles. This is a proven technology. It is already used in HPV vaccine. If I have to mention the brand name, that's Gardasil by Merck, which is using this technology. What is exactly these virus-like particles? These are the synthetic molecules which resemble the virus in the shape and the structure, stereo structure, but they are not having any viral genes. So you can imagine it as a cover of the virus without the inside masala of the virus genes. So virus-like particles can be produced in different cell lines. They can be produced artificially in animal cells, in yeast cells, in plant cells, in bacterial cells. There is already a vaccine in first phases of trial based on this technology by a firm in Canada called Medicago. They are using the tobacco plant cells to develop these virus-like particles. Basically, these particles, they express the synthesized viral proteins and they self-assemble into a stereo structure or a 3D structure which resembles the virus. They are non-replicating and they are highly immunogenic. So as we know, since they are not viruses, so all the side effects associated with a live attenuated virus in the form of that in immunocompromised patients, we may not use it. Or some untoward effects that we see in the old technology like killed whole virion vaccines, they are naturally not present in these VLPs. And being highly immunogenic, they are known to mount very strong and broad spectrum immune responses by our immune systems. So this may also perhaps lead, this particular technology is in the work for a possible future candidate called polycorona vaccine. Now, what is exactly this polycorona vaccine? This is still at a conceptual stage. A polycorona vaccine is at least 3 to 4 years away. The postulate here is that using the technology of VLPs, we may synthesize artificially a particle which contains the proteins or the antigens of all coronaviruses, not just SARS-CoV-2, which is causing COVID-19, but also the previous pandemic causing coronaviruses like SARS virus, MERS virus, and also rapidly in future, if new viruses emerge from the zoonotic diseases, from bats or from pangolins, for any other animals, new coronaviruses emerge, we can perhaps add antigens of that as well. So a single vaccine with a single dose or double dose can provide us the 360 degrees protection against possibly all the coronaviruses that are pathogenic to humans. So if this feat is achieved, that I would say would truly bring the total end to this pandemic. Next slide, please. Another important technology which is in the works is oral vaccine. This is in the preclinical stage. Again, the oral vaccines, many times they use VLPs or else they use vectors. There are 2 companies that come to mind. They are leading candidates. One is Premas Biotech, which is an Indian company, again, proudly Indian, along with Israeli company Oramed. They are working on a vector-based oral vaccine, and also Vaxart and then Simvivo. Simvivo is a company which is using Bifidobacterium to deliver its payload. Oral vaccines in the preliminary studies have shown to be highly immunogenic, again producing both broad spectrum IgG antibodies as well as specific neutralizing IgG antibodies, as well as the mucosal IgA responses. They have also, especially the candidate by Vaxart, has shown to have a very high CD8 response, the cellular T cell response, thereby conferring the long-term protection against the disease. As the vaccines are available in the form of tablets tablets or capsules, they are perhaps easiest to administer, easiest to store, and patients can self-administer it. Even the general practitioners can prescribe it in their OPDs, and vaccines can be bought over the counter from the medical stores. If this works out, again, it's going to be a total game changer, just like the nasal vaccines. That brings us to the end of this talk. Like I said, I'm going to really keep it short because we have many more speakers waiting. I thank you all for patiently listening. If you have any queries, you can always reach me on our Telegram group, and I'll be very happy to answer those queries. Thank you very much. Over to you, Piyush.
Thank you, Vedhas. It was very fine.
Thanks, sir. It was a very nice lecture, actually. And here's your e-memento. Please accept this on behalf of DigiSheet and to keep here.
Thank you, Piyush. Thank you very much. I accept it on behalf of myself and also on the behalf of the organizers. Thank you very much. I would like to call on Dr. Minal Gadge.
Dr. Tope is here. Tope sir is there in the meeting. Just to inform to the forum. He has joined in.
Just hold on for a second. Dr. Desai, are you there? Dr. Desai?
Yeah. Mr. Piyush?
Dr. Desai,
I know.
Mr. Tope sir has joined.
Mr. Piyush, please see that Tope sir is on the screen.
Yes, sir.
Yes. Yeah. So thank you very much, the panelists, and we in between welcome Dr. I called you Doctor Sir, though you are engineer, Tope sir, and you have almost handled the first wave, and you are handling the second wave fantastically. So I welcome on behalf of organizers and the Pathologist Association for this day prolonged active meeting of all the task force members, corona warriors, and from pediatrics to gynecology and radiology to pathology, all faculties, ENT people and everybody. Sir, there are 500 online, but 15,000 are nearly watching from Facebook and YouTube. So can you, Mr. Piyush, can you take sir on the screen?
I have added him. His video is off, sir.
Tope sir, video on kara, please.
Phone kara. Shilpa, phone karna.
Yes.
Okay, so thank you panelists for this nice, wonderful lecture vaccination. You can, Piyush, you can take Tope sir, Vedhas, myself on the screen.
Your video is off, sir.
Pardon?
Please turn on your video.
Yeah. Yeah, I'm seeing.
खूप स्वागत टोपे सर आपलं द पॅथॉलॉजिस्ट असोसिएशनच्या मार्फत आपलं स्वागत आहे सर. टोपे सर यांची काहीही स्पेशल इंट्रोडक्शन देण्याची काही गरज नाहीये. एव्हरीवन नोज. प्रत्येक स्क्रीनवर, प्रत्येक न्यूजपेपर मध्ये टोपे सर आहेत. तर स्पेशल फॉर्मल इंट्रोडक्शनची अजिबात गरज नाही. पण थोड्याशा काही गोष्टी ज्या मला त्यांच्याविषयी माहिती आहे, बिकॉज आय एम फ्रॉम मराठवाडा, त्या मी सांगू इच्छिते की फर्स्ट थिंग दॅट एव्हरीवन सेज अबाउट टोपे सर की ही इज अ वंडरफुल पर्सन. मी कालपासून 3-4 जणांकडून त्यांचा नंबर घ्यायचा प्रयत्न केला, बट एव्हरीवन सीज टू इट दॅट ही सेज की ही इज अ व्हेरी नाईस मॅन. तर पॉलिटिशियन्स विषयी जे आपले काही मिसकन्सेप्शन्स असतात, दॅट इज ॲब्सोल्युटली नॉट ट्रू हिअर. मला अजून एक असं आवर्जून म्हणायचंय की सर, करोना वॉरियर्स बद्दल एवढं चालतं, बट मी म्हणेल यू आर द टॉप मोस्ट करोना वॉरियर फॉर महाराष्ट्र स्टेट. डे 1 पासून अजूनपर्यंत तुम्ही कंटिन्युअसली डे अँड नाईट काम करत आहात. आम्ही तरी डॉक्टर्स म्हणून रात्री अपरात्री कॉल उचलतो म्हणून भरपूर कौतुक आहे. बट टोपे सरांचा जो नंबर आहे, आय जस्ट गॉट टू नो की एव्हरी सेकंड ही गेट्स अ कॉल. तर तरी सुद्धा ही रिसिव्ह द कॉल्स, ही सो पेशंट. आपण आज सकाळपासून एका झूम कॉन्फरन्समध्ये आहोत. सरांची ही तिसरी आजची झूम कॉन्फरन्स आहे. त्यांनी स्वतः आज जनरल प्रॅक्टिशनर्सना ऍड्रेस केलेलं आहे दुपारी, आणि ही इज कम्प्लिटली ऑन इट. आणि थँक्स टू यू सर की तुमच्यामुळे हा सेकंड वेव्ह एवढ्या लवकर कंट्रोल झाला महाराष्ट्राचा. फुल क्रेडिट्स टू यू सर. सो अँड वन व्हेरी इम्पॉर्टंट थिंग जे टोपे सरांनी मला सांगायला सांगितलेलं आहे की प्लीज एव्हरीवन फील्स आय एम अ डॉक्टर बट आय एम अ मेकॅनिकल इंजिनियर. पण सर तुमच्याविषयी मी तर म्हणेल की यू आर अ मल्टी डिसिप्लिनरी करोना स्पेशलिस्ट. दिस विल ऍड्रेस इट ऑल. सो ओव्हर टू यू टोपे सर.
सर, मी डॉक्टर दिनकर देसाई, द पॅथॉलॉजिस्ट असोसिएशन या संघटनेचा अध्यक्ष. आपली ही सगळी पॅथॉलॉजीची राज्यव्यापी संघटना आहे. आणखीन त्यांच्या मार्फत आपण हा आजचा कार्यक्रम आयोजित केलाय. त्याच्यामध्ये मल्टी स्पेशालिटीची जवळजवळ पिडियाट्रिक पासून गायनेक पर्यंत आणखीन सगळे टास्क फोर्सचे लोक त्याच्यामध्ये आज येऊन संबोधित करून गेले. प्रत्येकाने आपले विचार मांडले आणि या कार्यक्रमाला आपण उपस्थिती ठेवून मार्गदर्शन करतात हा आमच्यासाठी खरोखरच अभिमानाचा विषय आहे. मी आपलं मराठवाडा लोकांचं एक जो ठाण्यामध्ये कार्यक्रम झाला त्यावेळेला आपल्याला प्रथमतः ऐकलं आणि मी खूपच आपल्या भाषणाने प्रभावित झालो होतो की एक अत्यंत संयमित आणखीन सुबुद्ध असा राजकारणी आपण आज पाहून आलो, याचा एक मला अत्यंत आनंद होता. आणि त्याच्यानंतर लवकरच आपण निवडून आलात, आपली आरोग्यमंत्री म्हणून निवड झाली आणि तुम्हाला एक आव्हान म्हणून हा कोरोनाचा सगळा पहिली लाट दुसरी लाट असं आलंय आणि त्या प्रत्येक आव्हानाला तुम्ही खरे उतरत आहात आणि आम्ही तुमच्या पाठीमागे सतत आहोत. तेव्हा यात आपल्या कार्यक्रमासाठी आपल्या मार्गदर्शन असावं अशी आमची विनंती आहे.
नमस्कार, आवाज येतोय?
आवाज येतोय?
येस सर, येतोय.
नमस्कार सर्व पदाधिकारी, पॅथॉलॉजी संघटनेचे तुमचे सर्व पदाधिकारी, अध्यक्ष, सर्व पदाधिकारी, खास करून दिनकर देसाईजी, शिल्पा तोतालाजी आणि उपस्थित सर्व मान्यवर. मी वेळ घेणार नाही, आपण सगळे प्रोफेशनल्स आहोत आणि त्यामुळे मला वाटतं की नाव घेण्यापेक्षा सुद्धा आपल्या सगळ्यांना नमस्कार करतो आणि नमस्कार खऱ्या अर्थाने अंतःकरणातून करतो. कारण आपण सगळेजण खूप दिवस आणि रात्र मेहनत करतायत. पॅथॉलॉजिस्ट सुद्धा खूपच मेहनत करतायत आणि या सगळ्या कोरोनाच्या पार्श्वभूमीवर मला वाटतं की आपल्यासारखा लोड दुसरा कुणावरच नसावा, इतका मोठा लोड आपल्याकडे सुद्धा आहे. आणि त्यामुळे इन जनरल मी एकच म्हणेल की डॉक्टर फ्रेटर्निटी, कारण आज जसं तुम्ही म्हणालात की पिडियाट्रिशियन पासून गायनेकॉलॉजिस्ट पर्यंत आणि संपूर्ण सर्जन्स आणि एव्हरी स्पेशालिटी तुम्ही कव्हर केलेली आहे. आणि त्यामुळे एक नक्कीच आहे की आपण सगळ्या डॉक्टर्सच्या ग्रेट वर्क मुळेच खऱ्या अर्थाने हे सगळं आजपर्यंतच जे काही कंट्रोल झालेलं आहे किंवा जी काही चांगलं काम केलेलं आहे, आय रियली attribute everything to डॉक्टर फ्रेटर्निटी. आणि संपूर्ण आपल्या सगळ्यांना जेवढं करावं तेवढं घेतलेले आणि एक मिशन मोडवर आपण काम करतायत. म्हणूनच आपल्या सगळ्यांना मी मनापासून आणि सगळ्या समाज वर्गामध्ये सुद्धा, सर्व समाज घटकांमध्ये सुद्धा डॉक्टर्सला पहिल्यापासूनच खऱ्या अर्थाने देव मानत आलेले आहेत आणि खरोखर परिस्थितीच्या अनुषंगाने दिवस रात्र आपण काम सगळेजण करतायत. मी एकच सांगेल की आज आपण मत आहे, मी आज बऱ्याचशा विसीज मध्ये होतो, माझ्या काही महत्वाचे निगोशिएशन आणि बाकीच्या काही गोष्टीच्या विषय होते आमच्या काही ऑर्गनायझेशन, तर त्यातही मला व्यस्त राहावं लागलं. आताही मी मुद्दाम 5-1 मिनिटं म्हटलं आपण बोलायचंच, कारण मी डॉक्टर शिल्पाजींना शब्द दिला होता आणि जर शब्द नाही पाळला तर मग राजकारणी लोकांबद्दलचं मत खराब होत जातं. मला वाटतं की ते योग्य नाही आणि म्हणून मुद्दाम आपल्या सगळ्यांच्याशी मी संबोधित करतोय किंवा बोलतोय. मी एक सांगेल की चॅलेंजेस खूप आहेत. अजून आपल्याला आपण जरूर 7 लाखाला टच केलं होतं. आता आपण पुन्हा जवळजवळ 4.5 लाखच्या दरम्यान आपण आलेलो आहोत आणि बरचसं कमी आलंय. आतापर्यंत 60-65 हजार पर डे वर आपण गेलेलो होतो. आता आपण सध्या कालची जर आकडा बघितला तर आपण जवळजवळ मला वाटतं 39,000वर आलेलो आहोत. त्यामुळे त्यातही भरपूर कमी झालेलं आहे. रिकव्हरी रेट आपला 80च्या खाली गेला होता. आता आपण रिकव्हरी रेट मध्ये सुद्धा जवळजवळ 89 रिकव्हरी रेट सुधारलेला आहे आपल्या. त्याच्यात आपल्याला भरपूर सुधारणा आहे. मला असं वाटतं की इन जनरल नक्कीच सुधारणा होतीये. ग्राफ इज डिक्लाइनिंग. दॅट इज अ गुड साइन विच आय जस्ट वॉन्ट टू put before this gathering. प्रश्न एवढाच आहे की आता आपल्याला काही जिल्ह्यांमध्ये निश्चित प्रकारचे डिक्लाइनिंग कर्व आहे, परंतु काही जिल्ह्यांमध्ये ते वाढतोय. पश्चिम महाराष्ट्रामध्ये कोल्हापूर, सांगली, सातारा आणि या अनुषंगाने प्रधानमंत्री मिस्टर मोदी सुद्धा जवळजवळ 17 डिस्ट्रिक्ट मॅजिस्ट्रेट्स किंवा कलेक्टर्सला 20 तारखेला ते बोलणार आहेत आणि त्याची पण आम्ही तयारी करत आहोत सध्या की एक्झॅक्टली आपल्याला कुठे काही जे सेंट्रल गव्हर्नमेंटने सांगितलेल्या नॉर्म्स मध्ये कुठे काही चुका आहेत का, टेस्टिंग पर मिलियन किंवा टेस्टिंग मध्ये कुठे कमी पडलंय का, ट्रॅकिंग ट्रेसिंग मध्ये कुठे कमी पडलंय का, किंवा खास करून आपण जर म्हटलं तर ट्रीटमेंट प्रोटोकॉल जे आहेत त्याच्यामध्ये काही चुका होत आहेत का, इन्फ्रास्ट्रक्चर वाईज आपल्याला ज्या काही गोष्टी लागतात, बेड मॅनेजमेंट असेल, डॉक्टर्स असतील, इक्विपमेंट्स असतील, त्या अनुषंगाने मेडिसिन म्हणून असेल, म्हणजे लॉजिस्टिक्सच्या पर्स्पेक्टिव्हनी काही कमी आहे का, त्या सगळ्याच गोष्टींचा आम्ही अभ्यास करून ठेवत आहोत. मला शॉर्ट मध्ये सांगायचं एवढंच आहे की आपल्याला आपलं चॅलेंज, आपल्याकडे अजून भरपूर आव्हान आहे, भरपूर चॅलेंजेस आहेत. अजून आपण काही विक्ट्री मिळवली असातला भाग नाहीये. थर्ड वेव्हची सुद्धा आज एक थ्रेट आपल्या समोर आहे आणि म्हणून या सगळ्या गोष्टींच्या अनुषंगाने आपल्याला ऑन टोज राहावंच लागणार आहे. आणि मला असं वाटतं की आपण सगळ्यांनी या सगळ्या अनुषंगाने काय काय करायचं असेल ते आपण करावं. आता थर्ड वेव्हच्या मध्ये असं सांगितलं जातं की पीडियाट्रिक इन्व्हॉल्वमेंट खूप जास्त असेल आणि त्यामुळे आपल्याला स्पेशल SNCU वॉर्ड्स किंवा पीडियाट्रिक वॉर्ड्स, त्यांच्यासाठी असणारे व्हेंटिलेटर्सचा मोड पीडियाट्रिक किंवा त्याच्या संदर्भातला मोड तयार करावा लागेल. त्यांच्यासाठीचे जे मेडिसिन्स असतात ते मेडिसिन्स वेगळे असतात, ते आपल्याला बघावं लागेल. आणि इन जनरल आपल्याला ह्या सगळ्या गोष्टींची तयारी करावी लागेल. आता नवीन म्युकर मायकोसिसच्या संदर्भाने काही चर्चा होतीये, तर त्याच्यात आपल्याला एम्फोटेरेसिन B त्याची कमतरता भासतीये. आज आम्ही त्याची 1 लाखाची, परंतु आज जे बेडवरचे पेशंट आहेत त्यांना मी रातोरात, ज्याला म्हणू आपण रात्रभर, आम्ही 12 वाजता मी डायरेक्टर्सला फोन करून सगळ्या डेप्युटी डायरेक्टर हेल्थ यांच्याकडे जे काही उपलब्ध होते आमच्याजवळ अल्फा एम्फोटेरेसिन B ते सगळ्या जिल्ह्यांमध्ये वाटप करण्याचा प्रयत्न करतोय. त्याच्या ज्या ट्रीटमेंट्स आहेत त्या महात्मा ज्योतिराव फुले जनआरोग्य योजनेमधल्या बीचा सप्लाय आम्ही करणार आहोत आणि पॅकेज मध्ये कसं बसवता येईल ते पण आम्ही बघत आहोत. थोडक्यात हे जे काही चॅलेंजेस आहेत, आता रेमडेसिवीर हे जे काही महत्वाचा विषय होता त्याच्यावर आपण भरपूर मात केलेली. आता आपण प्रोडक्शन सुद्धा इथं सुरू केलं आणि दॅट वी हॅव मोर ऑर लेस स्टॅबिलाइज्ड सप्लाय फ्रॉम द perspective of supply of remdesivir. That was really a big challenge in the last month or last 15 days, fortnight. So now that has been stabilized. Even from the oxygen perspective also, we had really done good work that we are at present experiencing and observing. Not many other states, they are so much having mishaps from getting less oxygen or not supplying oxygen in time, and patients are dying because of want of oxygen. And so हे challenges आपल्याकडे नाहीयेत किंवा आपण करू शकलो नाही. आपण we have at least asked every collector to give orders for PSA plants, and so PSA plants, as you know, they are pressure this swing type absorption oxygen manufacturing plant. We convert oxygen from atmosphere to get to the purity of 95+%, and we use that oxygen. So approximately we have asked every collector to give order for every block. Like block means rural hospital, RH, and we should be self-sufficient in all respects to in case of preparedness for the third wave from the oxygen perspective. So we should be self-sufficient. आपण स्वतः स्वयंपूर्ण असायला हवं ऑक्सिजनच्या बाबतीत. आपण स्वयंपूर्ण असायला हवं रेमडेसिवीरच्या बाबतीत. आपण स्वयंपूर्ण असायला हवं आपल्याला लागत असणाऱ्या सगळ्या अँटीव्हायरल आणि अन्य ज्या काही आवश्यक बाबी त्याच्या. We should also ramp up capacity from beds perspective. So from all angles, मला असं म्हणायचं की we should be ready for the third wave. साठी डॉक्टर्स कुठून आणायचे हा मोठा प्रश्न आहे. त्यामुळे ट्रेनिंग हा आम्ही एक फार महत्वाचा भाग मनावर घेतलेला आहे. मला असं वाटतं की तुम्ही कोणीही डॉक्टर असो, तुम्ही कोणी पिडियाट्रिक असू शकाल, कोणी गायनेकोलॉजिस्ट असू शकाल, पण माझं म्हणणं आहे की जर RH ला रुरल हॉस्पिटलला जर आपण कोविड TCHC केलेला असेल, if we have given a nomenclature of center, so in that center also, if there is a requirement of a doctor who can put the patient on BiPAP or on CPAP or like on NIV, so the doctor MBBS also should be able to maintain or should be able to operate the ventilator, and he should be trained from that perspective as well, so that there is no requirement of reference of the patient from the RH to the district hospital or to the higher tertiary care center. So in this way, we have to see from the to the training of the doctors, even from any specialty, he or she should be trained. The doctor should be. So that is also one of the important target or goal we want to achieve. And while preparedness, so from preparedness angle, we have to be really prepared for the third wave, because I don't know to what level we will reach, but hope so that the third wave should not be more dangerous than the second wave which we have faced at present, because casualties also has increased in the second wave. And of course, my humble request to the total doctor fraternity present over here in this webinar, that please ensure that even the general practitioners, suppose from other pathies like BHMS or BAMS or Unanis, those who are practicing in the rural area, and they should not entertain the patients who are really experiencing the COVID symptoms, and still we are admitting the patient and entertaining him for 3, 4, 5 days, and then he becomes bad, and then we are getting him admitted to the tertiary care center where he immediately needs ventilator. And once he has become, once lungs are so much involved and there is a lot of fibrosis in the lungs, then it becomes very difficult for the doctor even to really get him well soon. So या सगळ्या गोष्टींच्या अनुषंगाने मला पुन्हा एकच सांगायचंय की या बाबी सुद्धा आपण लक्ष द्याव्यात, आणि जितकं सांगता येऊ शकेल डॉक्टर्सला पटकन जर कोणाला सिम्पटम्स असतील तर आपण टेस्टिंग करून घ्या. इमिजिएटली जर हे असेल तर आपण पुढे पाठवा आणि ट्रीटमेंट सुरू करा, हे सुद्धा सांगणं फार गरजेचं आहे. तर मला वाटतं ह्या काही महत्वाच्या छोट्या मोठ्या सूचना होत्या, काही डॉक्टर्ससाठी होत्या आणि काही एक नक्कीच की तुम्ही माझ्या सूचना होत्या, काही विनंती होती की आपण कशा पद्धतीनं पुढे काम करूया, टीमवर्कनी करूया. डॉक्टर्सच्या बरोबर शासन आहे. तुम्हाला काहीही सूचना करायच्या असतील, तुम्हाला काहीही प्रॉपरली सांगायचं असेल, जरूर आय एम रिअली यू आर मोस्ट वेलकम टू शेअर एनी ऑफ युअर एक्सपिरियन्स ऑर एनी सजेशन्स. काही तुम्हाला कळवायचं असेल, सो आय एम ऑलवेज ॲट युअर डिस्पोजल. You please let me know. My even email is rajeshtope11@the or you can just WhatsApp me anything. But in the interest of patient and the larger interest of Maharashtra, your suggestions are welcome. And आपण सगळे टीमवर्कनी एकत्र मिळून खूप चांगलं काम करूया. मला वाटतं एवढीच मी या निमित्ताने व्यक्त करेल आणि खूप चांगलं सजेशन्स तुमच्या असतील. मला एकच सांगायचं शिल्पाजींना आणि दिनकर देसाईजींना की प्लीज डॉक्युमेंट व्हॉट एव्हर been discussed, deliberations, and please document it everything. And if you can just share with me, I can forward it to my department.
Yes, sir.
So as a secretary, health and to my directors of my department and whatever suggestions has been given by doctors in today's webinar, we can put into action. So these are suggestions and ideas which you people have given. So
one small request, sir, in this connection,
converted to action. So that is what I wish from the output of the today's webinar. So looking forward for your documented piece of article. So someone should please do that very religiously. And best of luck, everyone, and
sir,
all the best.
Sir, on behalf of Pathologist Association, sir,
go ahead.
We have seen ki tracing, tracking, testing, and treatment is the Chatusutri of the present formidable defense. But for testing purpose, sir,
go ahead.
Pardon? Testing purpose, nobody has been inducted in the task force, either original or the pediatric task force.
Hello, can you hear me?
थोड़ा कम आ रहा है सर. Hello. Hello. Tope sir.
Voice is breaking.
Voice is breaking.
Yeah, his PA said me that they are in an area which is where the network.
Convey me the name, please.
Yes, sir. We will convey. Okay, sir. And thank you very much on behalf of our Pathologist Association and all the doctors, COVID warriors who are intensives who have joined for this today's session. And thank you very much, sir. On behalf of our association, sir, this is a memento for your kind presence. Thank you very much, sir. Yeah.
Thank you so much, Tope sir, to honor our invitation. Thank you, sir.
So you can carry. Dr. Meenal Gadgil?
Yes, sir.
So you please carry on the proceedings.
Good afternoon, everyone. I am Dr. Meenal Gadgil, privileged to invite our next speaker, Dr. Lalit Sankhe. today we are staying in a world of a fear where just sneezing also makes us disturbed. So during this time, the topic like influenza and COVID-19, the similarities and differences becomes very important for us. I would like to invite chairpersons, Dr. Vipin Checker, who is ex-president of AMC and ex-vice president of IMA Maharashtra. Please welcome, sir. Would like to welcome Dr. Pankaj Bachchav, who is a physician and who is working as an intensivist in Global Hospital. As well as I like to request Dr. Shilpa Gupta also to join the session, who is working as an intensivist in Thane Healthcare Hospital. And our speaker, Dr. Lalit Sankhe, who is HOD of PSM at GMC and JJ Hospital, Mumbai. He is a nodal officer for COVID vaccination at JJ Hospital and was instrumental in promoting indigenously developed COVID vaccine. He will enlighten us with this topic, influenza and COVID-19, similarities and differences. Please welcome Dr. Lalit Sankhe.
Thank you, Dr. Gadgil, for nice words. And thank you, the association, that is the Pathologist Association, for inviting me for this particular topic. And then I would love to share a story about Dr. Tope and my interaction when actually he came for the COVID vaccination to JJ Hospital. And then he was more interested to know about influenza and COVID. The symptoms are same, everything is same, and then what do you think? What is the correlation? Is there a co-circulation and this and that? He's so interesting, and definitely he's so impressive too. He was talking to a point, maybe a medical fraternity like us, maybe sometime gets, wondered how these politicians have so much of knowledge. And somebody introduced him as a Dr. Rajesh Tope. It's totally appropriate. I personally feel so. So thank you once again for inviting me for such a simple but interesting topic. I can see a couple of familiar faces. Like Vipin Checker, who is chairing the session, is my colleague from JJ Hospital. He was junior to me by maybe 2-3 years in JJ. Vipin, how are you? I hope everything is good. Yeah, that's great. And I'm thankful to Dr. Vedhas for actually telling me that I should talk to you people on, maybe share some knowledge about influenza and what are the similarities and the disparities during this COVID-19 pandemic, what we have. I'll just share the screen for you people. Actually, I'm not in the introduction, I was introduced as an head of the department, but I'm not head of the department. I'm just a simple associate professor who works in the Department of Community Medicine at Grand Medical College, Mumbai. And I'll just take you through the brief about what do we understand by influenza. Everyone is aware about influenza. It is an acute febrile, highly contagious respiratory infection characterized with sudden onset of fever that is more than equal to 38 degrees with myalgia, which can cause hospitalization or even deaths. So is it not the same what we are facing today? Yes, COVID pandemic has even highlighted that influenza and viral diseases, whenever we start discussing about COVID-19 pandemic, we refer to influenza pandemic or the Spanish flu pandemic, what we had in 1980. As per WHO, every year around 5 to 15% of the populations are affected with influenza. Influenza leads to almost 3 to 5 million cases to severe illnesses and around 6 lakhs of deaths in a year globally. influenza virus, same like what we see, the spike proteins, this, that, and it's almost same, everything. And again, what we are discussing about antigenic shift and antigenic drift, and these are all technical words which we are using, that has been there since maybe 1933 when we isolated the influenza. Basically, there are three types, type A, type B, and type C, but major important is type A and type B, which have a tendency of changing or doing antigenic shift. That is, they totally shift their uh, features, and then they come up with the new strain, as what we are getting presently. So type B has two strains, that is Yamagata and Victoria strains, which are, they usually mutate very slowly, but type A is very severe and which usually have the pandemic effects. Pathogenesis of influenza, it's a droplet infection which destructs epithelial cells from the nasopharynx to alveola, and then there is a body response, local inflammatory reactions of upper respiratory infections, and then there is systematic body reactions as fever, muscular pain, etc. So again, if you really see the symptoms or the pathogenesis, it is again the same as what we see in the COVID. Symptomatically and the demographic prevalence, influenza affects children about like prevalence is 20 to 30%, and adult it is 5 to 10%. But now with the new strain which is coming in, what we are expecting that pediatric, the wave 3, which will have the pediatric. So is it the same what influenza taught to us during last, maybe since 1933, when we isolated the vaccine or isolated the virus? And again, the high risk group, what we have talked about in what we discuss about influenza are children younger than 5 years of age, adults 65 years of age and older, pregnant women, immunocompromised people, people with chronic underlying medical conditions, and none less than what we are, like healthcare workers and vectors spreading the diseases to the vulnerable patients. So this is it not the same what we talk about the COVID? Yes, again. Influenza, again, symptomatically, it has headache, running, a nasopharyngeal, like runny and stuffy nose, sore throat, aches, coughing, vomiting, muscular pain, then aches, body aches, fever, and these are all the symptoms what we see at the juncture. And then again, the incubation period for influenza is 2 days, and influenza virus infects the respiratory tract. That is what, again, same what is happening with the COVID, and we have severe coughs which last for 2 more weeks. Now, what we have, basically influenza, what we have is the virus which was developed in around 1938, and then we have come across various changes. Like we have almost started with monovalent vaccine, and then subsequently, presently, what we have is a quadrivalent vaccine. I would like to highlight here is it has 3 times high risk of hospitalization in diabetic patients. If immunized, then 43 to 79% can be reduced. Around 6 times risk of heart attacks in cardiovascular disease patients. If immunized, up to 67% hospitalization can be reduced. And same with the 30% case fatality rate in COPD patients, and that can be reduced up to 54% of hospitalizations, and maybe around 76% reduction in COPD patients. So if we vaccinate people, then we can reduce the hospitalization, and these are the benefits what has been seen in these studies what are conducted till now. Then flu prevention can reduce healthcare cost and overall hospitalization and insurance claim. That is what Mr. Rajesh Topeji was talking about. We need to strengthen healthcare system. We need to reduce the healthcare cost and overall hospitalization in the COVID patients too. Now let's try to understand what are the similarities or how influenza and COVID-19 is. The most effective way to prevent influenza and severe outcomes from influenza is vaccination. And we have safe and effective vaccinations are available and have been used for more than 60 years. This is what WHO position facts talks, which are published in 2000. Now, there are numerous overlaps in the risk factors of influenza and COVID-19 infections. As I was discussing about influenza, COVID is seen in advanced age, obesity, underlying comorbidities like chronic lung diseases, cardiovascular diseases, chronic kidney diseases, diabetes, and maybe global this thing. It is more in the residents in the nursing homes, like old age homes, or maybe the prisons where there can be more infection, spread of infections of COVID-19. Then these are the complications. What we can think about: influenza can lead to pneumonia, respiratory failure, acute respiratory distress syndrome, cardiac injuries, multiple organ failure, worsening of chronic medical conditions including lung, heart, nervous system, diabetes, inflammation of the disease, heart, brain, and muscular issues. Same what we have been discussing throughout the day that is where we are actually worried about. And my subsequent colleague will be talking in detail about the COVID-19 management, etc. But now with mucormycosis, what we are talking, like we need to control diabetes and this and that. So same type of complications are seen following influenza and COVID-19. Yes, there is co-circulation of COVID-19 and influenza, worsen the impact on healthcare system that is already overwhelmed because of the COVID-19 pandemic. And this is what Mr. Tedros, who is Director General of WHO, stated on the 28 June 2020. Yes, co-infection is there. Cases reported, studied co-infections, and there are couple of studies which reports around 3 to 4% of the thing is co-infection of COVID already diagnosed. Now, if you really see what was the condition before COVID, around 62% of the employers did not have a plan to tackle this outbreak. Why employers, everyone, we were never prepared for COVID. We were never prepared. This whole health system was. Now after COVID, how prepared are we today? This is again an issue and a challenge. Now Honorable Minister was here, and then he has already mentioned, and today there was a Zoom meeting which are organized, and where our CM Devji Thakre also spoke to all the general practitioners across Maharashtra, and there were around 20,000 general practitioners practicing at the village level, and maybe at the most rarest place, let it be the allopathic doctor or Unani or Ayush practitioners. So Uddhav Thackeray also mentioned about we need to be prepared. We need to understand what we need to strengthen about the healthcare system. That is what at the ground level or at the rural part of the Maharashtra. It is possible that coronavirus threat will eventually fade, as we know the stories of H1N1, Ebola, Zika, SARS, and many more. But even if it does, the next devastating or yet unknown outbreak is not so much matter of if but when. So basically, we need to understand and strengthen our healthcare system. We need to understand that if we have a good healthcare system, then that is the best what we can give it to the society. What does holistic well-being means to us when we talk about this particular pandemic? Do we consider pandemic preparedness as a part of holistic well-being? This is a question which needs to be answered. Do we consider all aspects of prevention? Again, this is a question which needs to be answered usually. Yes, but few things are important. That is, are we utilizing what we already have? I'm taking you towards the vaccination, what we have against influenza. So we need to understand the importance of the vaccines which are available in the market for the treatment or prevention of the disease as such. As I was talking about flu-related hospitalization, leading causes, it's again the same slide. But what I want to highlight is the benefits of flu vaccination can help reducing flu-related risk of hospitalization by average 41% in. So we need to, if we could cover this population, the high-risk population are diabetic patients, cardiovascular disease patient with COPD, stroke, and maybe with acute respiratory infection with influenza, then we might maybe we'll be able to prevent a hospitalization for almost 41% of them. Okay, this slide is a bit doesn't fit here, but I just wanted to highlight that there are barriers for not only influenza virus, and the causes remains the same, and it is for the COVID vaccine. It is COVID vaccination also. The cost of vaccination, there are no convenient vaccination clinics, fear of vaccine adverse event, and so on. Fear of needles. Do not feel like we don't feel like we are at risk of infection or something like that. So these are the barriers which are there in healthcare workers as well as basically, and then the major what we try to understand is about the misconceptions about the vaccine efficacy, and then there are so many effectiveness, and there are so many words which my previous colleagues spoke about in vaccines development and vaccine issues. Okay, then yes, influenza reduces productivity in several ways, like absenteeism, absent employees reduce the productivity, presenteeism, then medical costs, replacement costs, and so on. This is basically why we should vaccinate against influenza. This is important in care when we talk about influenza vaccination is the best approach, but still when we are talking about the COVID vaccination is the best approach when we are talking in terms of vaccination. And then hand hygiene, healthy lifestyle, smoking cessations are important. Annual vaccination is best way to prevent influenza and its complication, as I really don't know about how it's going to be, whether it's going to be annual or it's going to be lifelong about COVID, but still that is what we need to prevent the cause. Then immunization benefits the individual, the workplace, and the family. And the following diagram talks about if some people get vaccinated, then the virus can spread. The person who is the same spreading the disease, and there are no people healthy, vaccinated people are in yellow, and bluish are healthy, non-vaccinated. So in left-hand side, you can see there are more non-vaccinated people, and what can convert is the spread of the virus. And then same way, if you really see on the right-hand side picture, if most of the people get vaccinated, then spreading is contained. And then there was a question of somebody had asked question to the previous speakers about how we are going to have the better effect of vaccination. If more people are vaccinated, then we will be able to maybe stop spreading the disease. And recent CDC guidelines, what they have opened up no mask at United States, who are basically those who have taken both the vaccines. So that was maybe 2 or 3 days before. What did we do during this pandemic, immunization guidance during this pandemic? I'm going to be very specific about what immunization guidelines were prepared for. The guidelines for management of co-infections of COVID-19 with other seasonal epidemic-prone diseases. OHF points out that vaccination for seasonal influenza for healthcare workers and other high-risk group to be implemented aggressively to avoid maybe the co-circulation. Same where the WHO talks about wherever feasible, influenza vaccination for healthcare workers, older adults and pregnant women was advised by WHO in their interim guidance on 26 March 2020. WHO said that that is strategic advisory group of experts recommended that highest priority should be given for healthcare workers, older adults, and other pregnant women, other priority groups, pregnant women, and individuals with underlying health condition, children should be vaccinated for seasonal influenza vaccine during COVID-19 pandemic. There are various organizations which also supports the influenza vaccination across. And then the tagline for today is the same. I mean, we need to understand what we can prevent, what we can be prevented. That is what we need to understand, that we need to prevent all vaccine preventable diseases. And then influenza remains one of the important diseases. To summarize my talk, influenza vaccinations are efficacious, and there are 3 reasons why we should vaccinate people. That is, first is for prevention of influenza and the post-circulation. Then we really want to reduce the burden on healthcare systems and everyone, because we are the backbone of the healthcare system, and we know last 1 year plus we have been working day in and day out. There are people, we have lost so many of our friends and this and that. So we need to reduce that burden, and that can be reduced only when we have good solutions and when we introduce that solutions like vaccinations for various diseases as such. And then the last one is to reduce the risk of catching influenza, which will again reduce the burden on the healthcare system. Thank you very much for patient listening.
Unmute.
Thank you.
Hello, sir. I'm Dr. Shilpa Gupta.
Hello.
Can you hear me?
Yes, I can. Dr. Shilpa.
I've been seeing some of the questions in the chat box, sir. Very informative talk this first. First, I should thank you for that. There is somebody who's asking, can influenza vaccine and COVID vaccine be administered together? If not, how much should be the gap between the 2 vaccines?
Actually, the gap between the 2 vaccines should be ideally 28 days. But some vaccines with COVID, like the rabies, what guidelines what we had received for rabies vaccine was 14 days. So, and this the seasonal influenza vaccine, what we have is Southern Hemisphere and then the Northern Hemisphere, and we should vaccinate for a better effectiveness in our country. But we fall in a tropical part, and we are to the Southern Hemisphere. So Southern Hemisphere vaccines are usually made to April to July. So this is the time, if we get vaccinated shots of Southern Hemispheres, they are more effective. So we need to plan our schedule accordingly. But it should be 28 days apart.
Thank you, sir.
Thank you, Dr. Sankhe, sir, for that wonderful, informative talk. I would request Piyush to kindly present Dr. Sankhe, sir, with a memento.
Thank you,
Dr.
Vedhas.
Lalit Sankhe, sir, I request you to accept this virtual trophy on our behalf. And
Thank
a
you.
big round of applause for him.
Thank you, Vedhas, and I hope I'll get a real one too.
Yes, sir. Sure, sir.
Okay.
We'll courier it to you. Don't worry.
Yes. No.
I'd like to call upon Dr. Jayanti Bhate to introduce our next speaker. Dr. Jayanti Bhate, are you there?
Yeah, I'm there. Thank you, Vedhas.
Over to you, ma'am.
Yeah. The next talk, we have the chairperson, Dr. Yogesh Sharma, who is the head of department, Rajiv Gandhi Medical College, and he is the head of department medicine and also the chairman of the Thane task force. He was the dean of the global hospital, the COVID hospital, which was running then. We have the second chairperson, Dr. Sita Raju, who is a leading physician attached to Param Hospital, and Dr. Priya Choradia, who is a leading physician and intensivist. All these chair people are actively working as COVID warriors in Thane task force. And the speaker for today's topic is Dr. Anand Bhave, who is a renowned consulting physician and attached to Jupiter Hospital and the Param Hospital. He's a member of the Thane COVID task force, and he's going to be enlightening us on the emerging therapies in COVID. Over to you, sir. Thank you.
Dr. Murik will be also joining as chairperson sooner. So,
okay, yeah, fine. Yeah, welcome, Dr. Nimkar.
Can I share my screen?
Yes, sir.
Presentation. Presentation start slide show. Oh, okay. This time, but it is being covered by that Zoom task. Sorry.
So let's help you. Khalti, right bottom.
Don't worry. I am there. My technical backup is very much here. So, good afternoon, everyone. I've been given this task of talking about emerging therapy in COVID. It's an endless topic because there are literally hundreds or even thousands of molecules for COVID. Now, what is common between the plague that we had? परत window हलवायला लागेल. Okay. So what is common between the episodes of plague that we had in the past, the Spanish flu and COVID? It is that the screen is not moving now. Which slide nahi yet. Can we minimize it?
Sir, तिथेच right click करा.
हो करतोय. हे करा ना play. Okay. After right click start. Thank you. This is a picture of a doctor from the plague era. At that time, they believed that it was caused by some kind of a bad or asthma. So they used to wear such masks. And in the beak of the mask, they used to keep some herbal leaves or flowers so that they will get a good fragrance and the miasma will stay out. This is a picture from the Spanish flu 1918, where you can see the family and the cats are wearing the mask. And this is a modern COVID pandemic photograph. So what is common in all these three is that all of them had this dangerous of cytokine. So what is cytokine storm and why is it killing people? And can we find some therapies against that? So basically, when the virus enters the body, the first line of defense is complement, which actually destroys the virus. And complement does another job. It will capture the virus and take it all the way to the local lymph nodes. So if the virus has come through the lungs, then the virus will be captured and taken by complement to a mediastinal lymph node. In the cortex of the lymph node, there is this follicular dendritic cell. On the surface of this cell, the virus is displayed like a notice board. So there are many B cells which are passing every second through this lymph node. And when the specific specialist correct B cell comes along, it realizes that there is a notice, the COVID virus has entered. And that is a signal for the B cells to multiply rapidly and make antibodies. This process from entry of the virus to the activation of this adaptive immune system takes at least 5 to 6 days. Until that time, it is our innate immune system which is doing all the fighting. The virus enters various cells. Now, the normal cells, they will fight back by using interferon. When a virus enters the cell, these receptors called pattern recognition receptors, they are alerted and the cells start making interferon to warn the other cells. And interferon also stimulates the synthesis of antiviral proteins and tries to counter the virus. The virus also is detected by macrophages which are waiting, and they start the fight by phagocytosing and destroying the virus, and they release lot of cytokines. Note that interferon is also a type of cytokine. Macrophages are almost like factories of cytokines. What do these cytokines do? They will open up the blood vessels, allow neutrophils to come in, they will attract other cells, activate other macrophages, activate neutrophils to fight the virus. And importantly, they will stimulate the natural killer cells to join the fight. The virus which is outside will be captured by macrophages and neutrophils, whereas the virus which has entered the cell, that cannot be captured by these. So the natural killer cell will recognize which cells are infected and destroy those cells. The virus is also detected by the dendritic cells. But these cells, they don't stand and fight over there. They will also go back to the lymph node and they will display the virus on the surface of the cell. The T cells have to be brought into the picture. So when the virus is displayed by the dendritic cells, the killer T cells are activated to go back to the site of action and kill the infected cells. And the helper T cells are activated. They are like commanders of the fight, and they send cytokines to stimulate the B cells, the dendritic cells, the macrophages, and the killer T cells to join the fight. They themselves, the T helper cells, don't fight, but they already coordinate the fight. So basically, it's the macrophages, the dendritic cells, and the T helper cells which are the main sources of cytokines. Now, when the virus is destroyed, all this immune response has to be switched off. So firstly, the level of the virus goes down. As more and more virus is destroyed, the antigen falls and the stimulation is switched off. If that doesn't happen, then there is a continuous stimulation by the immune system. The fighting cells, that is macrophages and the dendritic neutrophils, all have a limited half-life. So naturally, they will start dying off after the job is done. And there are some regulatory T cells which make the anti-inflammatory cytokine interleukin 10 and TGF-beta. So this would be the normal expected response, that you kill the invader and switch off your immune system. But this doesn't happen all the time. Supposing there is a reservoir of virus in the gut which keeps on stimulating. Supposing there is a deficiency in interferon or in the innate immune system, then the virus is not totally destroyed. There can be genetic defects when the dendritic cells will not die but keep on stimulating the the immune system. And all these reasons tend to continue the immune response, leading to a hyperimmune response. Now, the cytokines are very important and they do a vital job by calling other cells, stimulating the cells, and creating inflammation to fight. But if there is excess of a good thing, that also can be very bad. So if the cytokines are in excess, they have serious effects on the entire body. They can cause coagulopathy with thrombosis everywhere, endothelial damage, increased capillary leakage, pulmonary edema, elevated liver enzymes, hypoproteinemia. Of course, damage maximum is in the lungs because the infection is mainly in the lung. So the organ which suffers first and the most is the lung, causing ARDS. Then they can cause delirium, fever, fatigue. They can cause a type of cardiomyopathy and various other symptoms. So this is just what we can refer to as a cytokine storm. These are the main cytokines. Interleukin-6, which is secreted by macrophages and T cells and endothelial. It's a pro-inflammatory cytokine. And interleukin-1, again made by infected cells and macrophages. Tumor necrosis factor, made by natural killer cells, T cells, macrophages. This has effect of increasing vascular permeability, activating the other cells. GM-CSF. We know GM-CSF as a colony stimulating factor for the bone marrow, but actually it is a cytokine by itself and it is pro-inflammatory. And the VEGF or vascular endothelial growth factor is also a cytokine. And if we can control the activity or overactivity of these, then maybe we can tackle cytokine storm better. So trials are going on against every one of these cytokines. About interleukin-6, I will not speak because it is accepted therapy, tocilizumab. It has been shown by these trials. But the others, etanercept, which is a receptor for TNF, these two anti-TNF antibodies are in trials. Solidarity, Catalyst, Avid-CC are the names of the trials. Similarly, interleukin-1 receptor antagonist or antibody are in trials. This particular trial, Corimino 19, has failed, but the other trials are still going on. VEGF is antagonized by this monoclonal antibody, bevacizumab, and it was studied last year in Italy and China. There's not much activity with this, but in India, I know they use this because the approved therapy, that is tocilizumab, was not available easily. So people are looking for the alternatives. And GM-CSF is very much in trial. And in fact, some of the monoclonal antibodies against that in trial have shown some promising results. Now, one thinking is that instead of trying to block all these separate cytokines, can we block something which will stop the action of what I said once? This photograph is Janus, the father of Zeus in Greek mythology. Notice that it has two heads facing on opposite sides. Because of this, a certain group of enzymes, tyrosine kinases, are known as Janus kinases. See, this is interleukin-6 molecule. If it is allowed to interact with the receptor of the cell, it stimulates the receptor. And these are the two Janus kinase enzymes sitting on either side of this receptor. So they will phosphorylate it and activate it. So the importance of Janus kinase enzymes is that they are the ones which allow the cytokines to act on the cell. Then they will activate the further proteins called STAT proteins. And these STAT proteins, when they are activated, they will cause effect on the nucleus of the cell. So if the cytokine is to have any effects, it must attach to the receptor, stimulate these enzymes, the JAK enzymes, stimulate an effect on the nucleus of the cell to be activated. So interleukin-6, interleukin-1, interleukin-2, This is TNF alpha. These are all various cytokines, interferon, and many of them GCSF. They are acting through this JAK system. So there was a thinking that if we can block this JAK, then it will block many cytokines at once instead of blocking one of them at a time. So trials were done with baricitinib, which blocks the intracellular effects. And this drug was already in use for treatment of rheumatoid arthritis and for some other autoimmune disorders. Along with that, baricitinib also blocks the entry of the virus by disrupting this enzyme. It is given 4 milligrams a day for 10 days. The trial was done in combination with remdesivir. The trial is available in the standard textbook. Basically, what it achieved was, when given with remdesivir, it achieved earlier discharge, earlier oxygen, and more benefit in patients who require non-invasive ventilator or HFNO. But this trial could not demonstrate whether adding this baricitinib to steroid is beneficial or not. That is still not clear. Another study showed a good recovery in 83 moderate to severely ill patients of COVID, and including 48 patients of pneumonia. Tofacitinib is another JAK inhibitor, and but all JAK inhibitors, another trial with ruxolitinib failed to show any benefit. For tofacitinib, there is one trial which is published in Mayo Clinic Proceedings, where they showed that combination of dexamethasone with tofacitinib was better than tofacitinib alone. It's not a very big trial, 269 patients, but it did show a significant improvement. So this drug also deserves further trials and experimentation. When you use these JAK inhibitors, when to use them? First, if you don't see the benefit in terms of improvement of oxygen, reduction of fever, or drop in CRP, while using them, you have to watch out for the side effects. There are known compounds which can cause severe thrombosis. And as we know, COVID is a disease of coagulation in many patients, and not to be used early in the disease, not before day 6. So considering all these things, on the 3rd of May, the Gujarat Rheumatology Association has come out with this guide. Many of you must have seen through social media. In the first 5 days, no immunomodulators, except you may consider inhaled steroids. And if those patients who are getting fever or signs of inflammation, abnormal markers after the day 6, then oral steroids or IV steroids. Baricitinib is one choice, or tocilizumab. Now, if you start baricitinib, at least up to date recommends that then you don't use tocilizumab because it would be too much of immunosuppression. But there have been no trials doing this. So if tocilizumab is not available, one can probably consider baricitinib or tofacitinib. And only if tocilizumab is not available, because that is a proven one, the others are all unproven. Only if it is not available, you may consider infliximab, itolizumab, or bevacizumab. They have minimum data, and they can be only taken as experimental if tocilizumab is not available. But I know for a fact, several of my classmates, Dr. Pankaj Gandhi, Dr. Pataria, they have good experience with using some of these molecules. And as the trials progress, we will come to know how many of these molecules are useful and whether they are better than tocilizumab or not. There's a good trial going on even with etanercept. The other experimental therapies, one is based on bradykinin. Interleukin 1, interleukin 6, they stimulate kallikrein system. Now, kallikrein, which breaks down kininogen to synthesize bradykinin. Bradykinin is a vasodilator and increases the permeability of the capillaries, causing pulmonary edema. So this can be blocked by icatibant, which is a selective bradykinin B2 receptor antagonist. It's already available. It's used for angioedema. It's an injection, subcutaneous, and it is going on in trials. This is the name of the trial, I-SPY COVID trial. Another Another experimental antibody is done, which is an antibody against kallikrein. This is also given subcutaneously by injection, and a consortium of 3 companies is doing this trial. A group of drugs which are used by oncologists in lymphoma or chronic lymphocytic leukemia, is also being tried in COVID. And these are acalabrutinib and ibrutinib. What do? Is they inhibit macrophage activation and interleukin-1 release. So they could be of use in COVID. But so far, Conclave and alcohol trials, out of that, Conclave has not shown much benefit with acalabrutinib. So only future will tell. There are many novel therapies or even science fiction therapies coming up. Now, prazosin is a drug we all know, and it's being tried by Johns Hopkins because the sympathetic overdrive also stimulates interleukin-6, and prazosin blocks that. They are trying inhaled small molecular interfering RNA. So you inhale these bits of RNA and try to prevent malnutrition. Now, we just saw that the T regulatory cells dampen the immune response and stop the cytokine storm. So they are using this antibody intranasally to induce the regulatory cells. These are natural killer cells which are being given by intravenous therapy. So they are allogenic, means belonging to a different person, but they are being given by intravenous therapy. And also ready-made antiviral CD4 and CD8 cells. All this is basically science fiction, but they could be the important biologic therapies of the future. What are exosomes? This is a cell. From inside the cell, this is called a multivesicular body. It fuses with the cell membrane and releases these vesicles. These vesicles are called exosomes. This is a normal phenomenon going on in all the cells. Such exosomes can contain nucleic acid, lipid, proteins, and on the surface, they carry some markers. They are probably like messengers between the cells, transferring vital information. So these exosomes are being now used. One trial is using inhaled exosomes. On the surface of this, there's a CD24 protein which is deposited on these exosomes. By inhalation given for 5 days, this inhibits the secretion of cytokines, still under trial. Another trial by a company called ExoFlow, they are signaling exosomes. They are derived from human mesenchymal stem cells, and they are given intravenously for ARDS patients. Again, absolute science fiction therapies. Israel is somehow making a lot of progress in immunotherapy, and a company from Israel called Enlivex, this has made the marketed this therapy, which is used also for cancer and being tried in COVID. They are mononuclear cells which are collected from healthy donors. They are treated to express this cell is going to undergo apoptosis. They are expressing these on the surface, and then they are given intravenously to the COVID patients. The idea is that when they are injected into COVID patients, the activated macrophages or other overactivated macrophages in the patient, they will eat up these cells, engulf them, and calm down, thus calming the cytokine storm. So this has been already tried in Israel for critical patients with some stunning results in very small trials. What would be the future? There are so many antivirals, antibodies, anti-cytokine storm drugs, ARDS treatments which are under development. Now, I'll just briefly cover some treatments which are going to be available to us soon. Monoclonal antibody therapy was given to President Trump, and one of the monoclonal combinations has come to India. It has been given approval. Cipla is going to market that. Cost will be quite heavy, around 50 to 55,000. It's a recombinant monoclonal antibody against the spike protein of COVID virus. These are 2 antibodies, and they are mixed together and given intravenously. Why 2 antibodies? Because each antibody attaches to different part of the spike protein, so that if the virus has shown some mutations, at least one of the antibodies will attack the virus. So far, it has been found in UK, US, Brazil, and South Africa. a study of 4,000 patients showed that the need to get hospitalized is reduced by around 70% when compared to placebo. These antibody injections can cause nausea, rash, paralysis, fever, and flushing. You have to watch out for that. This is basically OPD therapy. It's not for admitted patients. The idea is that if the patient is already in the 6th or 7th day of illness, that patient already has his own antibodies. You don't have to give him monoclonal antibodies. But in the early stage of the illness, to control viral replication, now some patients who are at risk of getting severe COVID, like older, obesity, hypertension, ISD, if these risk factors are there, then you may consider giving monoclonal. To give, they have to be given within 3 days of the diagnosis. So as soon as the diagnosis is made, you have to give those antibodies. The next one, which is coming to India, is interferon. Basically, whenever any virus enters the cell, it is detected by a receptor in the cell, gives a signal to the nucleus, and the cell starts making a lot of interferon. The interferon goes to the neighboring cells. It is a warning to the neighbors that we are under viral attack. Interferon receptor signals the nucleus, and that cell starts making antiviral proteins. Interferon is made by all body cells, not just immune cells. It's a universal response. So in interferon trials in India, it is coming out as a single injection of pegylated interferon alpha 2B. It's a small trial, 250 patients, and they showed a clinical improvement, which is better on the 8th day. RT-PCR becomes negative earlier, and they have reported less number of oxygen if the patient requires oxygen. Basically, this has to be taken with caution because in Solidarity trial, they could not prove any benefit with interferon. In US, a trial of interferon is going on. There are many trials with interferon. Some are inhaled interferon, given as soon as the diagnosis is made. And this is done by a British company that might come into clinical practice. But if you give interferon late to seriously ill patients, then you can cause worse prognosis because of cytokine. So you can't use it if the patient is in cytokine stop. This is one antiviral which is being tried. It's a prodrug which gives rise to this nucleotide, and that nucleotide interferes with the process of viral multiplication. In this big study, move out study, 2,000 patients, viral culture became negative at 10 days in only 24% of placebo group, but in all of the treated groups. So it causes in OPD patients, it causes the virus to become negative very early. The dose is 800 milligrams twice a day. We don't know when it will come. It's still under trials, but it is already being publicized as one of the possible candidates. There are many other antivirals in studies. Our well-known drug nitazoxanide is being tried for prevention and early treatment. Niclosamide is also under trial. It reduces the load of the virus in the intestine because COVID really affects the intestine also. And Yogesh Sharma is also part of a trial with these drugs. Oral protease inhibitor as well as IV protease inhibitors are being tried by Pfizer. We all know that lopinavir, ritonavir was not very effective. So these are the new protease inhibitors. Remdesivir is now being tried as a nebulized form and an oral form. It will make it easy to give it to a lot more patients early on. Even emetine, old drug which was used for amyloid, has a potent activity against coronaviruses, and they're checking out to see if it's any good. And then new drugs like RBD binding drug by Novartis, and this drug is under trial in UK in the Accord study, benzatinib. Now, this is actually an antidepressant. It's an SSRI group of drug, and it has some activity in regulating cytokine synthesis. There are 2 studies with this. Tablets are available, 50 and 100 milligrams. It is available in India, but it's not part of any guideline anywhere in the world. It's something which makes bulimia, depression, panic disorder, etc. it was demonstrated by Dr. Lenz and others, published in JAMA, that OPD patients given 100 milligrams twice a day for 2 days and then 3 times a day for 13 days. In 152 patients, it reduced the deterioration of these patients. And another trial reported in by Saftil et al., 50 milligrams BD for 14 days, again reduced the chance of hospitalization. It is believed to regulate cytokine production. By antidepressants, it can cause headache, insomnia, restlessness, nervousness, nausea, and diarrhea. So, but it's an oral drug available in India, so I thought at least I should mention it. Inhaled steroids now they are becoming part of the guideline, and they should be given early. There's a trial called STOIC trial in UK. 139 patients were given usual care versus inhaled budesonide for 7 days, and less number of patients required emergency care or hospitalization after using budesonide. Only 1.4% of patients who used inhaled steroid required urgent care versus 14.4% of the people who did not get budesonide. So this is another useful thing which may be applicable in our OPD scenario. Nitric oxide. Nitric oxide basically is a gas which is virucidal. It's a pulmonary vasodilator, bronchodilator, anti-inflammatory, anti-thrombotic, but it can cause hemoglobin, cause ARF, and it should be avoided in cardiac failure also. There have been a lot of trials of nitric oxide, particularly by Dr. Berta at Mass General. He has been using inhalation of nitric oxide at 20 to 40 parts per million, that is low dose, and 160 parts per million. And in US, it is being used as a clinical trial for intubated patients, very serious patients. But a company has come out with a spray of nitric oxide releasing solution. So this spray was tried in patients, and it showed a viral load reduction. And in Canada also, as a gargle as well as a nasal spray. And they have already applied for emergency use authorization in Canada and UK under the name of Sanotize, which is coming out a lot on social media as something better than hand sanitizer, a nose and throat sanitizer. This drug is just making waves. It has been researched in India. And again, Dr. Yogesh, one of the chairpersons, is part of that study. 2-deoxy-D-glucose is basically a modified glucose. So it will compete with glucose for uptake and metabolism. Infected cells are metabolically more active. So they will pick up this 2-DG, but it is not glucose. It's a modified glucose molecule. So it cannot be used for glycolysis. So it blocks the generation of energy in the metabolic pathway. And this decreases viral replication. It interferes with glycosylation of viral proteins. Phase 2 study was in 110 patients. It was completed in October, and it showed that patients given this drug, it is given as a powder, and those who received this drug recovered earlier by 2.5 days. A larger trial, which was completed just now in March, 220 patients, showed that there was a freedom from oxygen earlier and early clinical improvement by the third day of administration, and has been given emergency use approval in moderate to severe cases of COVID from 1st of May. This was not a new drug. It's an old molecule used as a radiosensitizer in thyroid cancer for last 3 decades. And one of the side effects is hypoglycemia, which was seen for cancer treatment. Patients become sedated and drowsy, and when you check them, the sugar is found low. But apparently in the COVID trials, there was not much of hypoglycemia. When to start, how much dose is to be given, we need clarity on that as the drug is released. These are some of the references. There are so many drugs under research. So if anyone wants to check out the ongoing studies, this is the reference website, the Pharmaceutical Journal of the Royal Society. All the drugs trials are listed. The best article on cytokine storm is in MEJM 2020. This is the reference. then this Woman has reviewed all the current drugs which are under trial. Anyone who would like to know a lot about the immune system, this is the best book I've ever seen on immunology. And this is an article on JAK inhibition. I would like to thank all my GMC batchmates for giving so many inputs, and all Dr. Pahuja and so many of my API colleagues for giving valuable inputs for this presentation. Thank you.
Thank you, Dr. Bhave sir, for the exhaustive lecture. I request Piyush to present Dr. Bhave sir with
I
the
have a
trophy.
question.
Dr. Yogesh Sharma sir wants to say something. Sir, please go ahead.
Yeah. Dr. Anand, it was a very wonderful lecture by you, right from the basic and covering the whole spectrum of the latest treatment which is available. I think you have enlightened all the audiences with the latest treatment what is going on and likely to be in future. So the future holds good for COVID-19 treatment. My question to you is, as you told about the monoclonal antibodies and the early treatment in the first 2 or 3 days of treatment, the challenging part would be if the person appears to be clinically with COVID symptoms, but his RT-PCR is negative. What should be your challenge of treatment?
It's a costly treatment, and if it's early in the disease, then you will have no way to prove COVID infection, because even the CT scan will not show anything. So it would be difficult to use in such patients.
So Trump was RT-PCR positive before he received.
Yeah, but we know that in spite of taking the treatment, he became hypoxic and required steroids. So it didn't work for him at least.
Right. One last question to you. All the treatment which you have spoken about is for almost, you can say, affording class of people as well as 5-star hospitals. What about for the simple man in mass epidemic of COVID? What do you suggest about the latest treatment?
I think in OPD basis, what I'm looking at is the inhaled steroid, maybe fluoxamine. These are the economical, cheap, easily available in India, and we need to do trials on those. And we would like to know from you actually, Yogesh, because you are doing trials on niclosamide and on nitazoxanide and the others.
Yeah. These two drugs, we are in a process of starting the trial. I think as we have the experience of favipiravir, we might be getting good results with monopiravir as well as injection niclosamide. It is just 2 injections to be given. In vitro studies, it has been shown it is 40 times more powerful than remdesivir and 25 times more powerful than your hydroxychloroquine. If it holds true in this future in vivo studies in a clinical trial, I think it might turn out to be a poor man's remdesivir.
Just one comment actually is that what is the life cycle of any drug? First, there is a lot of hype, and everyone thinks now there is some
Yeah, that's true.
magic drug coming. When you they are disappointed and you think it's no good, and only after some time you come to know what is the exact place for this drug in your therapy.
Yeah, that is true. What happens is we keep on having the recycling of all the drugs in different indications. As you know, the ivermectin, which has been clinically being used in poor man's people in poor countries and all, while other people, they have hardly shown any particular positive effect. But definitely, it has got some vericidal effect. And let's hope for the best with niclosamide, because it's not going to be a very costly affair. As you know, all the drugs are getting recycled for different indications. So you might be getting, as we are using as a anti-parasite drugs, ivermectin and niclosamide, we might be very much surprised with the trial of niclosamide. Hope for the best.
Anand, your experience with baricitinib and tofanitisib?
Yeah, honestly, there will be people in the audience who have used it much more than I have. But so far, it's been very difficult to make out that it has anything to add as compared to remdesivir plus steroid.
I think this baricitinib of latestly has been added into the task force for the
Yes.
treatment. So in next 2 to 3 weeks, we might be getting a better outcome with all the people those who have used it.
Dr. Netaji Mulik is the chairperson who lately joined. And I remember on 15th of February, sir, it was the very first meeting at collector office. And as IMA president, I attended it. And we were given task of forming the track team by none other than the guardian minister. And I still remember the very fantastic presentation by Dr. Netaji Modi. The day you made a very good presentation. And we were not aware and we were just in a joyous mood of celebration and everything. And then suddenly an alert signal was buzzed. And from that day onwards, I never think we have met anybody. We are just meeting virtually. I wish to meet Dr. Anand Bhave, Dr. Sitaraju. Yogesh, I could meet you just because of Global Hospital, and that was the incidence. But
the amount of contribution you have given from the IMA part to the Global Hospital cannot be forgotten.
Yes,
we could run the hospital.
It is easily forgotten by TMC.
No, but as a dean, I still remember.
And I was just unceremoniously removed, or rather, I was out of the scene. Anyway, that is part of the game.
No, but nothing to be forgotten.
Nothing to be forgotten between our relations, because our bonds became strong there. Anyway, we'll move further because two more speakers are waiting, and I am so grateful to the audience who is above in the range of 400, still waiting for the marathon. And I am getting continuous messages from the audience as well as those who are viewing. Fantastic lectures, and the content itself is so powerful. The speakers are so well studied and well versed that the whole thing is going on. It is very difficult to attend a 45-minute lecture in our day-to-day classroom. But since morning 9:45 a.m., this is now about 5:44. So I think long marathon and two more things, and then I will be grateful to you for the patience. So thank you very much, panelists.
Desai sir.
Desai sir. On behalf of the Pathologist Association, I request Dr. Anand Bhave to accept our virtual trophy.
Thank you so much. It's a beautiful trophy.
It's a beautiful trophy. You can see it.
Thank you, sir.
And now I request Dr. Devani Soman.
Desai sir, 1 minute. Desai sir. Desai sir, thank you for inviting me. And it was a nice lecture given by Bhave sir. It is informative and huge information regarding immunity and newer drug and newer therapies. Thank you again, Desai sir.
Thank
Dr. Anand Bhave is our pillar of task force. He was given a task to go ahead. Not पीछे क्या हो रहा है इसका कोई हमको जरूरत नहीं. Anyway, thank you very much, everybody.
Thank you.
And I request Dr. Devani Soman to take over the next proceedings. Dr. Devani Soman, are you there?
Yes, sir. I am there.
Please continue.
Yeah. Good afternoon, everyone. After this wonderful lecture by Dr. Anand Bhave, we will move towards our next topic. It is chest radiograph and HRCT in COVID-19. For this, I will like to invite Dr. Mehul Thakkar, a renowned pulmonologist. Sir is working with Jupiter Hospital, Thane, and has been at the forefront of COVID treatment for critically ill patients. He has also participated as a faculty in multiple training programs for doctors on COVID-19. For this session, I will be inviting three distinguished eminent radiologists and sonologists, Dr. Amol Saman, Dr. Nikhil Kamath, and Dr. Nikhil Joshi. I welcome you all, sir. Proceed to you.
Okay. Good evening, everyone. Thank you for inviting me to speak on the topic. And I have to speak in front of such eminent radiologists. I hope I do a justified job, I feel. Let me share my screen. So I hope my screen is visible.
Yes, visible.
Yes, yeah. Okay.
Yes, sir.
Let me start by saying that chest radiology in COVID has had become the pioneer of diagnosis to when to excess radiation saga, and now somewhere the truth lies somewhere in the middle always. So I'll be speaking on chest radiology in COVID, but I'll be mainly stressing on the pulmonologist view. So I'll just jump to the topic. What about chest x-rays? In radiology, mainly in COVID, we deal with chest x-rays and HRCT chests. So chest x-rays, as we all know, are cheaper. They are available bedside, so that is used for sick patients who are not able to mobilize in ICUs. They obviously have less radiation, and nowadays people are more worried about radiation. You tell them to get a CT done for a thing other than COVID, they're still worried, I will get to 300 rads of radiation and 300 X-ray worth of radiation and whatever they read up in the newspapers. So it definitely gives less radiation. It can be used quickly to check for worsening. In an ICU setting, if a patient worsens, suddenly the hypoxia has happened, X-ray can be very useful to check for pneumothorax or any mediastinal emphysema or any such thing. But the most important problem that we face with chest X-rays, it is poorly sensitive for diagnosing COVID-19. Chest X-ray cannot diagnose COVID-19. What about CT scan? So CT scan is basically a thin slice you take at multiple levels in the from the lung, and then you make a picture out of it. So it can be anywhere between 0.25 to 2 mm, but most of the time it is a 1 mm cut that has been taken. Now I'll put, except for the radiologist, I would want everybody else to tell me, what do you see in this? I mean, I would at least think in your mind, what do you see when you see this? Okay, and keep this image in your mind when you see. And in HRCT, you have to know that the films that you get are not the complete set of films. The radiologist has the complete set of films. So you might get one such film. Don't focus on this thing. The nearer you get, the lesser you're going to see. So see a zoomed out picture, see a complete picture. And us pulmonologists always prefer to see the video nowadays of the CT that has been sent. So we get a video recording of the CT scan that helps us to diagnose COVID or its complications better than just one frame like this which has been sent to us. So now, have you guys made up your mind? What do you see in this? Now this is the same patient. Now the shadows have gone. So this is basically a shadow of air trapping, which looks like a ground glass opacity taken from a journal in 1995. So this is how misleading CT scan can be if you don't correlate everything clinically. So HRCT just in COVID, when you are looking at a CT in COVID, you should see first the duration of complaints that is. The report usually will show the findings that are there. It will show a CORAD score. I'll come to that. And it will also show something called as a differential diagnosis, which I think people have forgotten nowadays. When you see a CT finding of COVID, my radiology colleagues and seniors will agree that it can be a similar or an overlap pattern in an H1N1 or an influenza virus infection, any other viral infection like adenovirus, cytomegalovirus. Sometimes you see patchy consolidations, which can be representative of organizing pneumonia due to some other reason like RA. And also, most important, acute interstitial pneumonitis, which can present like an ARDS pattern. So if you forget these things, then and you still look at COVID, you're going to miss out. There was a study which showed almost 20 to 25% of mixed infections. Like a patient has COVID infection, but also has an H1N1, also has a mycoplasma, also has some other bacterial infection. So these things should not be missed. Just don't look at COVID when you're seeing a CT scan. Just today I saw a reference of a patient who had the CT changes suggestive of COVID, RT-PCR positive, but also came out to be sputum positive because there was a good clinician who could see some cavity in the right upper lobe and got a sputum test done. So you can get overlapping infections also. So please don't miss out on those things. And an screening X-ray is the first thing to be done. Then you jump to the CT scan. And what do you see in a CT report? Usually the CT report will also, most of the good radiologists take history from a patient or from the consulting physician. So they will tell you what is the duration in days. They will mention the CT finding that can be a ground glass opacity, which is every patient also nowadays knows. Consolidation, what is the distribution? Do you see a crazy paving pattern? Do you see a spider web sign, a halo spider web sign, vascular thickenings, effusions? Do you see an enlarged lymph node? Let me point out one clinical bit of information. If you see a crazy paving pattern, this is what at least we pulmonologists have seen. A crazy paving pattern, patients tend to do a little worse as compared to people who don't have a crazy paving pattern. And then you see a CORAD score, you see a severity score, and you see associated any comorbidities. And then you come to a conclusion. That's how a CT report is presented. But as a clinician, you should know these things. Just don't rely on the score. I've seen many clinicians just seeing the score and getting worried, and references are given for that. Just don't look at the score. Look at all these parameters. What are the typical findings of COVID-19 on a CT chest? It's going to be multifocal ground glass opacities. They are peripheral and basal distributed. You will have some rounded opacities. You can see crazy paving patterns. You can see a combination of ground glass and consolidation. You might see a reverse halo sign or a halo sign, which can be a sign of a fungal infection also in a patient who's recovering from COVID. So please be careful about that. Now, what are the atypical findings? If you see a more central finding, if you see a more peribronchovascular finding, if you see more of an apical distribution, if you see huge necrotic lymphadenopathy, they are atypical. And very atypical would be a cavitation, unless it's a secondary infection, a tree in bud appearance, like in today's case I saw, and a nodular pattern or a mass lesion or a pleural thickening. Unilateral pleural effusions are also sometimes seen in COVID, so please don't miss those things. And this is the favorite of everybody, even the common man on the road knows this. What is the CORAD scoring? 1 to 6. 6 is very simple. It's a PCR positive case. So whatever you finding you get, whether it is normal or abnormal, it's a CORAD 6 CT scan. CORAD's 1 to 5, it is increasing order of the likelihood of COVID coming positive in such patients. So this is the CT scan. Again, I would like all of you to have a mental image. I think after this, it will be very easy. What do you see in this? In this patient, the COVID is highly unlikely because the findings are not classical of COVID in this. An exception has to be made for the first few days of mild infection. Here comes the very important point. When do you do a CT scan in a patient of COVID or a suspected COVID? If you do a CT in the first 5 days, you might miss it out. This can be a classical CT of a person who's going to deteriorate at day 7 or day 10 and may land up on a ventilator. So first 5 days can look like this. So if you see a CT like this, don't get happy. Don't use CT scan, first of all, to diagnose a COVID patient. But in diagnosed COVID patients, if you see a CT like this, patient could still be in the early phase if you've done it in the first 5 days of the disease, not of the test, of the disease. And CT image of the patient for first 5 days can be like this. And there are no abnormalities, and this patient was PCR negative. So this is a CORADS 1 score. What about this? So there is a giveaway. Our arrows are pointing towards something. So this is level of suspicion is low. Findings are of typical of bronchiolitis, a tree in bud appearance, thickened bronchus, walls. No typical signs of COVID. And also there are some bronchiectasis seen. So there are no ground glass opacities. This is a CORAD score 2. It's not a normal CT, but not typical of COVID. Here, this could have been COVID. Had the findings have been bilateral, you could have suspected, but you can see a unilateral finding. So this is a 40-year-old woman with fever and cough. CT scan shows a lobar consolidation with tree in bud. So this is CORADS 2, and the COVID-19 is highly unlikely. I can point out that this patient can still have an RT-PCR positive. It is only according to the CT scan, this patient is unlikely to have COVID. Such multiple infections can be present in a patient. The patient can have a lobar pneumonia and a COVID positive infection. Again, as you can see, these are highly unlikely. You see a bronchial wall thickening, tree in bud consolidation. So as per the CT scan, unlikely to be COVID. Again, a CORADS 2 score. So abnormal, but not suggestive of COVID. In CORAD 3 score, you are indeterminate. You see some ground glass opacities, but it can be a bronchopneumonia pattern. It could be septic emboli with some ground glass. Once you see a ground glass, people get scared of COVID. But we've had cases who overlap with something called as a hypersensitive pneumonitis. In fact, in Jupiter itself, we have seen Kamas has reported suspicious of hypersensitive pneumonitis and not COVID. It is an experience of the radiologist, but as clinicians, you should see and look at the history. So this is again a CORAD score. You see ground glass, but this is not typical of COVID. In case 1, you can see 1-day complaint, unifocal ground glass opacity, RT-PCR negative. Case 2, again unifocal ground glass opacities, Case 3, again unifocal, and case 4, again unifocal. So these may be early COVID or may not be COVID. So that is usually labeled as a CORADS 3, but this should be viewed clinically. Again, these are CORADS 3 scoring. Case 5, day 7 of complaints, multifocal consolidation, ground glass opacities, but the PCR was negative. And this is case 6 is very interesting. History of pulmonary hypertension, recent influenza A, started coughing again. But you see this pattern, but this was influenza A positive pneumonia and not a COVID pneumonia, which was the influenza A with secondary infections. Best, you see unilateral or multifocal findings, and you have a history which is typical, but sometimes a CT scan may show these kind of findings. Okay, one sec. CT scan may show these kind of findings, and this can be a CORADS 4 scoring. So case 1 is a day 7 complaints and PCR positive, and case 2 was a patient with ground glass opacities in emphysema. CORADS 5, everybody knows it is highly suspicious of COVID. So these patients, we can see first case is multifocal. Case 2 was day 10 of complaints. Case 3 was day 11 of complaints. So typically in the so-called cytokine storm we call, where we see an extensive involvement of the lungs. Again, these are examples of CORADS 5 scoring, where you see an extensive involvement. You can see they are peripheral, they are mainly ground glass, they can be patchy, and apex is usually spared as compared to the base, but in extensive disease, all the lobes can be involved. So again, we come to the questions. We saw how the CT looks. When will you do a CT? I would do a CT scan if I am suspecting COVID and I have got an RT-PCR negative, or I'm awaiting an RT-PCR and I need a quick decision, only then. And usually I would tend to avoid it in the first 5 days, because my CT can be falsely normal. It can be a false normal or a false negative CT. And when do we repeat it, or if do we repeat it? I would say the indications of repeating a CT chest in a COVID patient are going to be very, very less. Indications for repeating a CT scan in a COVID patient is going to be very, very less, because you don't expect a change of COVID pneumonia to improve in the first 5 or 10 days. The CT findings, as with any radiological findings of an infection, can lag behind a clinical recovery. So a CT chest may remain abnormal for 1 to 6 months. Don't repeat a CT scan just to see the progress, just to see whether the patient can be discharged or cannot be discharged. Repeat a CT scan only if you suspect a new infection, say a fungal pneumonia, or you're suspecting a pneumothorax, or you're suspecting a pulmonary embolism, patient is not getting better. So then you can repeat a CT scan with a pulmonary angio if you're suspecting that. But there are very, very few indications of repeating a CT scan in a diagnosed COVID case who already has a CT chest. So what are the WHO recommendations? Somehow people have forgotten that WHO also has some role to play and has given some recommendations. I'll rush through them. They're very simple. For asymptomatic contacts, WHO does not recommend doing imaging for diagnosis of COVID. We've had many families. My mother is positive, RT-PCR positive, and I'm getting a CT scan to confirm whether I have COVID. No, it is not recommended. For if you have symptoms, like if you're a contact of COVID patient and you have symptoms, you cannot use CT scan as the first tool for diagnosis. You have to use RT-PCR. CT scan can be done if you're suspecting something else, to rule out something else, but not to diagnose COVID in suspect COVID cases. For patients who have been suspected COVID and you want to get a CT done, there are very few indications. RT-PCR test is not available. It's a late night patient has come to you. It is available, but the results are delayed. Or if the RT-PCR is negative and you still suspect a high clinical suspicion is there for COVID-19, only then you can get it done. Please don't do a CT scan to use as a diagnostic tool. For patients not currently admitted, but with mild symptoms, you can use it if you find patient is coughing a lot, or patient is getting hypoxic, or is you see a tachycardia which is unexplained, then probably you can use a CT scan. For patients who are not currently hospitalized but have moderate to severe symptoms, please use it. You can use a CT scan in this case. This will definitely help you to decide whether I can do a ward or an ICU admission. And if patients who are hospitalized, the moderate to severe cases, and you have not have any imaging, then a CT scan can be done to assess the severity of the disease. But WHO does not recommend doing a CT scan as a criteria for discharge. We've seen many people getting CT scan to decide when to discharge the patient. As I said, the radiology may take a very long time to get better. So please don't do a CT scan to decide when to discharge a patient. Now, touching up on a couple of post-COVID changes, you can see these kind of changes. And typically when this kind of CT scan is seen, the CORAD score initially could have been 5 or 6, and suddenly the CORAD score is 10 at discharge, and patients and the relatives and the doctors get panicked. Please understand that these are organizing changes, and organizing changes are going to be more denser shadows. So they might look a little more, or the CORAD score may be, the severity score might be more as compared to what it was initially. So don't base your judgments based on the score alone. Look at the patient, look at what it was right now, look at the clinical condition, the lab parameters, and I would be very surprised to know what was the indication for this. And this is just a scan of a 46-year-old woman suffering from COVID-19, and as you can see, from A to D to E, the changes have improved. And only few areas of localized honeycombing have remained. So the so-called ground glass opacities or so-called fibrotic changes have also improved to a great extent, and a very small amount of damage is left. And you'll see in clinical practice, many patients who were on 5 liters, 10 liters O2 have gone home on that for whatever reasons. Suddenly after 1 or 2 months come with cleaner scans, and we come with, now not requiring O2, even on exertion, they are doing well. They are not hypoxic, the tachycardias have settled, they have gained weight, everything has come back to normal, because these changes, even though can be labeled as fibrosis, when you see on a CT, tend to improve. So I am sure the radiologists are better people to tell you why these things are called fibrosis, but we also feel they are looking like fibrosis. But these tend to improve. So please understand these changes are going to improve. And in a post-COVID scenario, CT scan is done many a times with, if you suspect a mucor infection. Nowadays, we are seeing an epidemic of post-COVID fungal infections. So if you see any of these things, then probably a CT can be done to check for a cavity or check for any halo, reverse halo signs, or maybe a pulmonary embolism if a patient has developed. So these would be the only indications for repeating a CT. I don't know why CT scan were repeated in such patients. Such a patient should not be repeating a CT scan. You should be doing pulmonary function test, 6-minute walk test to diagnose what is going wrong with the patient. So what are my take-home messages? Use imaging judiciously. Don't think that your clinical sense and RT-PCR can be replaced by doing an imaging. It is not a surrogate for RT-PCR or antigen testing. And use chest X-rays. If you want to see in a hospitalized patient, I've seen patients getting 4, 5 CT scans. You have X-rays with you. Use your clinical judgment, your lab parameters, and chest X-rays. Repeat CTGs only if very strong clinical indication. Do not repeat it otherwise. And don't forget, there are differential diagnoses of whatever patches you see, or there can be mixed infections. Don't miss out on those things. Don't miss out on a tuberculosis case. I had recently a case, patient got admitted twice for COVID. RT-PCR positive, but had a big cavity. Unfortunately, sputum positive came when he came to me, but twice got admitted, but never sputum was done, because the CT scoring was done and the score was 12, then the score was 14, and that's it. The end of story. And patient was given steroids and remdesivir and all. Yes, but the patient also had tuberculosis. Don't miss out on those mixed infections. And the so-called fibrosis, I put it in inverted commas, can revert. So don't give a negative prognosis to a patient of COVID. Not all are going to improve. Almost 1/3 may not improve completely, but almost 2/3 will improve. So please keep an open mind for that. Thank you.
Dr. Mehul, you have really summarized it so well. And you have, as a clinician, categorically explained that repeat CT scans again and again, especially for the checking the recovery or the course of the disease, is not essential, which we see being rampantly done by many of the hospitals. Thank you for that perspective. I would like to request Dr. Kamath sir, Dr. Samant sir, and Dr. Nikhil Joshi to ask some questions.
So Mehul, I wanted to ask you two things.
Yes, sir.
How much you decide when to admit the patient, when to start remdesivir on the scorings of the CT scan. And of late, I'm getting a feedback that sometimes the score is very low, but the patient is critical. Like maybe score is 2, 3. Some intensivists were telling me nowadays they rely more on the X-ray chest than on the CT for serially monitoring the patient. So
So this is an excellent question, and this actually summarizes my talk. So it's a two-part question. First thing, I would admit a patient, or decision for admission is mainly going to be clinical. I would never rely on a CT chest. If the CT chest is, say, a 15 score, I've had patients of score of 18 doing well at home, 91, 92 saturation, stable, and I've had scores of 12 who are still on ventilator now. 3 months still, there's a 33-year-old kid on venti 3 months down the line, and he had a score of 12. So that doesn't matter the scoring system, clinically what the patient is doing. So if I see a patient worsening clinically, hypoxia, a fever not going, tachycardia, or any other organ system involvement, that will be the criteria for admission. CT scan is just done to just check, okay, I need to put him in an ICU or in a ward. Now repeating, sir, we don't do. I'll tell you why. Because first of all, a sick patient getting down to a CT scan center and getting the patient up is a big challenge for us. Patient who's on high flow oxygen. So I would do mainly an X-ray. An X-ray actually with the clinical sense, I think a clinician who has seen so many X-rays will be good enough for the clinician to give a fair idea what is happening. I would not do a CT. Only limited patients I've done a repeat CT is only when I've done it with CT pulmonary angio, and we have picked up quite a few pulmonary embolism. So if a patient is worsening, that would be an indication. And the second part where the score is low and the patient is bad. So we all know COVID is a viral infection, infect any part of our body. We've had patients with myocarditis, we've had patients with embolisms, we've had patients with strokes. A patient can be breathless because of multiple reasons, and somehow we tend to ignore those things and focus only on the CT score. So this message should go across that look at other organs. If you see a bradycardia, if you see a patient of saturation of 91 and a heart rate of 60, there is something wrong. 60 should not be a heart rate unless the patient is on beta blocker. I would think about myocarditis. That could actually potentially put the patient in ICU. So there are other factors which can make the patient bad.
Thank you.
Yeah, I would just like to add a couple of things. That one thing, Mehul, a very good lecture, very exhaustive, very comprehensive, and I would agree with you that CT should be used judiciously, because CT definitely helps, because what we have seen is even if the RT-PCR is negative, there were certain changes which you could see on CT, and then you could triage the patients, and after a couple of days the RT-PCR came positive. So that was a good point of CT. But the real tsunami of the patients that we had seen in last few days, that every center was doing more than hundreds, and as you said rightly, that it should be used judiciously, because the families, one was positive and the entire family was coming for CT. That is wrong. So I agree with that. And the second thing is that the clinician should be also that the CT score what we are given. In fact, as you said rightly, and then we have started putting that in our reports, adding as a disclaimer that the CT score is not absolute, because as you said that just on the base of report they were admitting the patients or triaging. That is wrong. You have to see the patient as a whole, and clinically a patient sometimes with a score of 5, 6 can be really bad, and a patient score of 12 or 15 can be really good. So that has to be taken with a pinch of salt, and that is a disclaimer that we have added. But otherwise the lecture was exhaustive and it has covered nearly everything. Thank you. Dr. Kamath sir, you have made a very good point there, because we face as clinicians many times patients themselves go and get their CT scans done. Perhaps they want to escape this so-called stigma of doing the RT-PCR, and like you rightly said, these are the patients who say my CT score is 5 or 6, so that I don't need any hospitalization.
Correct.
In spite of them having multiple comorbidities, and we advise them that it's better that you get admitted. And on the other hand, there are many patients who are absolutely stable, just they have a borderline score, let's say arbitrarily a score of 7, and they insist that I need a bed, and they fight upon that. So that's a very good point you have taken there. And what we really need to do is discourage these patients from self-diagnosis and doing CTs by themselves without advice of a consultant.
Absolutely.
Yeah,
absolutely.
Dr. Mehul, very informative lecture. I will just like to add one thing. This score, what we are talking, is the day, if we can intelligently, patient can tell us what day of fever he had. So, the duration of disease and the score is very important. If suppose day 5 somebody is getting a score of 7, then it is very important to start these patients on admitting these patients and starting them and treating them aggressively.
Yeah, so that's what. So in a what I would say, it is probably our clinician's fault at one end that when we send a requisition for a CT, we should mention what is the day of symptom for the patient.
Day of symptom.
It becomes easy for the radiologist. And I'll tell you what, if I show the same CT to 5 radiologists, maybe the score might differ from 12 to 13 in each thing. But
if score of 20 is there on day 15, I'm not bothered.
No, exactly. So it is the day of symptom. It is our job to write it on paper. What was the day of symptom?
Right.
Correct.
Mehul, this is Dr. Alok.
Yes, sir.
Can I ask a question?
Yes, sir. Sure. Go ahead, sir.
Mehul, some people who have come from outside, no? Jalgaon, Nanded and all, some of those cities have us reporting out of 40. Jupiter, Nikhil is reporting, I mean, most of the reports we see are out of 15 over here. So is there any correlation between a 40 ka score and 15? And the problem comes, wahan se 40 ka score leke aate hain. When we send them to Jupiter, we're getting a score of out of 15. So the two systems...
It's out of 25, not 15.
I'm sorry, yeah.
So I'm not sure, sir, what kind of...
I've seen some of the cities with reporting out of 40.
Yeah. There are some radiologists who are following that. Now, I think this is my just guess. I think Kamath sir is a better person to answer that. Probably it is every society, like in chest, there are multiple societies and they might take out a scoring system
Nikhil,
like this.
Can you shed some light on that?
Probably that is that.
Yeah, I am also not aware of, the shading by, the 40, because what we have been accepted is around 25.
Yeah,
so that is, you give 5 points to each lobes and then measure it. And that too, you have to remember that score is, even with the management of 5% or 25%, it will be score. So score is just a point mark. It's not something which can be really...
I've seen in my own practice patients with scores of 20 and 22, like you guys have said, doing very well. And in spite, after recovering also, the CT score remains 20, 25 and all, at least for another 4-5 days. So CT score is actually, the CT score is actually not a tool in its totality to guide. The problem is the relatives and the politicians who sit on your head. That's a different area. That's a different discussion altogether. But then I've seen a couple of patients with scores not improving. And we all know the CT findings don't change so soon. But patients, yes, they do respond clinically very rapidly if they respond.
Thank you all the chairpersons, panelists, delegates for the sharing of thoughts. I would like to request Piyush to present Dr. Mehul Thakkar.
Before that, I would like to say a few words.
Yes, sir.
Actually, on screen, Dr. Vedhas and myself are convener and co-convener respectively. But behind the curtain and behind the screen, another person was working hard, that is Dr. Mehul Thakkar, Secretary of IMA Mulund. So thank you very much, Dr. Mehul.
Thank you for the opportunity, sir.
For your indirect help.
Yeah, you have really helped us a lot and we appreciate that, Mehul.
Thank you, sir.
And you know it.
So next on the screen is pathologist Dr. Shilpa Jain from
Yeah, before that, Piyush, please present trophy to Dr. Mehul Thakkar. And I request Dr. Desai, sir, to kindly give it as a token of appreciation.
Mehul, sir, he gya.
Sir, I take it very, very graciously, sir. I accept.
You take it by both hands. Thank you.
Thank you, sir.
Dr. Shilpa Jain from Manduk, please do the further proceedings. Dr. Shilpa Jain.
Yeah. Hi, good evening, everyone. It's been a long day today, but a very wonderful day with lots of information from all the fields of medicine, pathology, surgery, gynec, even psychiatry and radiology, everything has been included. So we come towards the end of the session with a very important topic, that is post-COVID syndrome. I called Dr. Rahul Pandey, who is a renowned consulting physician with Jupiter Hospital and Metropole Hospitals, Thane. He has been managing COVID patients and post-COVID complications since the beginning of the pandemic. So he will be enlightening us about post-COVID syndrome. I also invite the chairpersons, Dr. Sushil Induria, Dr. Alok Modi, and Dr. Abhijit Pancholi, who are all MD physicians with leading practice and famous running their own hospitals fighting the battle against COVID in Thane. I hand over to Dr. Rahul Pandey.
Thank you, ma'am.
Welcome.
Thanks a lot. Very good evening to everyone and all the dignitaries who have joined the meeting. And special thanks to Dr. Dinkar Desai, sir, and a very special thanks to Dr. Vedhas Nimkar, who included me as a part of this grand session at the last moment, probably as my birthday gift.
I'm really thankful to you. At the onset, I would like to just thank everyone who have been fighting this pandemic with all their vigor and might. I also would like to thank Dr. Abhijit Pancholi, who had been a great support in taking care of patients at Metropole Hospital. With this, I'd like to start my today's talk. Yush, can you just share the slides? Yush, can you please help me out? Can you share the slides?
Yes, sir. Is this your just shutting off your screen, sir?
Yeah.
Okay, here we go.
Yeah. Can you move further? So since December 2009, coronavirus disease, also called as COVID-19, has caused by severe acute respiratory syndrome coronavirus SARS-CoV. It has rapidly swept the world. Now, this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. As Dr. Harish Shetty has said, that we have just ended a part of it. Yush, can I get a control of my slides? A patient who has been discharged and treated of COVID, probably we think that he has recovered, but the notion that COVID ends with resolution of symptoms and avoidance of mortality has been proven wrong. While most of the patients with COVID-19, they recover and return to normal health, there are some people who can have symptoms which may persist and last for weeks or even months after recovery from the acute illness. People are not infectious to others, but they are not feeling healthy. This persistent state of ill health has been named as post-COVID condition. It has been given various other names like chronic COVID syndrome, late sequelae, post-acute COVID-19, and many more. However, there is no internationally agreed definition of post-COVID condition as of yet. This appears to affect those who had mild symptoms or moderate to severe disease also. As of now, the incidence, natural history, and etiology of these symptoms is currently unknown. Next. Many people have tried to classify it in a various ways. Acute COVID-19, the symptoms last up to 14. Beyond that, it has been named as long COVID. Again, it has subdivided into two parts. Ongoing symptomatic COVID-19, where the signs and symptoms may persist from 4 weeks to 12 weeks, that is 1 to 3 months. And post-COVID-19 syndrome, again, the symptoms which persist beyond 12 weeks. Patients are having symptoms which are not explained by any alternate diagnosis. Now, anybody who has been asymptomatic or had mild to moderate or severe or critical can go into this acute post-COVID syndrome. Many people may develop persistent symptoms. Some may develop organ dysfunctions, and many can go into multiple inflammatory syndrome. There is a likely relationship between the organ dysfunction and persistent symptoms, but still it is not completely understood. As we all know, COVID affects the body by three mechanisms. It causes a direct infection, it causes inflammation, and it causes microthrombi. So whatever is being seen in post-COVID syndrome can be a manifestation of this. The direct effects of viral infection leading to tissue damage, collateral damage brought about by excess inflammation, post-viral autoimmunity, the consequences of thrombotic complications. Next. It can affect multiple organs of the body from head to toe, you name it, and it can be affected. Next. There can be various manifestations of all the symptoms noted. Fatigue is the most common symptom. Dry cough, weakness, malaise, these are the other symptoms. When we look at symptom-wise, the most common symptoms are seen in the respiratory system. The respiratory complaints of dry cough is very common. Patient may be complaining of breathlessness and easy fatigability. Sometimes there may be impaired mental or cognitive functions, physical deconditioning. Some may present with critical illness related myopathy and neuropathy. Many patients have suffered myocarditis. They may end up developing cardiomyopathy. Fatigue is a very prominent symptom seen in such patients. Postural orthostatic tachycardia syndrome may be seen. There may be difficulty in swallowing, problem with the taste as well as the smell. Many may develop rheumatological symptoms of joint stiffness and pain. Psychiatric problems may be seen. Many people develop hypersomnia. Some may develop insomnia. Next. Various non-specific symptoms are also seen. There may be mental clouding called as brain fog, headache, dizziness, palpitation, chest pain, tinnitus, and many more. As we discussed, and Dr. Mehul has already discussed a lot about the pulmonary manifestations, respiratory problems take a major toll of the patients in post-COVID syndrome also. There may be a persistent shortness of breath at rest or with exertion. There will be a persistent low oxygen levels seen in patients who have really had bad lung during the acute phase of infection, and that may lead to abnormal lung function. We may find abnormal chest X-ray and CT scans showing infiltrates or scarring in the post-COVID period also. All the patients who are having lung infection in the acute stage, they don't turn bad. Most of them recover. Almost 90%, 95% of the people develop no to moderate symptoms. It is only 5% who go to severe to critical symptoms. Of that, again, full recovery is seen in 30 to 50% of the patients. Death in hardly 20% of the 5%, that is almost 1 or 2%. And pulmonary fibrosis is seen in 30 to 50%. So very less number of patients are developing pulmonary fibrosis, but then those who develop, they are having a very morbid life. Dr. Mehul has discussed in detail, so I'm just skipping these slides, lung infiltrates. Patients many times develop myocarditis. Tachycardia is a very important symptom, especially patients who are having unexplained tachycardia, retrosternal chest pain, rising in the troponin. We start suspecting of myocarditis. 2D echo done during acute phase may show global hypokinesia or decreased regional wall of motion abnormality. There may be ECG changes. In such patients who have undergone myocarditis, we should always look for cardiomyopathy in the post-COVID period also. The echocardiogram done at 6 weeks after hospital discharge will help us to pick out this complication. Many times cardiac MRI, which has been done 3 months after hospitalization, has shown inflammation of the heart muscles leading to myofibrosis and myocarditis. Postural orthostatic tachycardia syndrome is also a complication which is seen in many of the patients. This usually affects the person. Whenever they get up from the lying down position, heart rate suddenly goes, and usually the heart rate becomes more than 30%. They start feeling lightheadedness, brain fogging or severe fatigue or palpitations. They have inability to tolerate exercise, activity or even standing up, leading to palpitations or rapid heart rate. And this may happen because of the malfunction of autonomic nervous system. Persons also experience persistent anosmia. Smell sense may take time to come. It may come early in some it may take a longer time. There's no fixed period in which it will come. Also, many people develop loss of taste called as ageusia. What is the implication of this? Many people are having loss of appetite because of that. They are not able to eat properly. That leads to weight loss, leads to depression. Sometimes they may not be able to smell smoke or gas leak, and it may lead to certain accidents. This is important because these patients are many times asked to be quarantined, and if they are in a isolated place, nobody in the room, they may end up into certain catastrophic. So it is important to keep a watch on the patients who are in home quarantine and isolated. Joint stiffness is also a prominent complaint in many of the patients. They also complain of chest stiffness because of the costochondritis, and dysphagia may again be an important symptom. Critical illness, myopathy, and neuropathy is also seen in patients, especially in patients who have been in ICU and who have been immobilized for longer duration. This may present as tingling, numbness, or pain of extremities and weakness of the limbs. Physiotherapy has got a prominent role. So patients who are given physiotherapy early in the disease are many times prevented from going into such complications. Certain patients develop physical deconditioning. What it means reduced exercise capacity, which is not explained by their lung impairment. Their lungs may not be that much badly affected, but they are not able to carry out the work which they were able to do earlier. They always feel a sense of weakness, which is maybe associated with reduced muscle mass also. They may have inappropriately rapid heart rate or breathing for level of exercise which they were able to do when the lungs were normal. This probably may be because of the loss of energy and maybe because of the metabolic derangements which happen in the body and catabolic changes because of the viral infection. The activities of daily living like walking, household work may be also affected because of exertional shortness of breath, palpitations, rapid pulse. Even with mild activity, people are not able to carry out their activities of daily living with the ease with which they were doing earlier. Some may complain of tremors, generalized weakness and fatigue, really very incapacitating for them. 63% of the patients in certain studies were found to report fatigue or muscle weakness. And there's unfortunately no medicine which can give them a quick recovery. And this leads to again a lot of depression and anxiety in the patients. Some may find that they are sleepy. They are sleeping too much. Now, fatigue and sleepiness many times may have some other underlying features also, which we should be able to identify and target them accordingly. Some patients may have insomnia. This has got a very catchy name of coronasomnia. There's a marked increase in the disturbed sleep or difficulty in sleeping. This may be because of the lingering symptoms. It may be also because of cough or some breathing difficulty. Some patients develop post-traumatic stress disorders, especially who had been in ICU and had really gone through a lot of cytokine storm. They are really frightened. Some people who have not got COVID infection but had some relatives and have heard stories of COVID are seeing a lot of news on the media. They also get worried whether they will get COVID or not, and that adds up to their insomnia or nightmares. Psychiatric sequelae are also seen, which Dr. Shetty sir has already spoken, so I'm just skipping. Next. So when we see organ-wise, almost every organ is involved by COVID. Let it be pulmonary, cardiovascular, neurological, hematological, endocrine, mental health. And now even skin rashes are seen in many patients. Even after 15 to 20 days of discharge, some patients are coming up with post-viral exanthem, which are seen in the OPD basis. Next. So when a patient who has been discharged and he comes for follow-up, usually we advise this patient to follow for after 7 days if they have been moderate to severely, and after 14 days if they had just mild illness. Patients who come for the follow-up, we always try to look for whether they have developed any symptoms related to inflammation, thrombosis, or any ongoing other complication. So first evaluation for mild patients is usually after the completion of 17 days from the first day of symptoms. We do a detailed study. Certain blood tests like D-dimer and CRP can be done. If they have any comorbid issues, the tests pertaining to them are done. We try to look at the inflammatory markers. If the inflammatory markers are high, how high they are, that is an important parameter to be looked at. If CRP is more than 5 times the upper limit of normal and D-dimer is more than 2 times upper limit, we try to find out whether they are having any ongoing inflammation or any thrombotic phenomenon. If they are less than that, they are raised but less than the CRP is less than 5 times the upper limit of normal and D-dimer is less than 2 times. We just keep a watch without rushing for anything. And counseling is very important because seeing high values and reading so much in the media and people, they really get frightened. And such patients will be kept a close watch. Next. Patients who are having moderate to, go to previous slide please. Patients who are having moderate to severe disease, they are again followed up after 7 to 14 days. And on follow-up, we look at the inflammatory markers. If the inflammatory markers are high, we follow the pathway which we discussed earlier. We try to look at the sugar level. These patients are being given sugar. COVID has unearthed many patients, have diagnosed many patients who had silent or hidden diabetes and brought them forth. If the sugar levels are high, we have to give a tight control of the sugar level. And with the fear of mucormycosis coming nowadays, it is still more important that we do a good and tight sugar control. Lifestyle modification has to be really stressed upon. Psychiatric evaluation should be done. The patients are many times depressed, anxious. We have to allay their anxiety and depression. If the patient had a mild to severe, moderate to severe disease, chest X-ray can be repeated to look for the resolution. If the patients are doing well, symptomatized, they are improving, we just defer any further investigation. But if there's any deterioration in the symptom or onset of any new symptoms, we need to follow them further and rule out any new disease or condition. Sometimes some patients who have been given oral anticoagulants, they end up with bleeding tendencies. We have to just take care of those patients. Certain patients come with episodes of hemoptysis. Like I had a patient who had presented with hemoptysis. We did a repeat CT scan of this patient after stopping oral anticoagulant, and we found that he has developed a new lesion on the CT scan, and it turned out to be a fungal ball. So we have to be really looking at the patient and try to rule out any new complication. Next, please. We have to really manage these patients on a holistic basis. There's no definite medicine which will treat this condition. So we have to be really counseling the patient, taking care of their emotional needs as well as the medical needs. We have in any new symptoms which has arisen out of this period, we have to diagnose and treat it. The underlying comorbid conditions which were there existing before has to be really taken care of. Pulmonary rehabilitation is very important for them to achieve a good quality of life. General physical therapy and rehabilitation for the weakness of the muscles is also quite important. Next. Various modalities can be tried for patients mainly complain of common cough. So we have to see whether it is just related to COVID, the lingering symptoms, or if there's new complication, they have got new infection. Certain cough suppressions can be given if there's no new infection. Honey-based preparations can be given. Codeine preparation or dextromethorphan preparations can be given. Some patients might be having GRD-like symptoms. We can handle that. Fatigue, again, we have to explain them that they cannot come to the level of activity which they were doing before getting infected with COVID. They have to go slow. So they have to prioritize their activities. They cannot jump to do too many things which they were doing earlier. They have to prioritize, they have to go slow, the pace has to be reduced. And gradually they have to increase the level of activity. Many patients complain of chest pain. Again, we have to find out whether it is really significant or not, or it is just part of inflammation which was there. A ECG, baseline ECG can be done. If it is showing any changes, any arrhythmias, we have to go ahead. Many patients present with tachycardia, a beta blocker can help them to take care of the heart rate. Then many times allays the anxiety and gives a good feeling to the patient also. Patients developing depressive features, anxiety, they have to be again counseled, and mental anxiety has to be added. Next, please. Next. 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 Just go to the. Go back. So this is a slide which summarizes. Next. Yes. This is a slide which summarizes everything in one go. So whenever we have a patient, we have to examine the patient, blood test necessary has to be done. And then we have to not only look for the COVID, we have to also look for the comorbid conditions and anything new which has crept up. During the follow-up, what is very important is moral boosting of the patients. They have really had a big fight coming out of this horrid infection. Many times they have lost money, they have lost few people who were infected with them, family members have been infected, and there has been a lot of mental trauma. As a treating physician, we have to really allay their anxiety, fear, boost up their moral, and just see that they take up this challenge of coming out on their own with your support in the best, finest way. Next. Rehabilitation becomes a very important part. So we have to tell them that your symptoms were very mild. You gradually increase your level of activity. We have to tell them it will take at least 2 to 3 months for them to come back to normal. They are not just going to become all right just because their fever has gone, their oxygen level has become normal. They have to be taught breathing exercises, which will again help them to regain pulmonary rehabilitation. Next. 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 Please go to next. This is one important thing which I'd like to discuss. Many patients, when they are admitted, we give them low molecular weight heparin as a prevention for deep vein thrombosis or thrombosis from other parts. Now, when they are being discharged, as we discussed earlier, that COVID patients have a tendency to form microthrombi in the body. So whether we should be giving anticoagulants to all the patients, we have to balance the risk between bleeding as well as thrombosis. There are various factors which lead to thrombotic phenomena. So they need this anticoagulant, but then there will be a risk of bleeding also. There are various scores which are being determined, which we should be using to determine whether these patients should be given anticoagulants or not. Please go ahead. So there are two scores. One is improved VT score and other is modified VT score. Please go to the next slide. Next. 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 Go to next. Next. Go to next. Next. Yeah. Backward. Go to the back slide. So we have two scoring systems. One is modified improved VT risk score and the other is improved bleed risk score. So modified improved VT risk score is the scoring system which we can use, which will guide us whether we have to give anticoagulant to this patient or not. We calculate the parameters and we see the total score. If the risk score is more than 4, the patient fits into a candidate for giving oral anticoagulants on discharge. Again, we have to see for the improved bleed risk score. Now, if the score is less than 7, that means he has got less risk of bleeding, then we can give oral anticoagulants to such patients. Patients who are having modified improved VT risk score of 2 or more, but their D-dimer at the onset has been more than twice the normal. Again, these patients have got a tendency and they should also be a candidate for giving oral anticoagulants. So, in summary, VT prophylaxis is given if the improved VT risk score is more than 4 or more than 2 with D-dimer more than 2 times the upper limit of normal. Plus, improved bleed risk score is less than 7. That is more risk of thrombosis and risk of bleeding. And by using this, we can judiciously use the patients and give them oral anticoagulants to prevent any thrombotic phenomena during this. Steroids, as we all have been discussing, and there has been a fear, patients who are having high CRP can be given steroids for a few days. But if the CRP has come normal, probably it's better to stop steroids. Those who are having diabetic, a diabetic control is very important. So to sum up, next slide. Next. So to sum up, post-COVID syndrome can occur in patients without symptoms during acute stage. Fatigue is the most common symptom. Post-traumatic stress disorder is common, especially after ICU admissions. Regular follow-up is mandatory for patient liable to post-COVID lung fibrosis. Consider extended prophylaxis after discharge in patients who are at low risk for bleeding and high risk for thrombosis. Next. And the post-COVID care should also include the common instruction which give to the patient that drink plenty of fluids, breathing exercise, do meditation, have a nutritious diet, adequate sleep, avoid smoking and alcohol, and they should not miss out their pre-COVID medication. They can get vaccinated after 1 to 1.5 months. As regards resuming their work, they should give time jogging or walking in the first week post-recovery and double the timing from the second week. And lastly, we should remember, next slide. We should always be imbibing upon them the warning signs which can happen at any time, and they should be aware of it. At any time during their stay at home, if they notice high-grade fever, breathlessness or saturation less than 93%, chest pain, dizziness on standing, they should be immediately contacting us rather than self-diagnosing on themselves and treating themselves. And they should be also made aware of the complications of lung fibrosis, its further implication, modalities of treatment, rehabilitation, impact on kidneys, the heart conditions, if they had any myocarditis, cardiomyopathy, adequate follow-up, and how to go about further has to be. And now with the onset of mucormycosis, where very rare cases of mucormycosis are seen, so we have to be really vigilant in seeing our patients that they are not having any symptoms of headache, eye pain, sinus-related pain, and especially if they are diabetic. And if we find such thing, we should be promptly our first step to rule out mucormycosis to prevent mortality and high morbidity. Thank you.
Thank you, Dr. Rahul. Post-COVID syndrome is really relatively new and still evolving concept, but you have so beautifully put it together. Congratulations. So now all the delegates know why we kept one of the best speakers at the last, I would say. And I would request Dr. Sushil Indoria, sir, Dr. Alok Modi, Dr. Abhijit Pancholi, if you could, we would want to add something.
Very nice and informative lecture by Dr. Rahul Pandey. I just want to know from Dr. Rahul that how he, is like monitoring patients for fibrosing alveolitis once they have somebody who had a very bad disease, who had a long stay in ICU. So when you add nintedanib and how do you follow them?
So basically when these patients are discharged, we send them on steroids for a shorter duration of time. I give them an acetylcysteine incentive spirometry. After 15 days, I follow them up. We just do a simple test of 6-minute watt test and single breath counting. Patients who had severe oxygen depletion, I call them after 1 month, or if they are not able to come, then telephonic conversation is being done. Patients who had a very severe disease are still requiring oxygen at the end of 1 month. I repeat their HRCT test. If they are showing fibrosing which is going on, I add up nintedanib. I am not using perfenix right in the first week or second week because when these patients, they are discharged and they are on oxygen, they also tend to be on oral anticoagulants. Some studies have shown that oral anticoagulants and nintedanib are leading to increased bleeding risk. So perfendinon will be a better molecule when the patient is on oral anticoagulants, if you have to start with. And once you have stopped with oral anticoagulants, you can shift him on nintedanib. This is policy what I am following. After a month or 6 weeks later, if patients are showing HRCT changes of fibrosis, I am putting them on nintedanib and pulmonary rehabilitation, chest physiotherapy, that's what. And if I am not able to manage them, I'm just referring them to Dr. Mehul Thakkar because he is a better person to manage it.
Right. And what today, not related to exactly your topic, but obviously we are seeing a lot of mucor. This is a question to like everybody. We are seeing mucor and so many like people are now worried about mucor. We are like biased with all the patients who are being discharged, whether they are getting mucor or not, especially diabetic and fragile patients. we did there somebody who had fever, maybe post discharge after 10 days they are getting fever. We do simple their CT PNS or say MRI PNS, and we find sinusitis, extensive sinusitis. So, and I'm seeing everybody is being biopsied and their biopsies are coming normal. So it has become a routine protocol to do for nasal endoscopic biopsy of this sinuses. Whether it should be generally recommended or we should go by CRP, because what I feel is CRP, if you keep on doing CRP, if somebody is having fever, CRP is like 100 or 70 or 60, and he's having sinusitis, then we can go ahead and do a biopsy, or it should be done for everybody who is showing sinusitis, post-discharge is getting fever, and the CT scan is showing pan-sinusitis. So whether it is indicated, it should be a routine protocol.
Patients who are having pan-sinusitis is having fever, and if he is having symptoms related to headache, there's some discharge. I think it is, and there's a history of diabetes.
No, settle pan-sinusitis. Obviously, discharge, blackish discharge or like nasal stuffiness, those things are there. So obviously, we'll go for endoscopy.
So initially, there will be just infection that will lead to inflammation that will increase to rhinorrhea. And once the mucus is able to establish itself, then the blackish discharge will come. So initial stages, like if we do a scopy, we do a KOH mount, and if we are able to rule it out, I think that will be the best. Because if we wait for that fungus to establish itself, then we all know the morbidity and the mortality which it causes. Many times we lose that golden period. So whenever we are dealing with such a disease, which the mortality and morbidity is very high, I think it is better to overdiagnose. It's better to do a scopy and rule it out that this infection is not there. Then we are also safe. We are also safeguarding his life, and medically also we are protected ourselves. Many times we may miss, even on the mount, if the fungal is, but clinically, if you are having a very high doubt that this patient might be developing mucormycosis, for example, a patient who developed periorbital edema and is having sinus tenderness, it can be bacterial sinusitis also. It can be mucormycosis also. But you know that the patient had COVID, patient has reduced steroids, and probably if he is having diabetes, why to take a chance? You can start empirical amphotericin B. You can monitor his renal function. And if your QH mount is coming negative, you can repeat his scopy again after, say, 48 to 72 hours. If that is also check scope is also negative, you can stop it. But if it shows, then you have already started the treatment presumptively and you have saved the patient.
Actually, it has become very difficult to get procure amphotericin B right now nowadays. So I don't know how much we'll be getting that medicine.
We are not getting, sir. We are not getting, but if we are not getting, I think posaconazole can be tried. Orally posaconazole we are getting. We can try it. Anyways, we are starting presumptive medicine. We don't have that patient is, we have not proven that patient is having mucormycosis. We can start with oral tablet because something is better than nothing. That is what I am feeling. Now, I may not be talking what is the standard protocol, but possibly this is a disease with so much of morbidity. So it is always better that we are little more aggressive in our approach.
Dr. Desai, sir, you would like to add something?
What I can add? So many additions here. Thank you, Dr. Rahul Pandey.
Thank you, sir. Thanks a lot.
It was not a birthday gift, but it was a birthday party from your side.
Thank you, sir.
So we enjoyed.
Thank you, sir. Thank you.
Dr. Shilpa, it was very nice and crisp introduction. Actually, Shilpa was posted in the morning, but she is a great soldier of TPA. And because Dr. Santosh Khernar wanted some exchange, so she gladly, and throughout the day she is sitting like me. And she's still looking absolutely fresh as if she's giving this at 6 o'clock in the morning. Now it is 6:30. So I don't know how many hours. 10 hours? No.
It's been
more than eight and a half hours. Marathon. I cannot forget this in my life. So thank you all.
Thank you, sir.
Dr. Alok is there? Dr.
Sorry,
Alok?
I'm there.
Yeah, you
Yes,
would
sir,
like
I'm
to
there.
add, Dr. Abhijit?
Yes, sir.
Dr. Abhijit is a very young, enthusiastic intensivist. And I'm glad that in the COVID thing, I could have some good friendships with him.
Thank you, sir, for your kind words.
Yeah. I think now it's almost.
Piyush, can you hand over the memento to Dr. Rahul Pandey?
And before I forget, please bring Dr. Dipen. Dr. Dipen, अरे यार मैंने उसको डॉक्टर बना दिया, जैसे मैंने टोपी को भी बना दिया. Dipen Mehta को स्क्रीन पे लाओ, जरा बड़ा स्क्रीन पे लाओ. Yeah. Yes.
Thank you, sir.
Rahul, please accept this from our side.
Thank you, sir. Thanks a lot, sir.
And can I see Dipen? Dipen is the CEO of DigiShield. Mr. Piyush, और तुम भी आ सकते तो आ जाओ.
Piyush, you also please come because he is the man who has been sitting for
man behind the curtain. He has managed throughout the day a name which was taken so frequently. It was Piyush. It was not TPA. It was not Desai. It was not Vedhas.
And for Dipen Mehta Saab from DigiShield team.
Dipen Mehta is a young enthusiastic entrepreneur, and my goodness, he has entertained us so much. And for every single moment, single bit, I can tell you the brochure was prepared for 8 days, and for every second there was some addition, this, that, some new people are coming, last moment some more additions, and he managed it very coolly, calmly, and he gave very, very strong support to us that we were never afraid to call him in midnight at even morning hours. And Piyush, he was awake with me till 2:30. And right from the morning, he was there. And till this time, he is very looking fresh. कहाँ से energy लाते हो भाई?
I like doing this. I like talking to such enigmatic doctors from all over, learning new things.
So you yourself are so energetic. We all learn from you. So obviously, look at you yourself, sir. Dinkar Desai, sir. You're so energetic yourself.
Yes,
you're inspiring us.
He's getting power from the doctors.
These kinds of
days virtual
make
steroids from the doctor.
These kind of days make me young by mind, body, physique, because I run very fast. And till the success is there, I do not stop the chase. I am a chess player, but it is CH8SE, chess. So Dr. Kamal is there, Dr. Sanjay is there, Dr. Meenal is there, Alok is there, Anupama Verma is there, Dr. Milind Ubade is seen on the screen. So thank you all panelists, thank you all persons behind the screen, off the screen, on the screen.
Thank you.
Dr. Vedhas Nimkar, I must not forget. He was the sole person who made this grand success. It was my brainchild that this conclave should take place. It was accident that Mehul Thakkar, myself and Dr. Vedhas were invited for such type of meeting by none other than Rajeshri Gadgil. And after this meeting, we thought कि चलो हम एक बड़ा प्रोग्राम बनाते हैं. तो बड़ा कितना बनाने का इसका कैनवास तो तैयार नहीं था, लेकिन जैसे जैसे रंग उतरते गए, रंग भरते गए, ये कारवा बनता गया. Thank you very much, and I think Vedhas would like to add.
Sir, if everybody can turn on their videos, we can take a group picture.
Before concluding, I'd like to say a few words.
Everybody can take the. Please be on the screen. We have to take a picture. Those who are here.
Yes, sir. Just.
I think Dr. Sanjay
can I say a few words about you?
Please, yeah.
Vedhas worked for me for 2 days yesterday for my birthday, and today is on the screen again for 12 hours. So Vedhas and Dinkar have created a bomb in this segment. I got a call from the officer. You know who? That what is happening. Right? Everything is going good.
Dr. Ramchandani is the inspiration for us. At the age of 75, if he can work, why not we? That is our motto.
Right.
Thank you, Dr. Ramu. And once again on this platform, congratulations for completing 75 and many more for the returns of the day. Yeah.
I think Dr. Sanjay sir want to talk something.
Yes.
Mr. Mehta, you please share us with us about DigiShield, will you?
How many?
Let him see. Madam? Yeah. We are not able to hear Dr. Vedhas, sir.
Dipen, can you hear me now?
Yes.
Yeah, Dipen, I was saying that if could you please share with all of us about DigiShield in brief?
Okay. So basically, sir, we are a EHR platform in which doctors can do video consultation. Doctors can maintain their medical records. Doctor can book online appointments for their patient. And in current COVID situation, we have integrated a WhatsApp chat with the DGC lab. So nowadays, doctors are doing video consultation through WhatsApp with the patient. So instead of having a doctor conversation with the patient, we have created artificial intelligence and virtual assistant, which will ask all the questions to the patient. Patient has to just need to say hi on the helpline number, and accordingly all vital question will be asked by our artificial intelligence. And after all the question, patient will receive the link for the online payment and online digital consent. And after that, doctor can do a video consultation through the DGC lab. So doctor will receive the online payment as well as digital consent of the patient before doing the video consultation. It's very user friendly. No need to type or no need to have a laptop or computer, and even patient doesn't require any application. Patient just need to WhatsApp number and say hi on the WhatsApp number. So doctor just need to write the prescription the way they are writing on the prescription pad, their traditional way. Click the photo and upload in the application. Patient will receive the prescription link in the WhatsApp itself. So it's very simple and easy to use. If I will share the link to download the application, and even you can get back to us if you have any queries or you want to know like how it will be effective for the doctors and how it is user friendly.
Thank you, Mr. Mehta, for sharing it with us. And it's well past 9 hours and we are still going strong. As I can see, there are still around 300 people listening to us on Zoom. That's phenomenal and wonderful. I must thank Dr. Dinkar Desai, sir, whose brainchild his whole conclave was, and he has been the guiding light, like I said before also today. He has really handheld us, told us, and given us the brightest ideas, and we have worked upon it and today made this conclave a big success today. I would like to thank every single of our eminent panelists, in spite of their hectic schedules and their prior commitments. They have, if I'm not wrong, I may say they have bent backwards to accommodate our request and been here with us, including the state task force members and even dignitaries like ICMR ex-head. I must thank all the delegates. We have had 600 plus delegates, unique delegates, and Mr. Mehta will update us with the final number, and many more thousands of delegates attending us on live platforms, that's YouTube and Facebook Live. I must thank you all as a co-convener. Because of you and because of the feedback that you share with us, it inspires us to conduct such programs. And I request you all to kindly put your comments into your respective WhatsApp groups and also share your feedbacks and any suggestions that you may have. I'm sure many of you might have some more questions. And I can assure you that we may arrange more of such programs with your inputs in future. And I would also like to thank Mr. Dipen Mehta from DigiShield for his unrestricted educational support, and also Mr. Piyush for being patiently there for all of us since morning. Over to you, Desai sir.
Initially, we had Firebrand, Anupama, then Supriya, then Vanita joined the bandwagon, then Shilpa joined, then Shilpa Jain, I mean to say. Zannebi, of course, joined late, but now she is the pivotal part of APPI. And I am surprised and pleased to note that to this list, there is one more Shilpa. Shilpa Deshpande is the second one, and she is the third Shilpa, Shilpa Totla from Aurangabad. She has done a wonderful job of inviting. For long hours, she was behind the most wanted person, that is the Rajesh Toble sir, and she has made it successful. So I am grateful to all of you. Dr. Shilpa Totla is a new addition to the TPA fold. She is Vice President of TPA. She has learned this sentence from me right now at this moment, I suppose. And also surprised yesterday was Dr. Jyoti Chidgupkar. She too is honored the post of Vice President. She happens to be from Solapur, and she has taken huge efforts for getting our CME accreditation. What happened is we applied on 2nd of this month, good in advance, but unfortunately on 4th of May, our tenure of 5 years was over. So we were required to renew the association accreditation, and for that some paperwork was required to be sent, then it was to be accepted, then we have to make payment, and in that course the time was lapsed. There were 3-4 holidays in between, and somehow we could not make the point on legal course. That is 10 days in advance we have to make the application. So accreditation is still pending, but we are still hoping that all the MFC members, Subhash Pingre sir is the member, Dr. Jyoti was behind, Dr. Ashok Tambe sir, Anil Pasnekar, Lele sir, and so many other kind persons. They are interested that this kind of academic activity, which is sincerely executed, should be awarded with credit points. But it's up to the president if he thinks fit, and he gives retrospective effect, which is very rare, I suppose. We shall be very much grateful to MMC. But nevertheless, forget about the points. We can give more points, and because we will arrange so many programs. What is so great thing about these 2 points? We will have many more CMEs and many more academic sessions like this. So with this differing note, I thank you everybody, and I request Dr. Deepen Mehta and Piyush to wind up.
Thanks a lot, Desai sir, for trusting us and giving opportunity to connect with you and manage.
One more word I have forgotten, that I see Artho TV. He is Bijlani. He is Mr. Bijlani. He has joined and he has got 14,000 of his members who are live on his channel. So our things are broadcasted to him also.
Wow, that's great.
Rajashri Gadge, who is having 4,500 her members, she also wanted to get these things live, but unfortunately the possibility of only one link was there. So Deepen said only one is there, and Artho came the first, so we gave them. So thank you, Dr. Bijlani. Dr. Bijlani is an orthopedic surgeon in Ghatkopar, and he has developed this for orthopedic people, and now he is using for the whole of Maharashtra, and he has got 14,000 doctors who lively watch this today's program. So great evening, right from great morning. Anupama, you have to say something. You are smiling. Before you say something, it cannot be over. Supriya is there. Yeah. You can add.
Anupama and me have to say hello to each other again.
Yeah. Hi Supriya.
अनुपमा कभी भी मीटिंग छोड़ती नहीं, वो लास्ट मोमेंट में सबसे पहले आके बैठती है उसको।
हाँ, क्योंकि
उसका दिल नहीं भरता।
हाँ, दिल नहीं भरता। अभी ना जाओ छोड़ कर के दिल अभी भरा नहीं. It's not about points, sir. It's about the enthusiasm which people are sitting till now, pura din. People were going, coming, taking lunch, taking tea, and again joining. This is the point which they got and which we got from them. 100 points to TPA, 100 points to the delegates, 100 points to the Deepen Mehta, and 100 points to Piyush Kale. Isko बार-बार बोलते change करो. So thanks to all of you. Thanks to Dinkar sir. We look forward to many more conferences and to see the beautiful faces of pathologists. Thank you all. Thank you all. सबसे पहले मैं बोलूँगी देसाई सर, ये आपका ब्रेन चाइल्ड था और बहुत ज़्यादा मजा आया. I enjoyed a lot. We all enjoyed a lot. Thank you very much.
And I think for pathologists it was very, very good thing because we all got well oriented clinically also today. So those who have missed it have really missed it.
And most important, the golden line was of day was, and Dr. Shetty told, अच्छा कोई pathology association भी है. That was highlight. So we pathologists, we shined in front of clinicians, we shined in front of psychologists, psychiatrists. ये बहुत बड़ी बात है. And when my clinician friends
and politicians also, ma'am,
politicians also. So now you have shown the strength of pathologists. Basically, we are studying pathogenesis and we are diagnosing it, and we should get our credit.
Now we are pathogenic and virulent.
Yes.
After today, definitely.
Yeah, previously we were malignant. Now we have become pathologic. Virulent.
We were malignant?
Yes, we were.
We were benign.
Ma'am, we were occult. We were occult.
Benign.
We were not considered a doctor.
We have to become malignant.
So,
occult. We should say occult.
Yeah.
So because of Desai sir, we pathologists are feeling very honored in front of clinicians. And thanks you, sir, you are always there. And मुझे बहुत अच्छा लगा in front of clinician. And my clinician friends from Ulhasnagar, Badlapur, Kalyan called me. अरे pathologist के अलावा बाकी subjects भी है क्या? When I told them about the topics, about Dr. Rishma Pai, about Dr. Shashank Joshi, about Dr. Zarir Udwadia, they were surprised. And you have taken our pathology association to another level. So thanks for this.
Yes.
Thanks for this, sir.
Thank you, sir. Thank you.
A big
लोग हमको बुलाते नहीं है, चलो हम तुमको बुलाते हैं.
Yes, yes.
आ जाओ खाना खाने.
तो एक तालियां तो बनती है, sir.
हाँ, बनती है.
And the most patients, one comment for Dr. Vedhas, very patient doctor. I don't know the water energy level you have since morning. You are conducting the thing. Amazing energy level.
His energy level for last 15 days. My wife has changed the bedroom because he is active after 11 o'clock, and his phone, he never keeps the phone up before 1 hour minimum.
He is so calm and quiet and smiling throughout. His energy level has not dropped. So, आपका oxygen level मानना पड़ेगा, sir.
Thank you, ma'am, for the kind words. Dr. Pingulkar, you wanted to say something? Dr. Sanjay Pingulkar.
I hate to break it between, but we have to end this right now because we have another webinar coming up in.
One small thing.
Oh,
one
yes.
small thing.
Yes,
Dinkar,
sure.
sir,
Can we get?
आप बंद करो नहीं तो ये रुकने वाला नहीं है. ये रात
Actually, I had to interrupt.
Sir, can we get a link of the recording or something?
अरे YouTube में है, YouTube में मिलेगा ना.
Dinkar, sir.
Yes.
Dinkar, sir, I want
This
to.
recording will
आप
be,
YouTube हमको share करो.
yes, we'll share the link. This will be saved in the YouTube channel. So even you can share that to your colleagues and friends that if they have missed the session or they want to see any particular session or miss any of the lectures.
Yes.
I just want 2 minutes.
आप
I
मेरे को भेज
just want
सकते हैं
2
ना?
minutes, sir.
And we are already way past.
Piyush,
Sanjay
just 2
wants to
minutes.
say something. Dr. Sanjay
Something
wants to say
very
something.
important. I have taken an appointment of Rajeshji Tope at 8 o'clock somewhere in the evening. If anything on behalf of pathologists has to be pushed there, please tell me. I've got that appointment.
Great.
So tell me if you have to tell something.
About task force, some pathology should be there.
Yes,
Our representative. Second
Yes.
point, antigen testing should be done by non-NABL lab. These two I remember from the today's session. Dr. Desai sir, you want to update?
Yes.
And,
I have briefed her what is to be taught. She knows.
Yeah, he told me.
Okay.
Jagdish sir wants to say something.